Heart is the first functional organ in vertebrate embryos, and it beats spontaneously by week 4 of development. First functional organ in week 4 of development. Cardiac looping. The primary heart tube loops to establish left-right polarity. It begins in week 4 of development. So cardiac looping starts as soon as the heart starts beating. And defect in left-right dynein can lead to dextrocardia as seen in Carter-Jenner syndrome. So there would be defect in the left-right dynein. So for that reason the heart will not be able to position itself in the left side. So there will be dextrocardia. So that is heart in the right side of the chest. Now septation of the chambers, atria, and then we'll see ventricles. So first atria. The septum primum grows towards endocardial cushions, narrowing the ostium primum. So this is septum primum right here. It grows towards the endocardial cushion. This is endocardial cushion, which will later form the valves and the atrial septum and the ventricular septum itself. The septum primum grows towards endocardial cushion and it narrows the ostium primum. This is the first step. In second step, the ostium secundum forms in septum primum due to cell death. So the ostium primum regresses. So here is the ostium. Here's the ostium secundum, which forms due to cell death in septum primum. Septum primum, ostium primum, and now ostium secundum has formed. The septum secundum develops on the right side of the septum primum as ostium secundum maintains right to left shunt. Septum secundum develops on the right side. So here is the developing septum secundum and develops on the right side of the septum primum as ostium secundum maintains right to left shunt. So this point is important, that ostium secundum maintains right to left shunt. Now septum secundum expands and covers most of the ostium secundum, and the residual foramen is called the foramen ovale. So septum secundum is expanding and there is just this foramen ovale which can be patent in some cases. Otherwise the foramen ovale gets closed. The remaining portion of the septum primum forms one-way valve of the foramen ovale. Now this point again is very important, that the septum primum is the one which forms the one-way valve of the foramen ovale. Don't get confused with septum secundum. Remember that it is septum primum that forms the one-way valve, and it's the ostium secundum that maintains right to left shunt. And the sixth point is not given here, and the septum primum closes against septum secundum, sealing the foramen ovale soon after birth because of the left atrial pressure, high left atrial pressure and less right atrial pressure. And the septum secundum and septum primum fuse during infancy or early childhood, forming the atrial septum. So both the septum fuses with each other and forms the atrial septum. Now we'll see patent foramen ovale. It is caused by failure of septum primum and septum secundum to fuse after birth. So most are left untreated. Can lead to paradoxical emboli. Paradoxical emboli is this venous thromboemboli entering the systemic arterial circulation to the right to left shunt, as can occur in atrial septal defect as well. So what happens is, when the septum primum and septum secundum does not fuse with each other after birth, which they are supposed to be, it forms a patent foramen ovale, which can lead to paradoxical emboli. So the paradoxical emboli arises from the venous thromboemboli, that is the right side of the heart, and then it travels to systemic arterial circulation, that is left-sided heart, through the right to left shunt, and it can also occur with atrial septal defect as well. Now ventricles. Ventricles the muscular interventricular septum forms, and the opening is called the interventricular foramen. Now, the aorticopulmonary septum rotates and fuses with muscular ventricular septum to form the membranous interventricular septum, closing the interventricular foramen. So, what happens is this is aorticopulmonary septum. It rotates and then it fuses with the muscular interventricular septum, and now it forms membranous interventricular septum. The growth of endocardial cushion separates atria from ventricles and contributes to both atrial septation and membranous portion of the interventricular septum. So here's the endocardial cushion, which will form two things. First, it will septate both the atria, and second, it will fuse with membranous interventricular septum to form the membranous portion of interventricular septum. It will fuse with muscular interventricular septum to form membranous interventricular septum. And ventricular septum defect, most common congenital cardiac anomaly, usually occurs in the membranous septum. So VSD is the most common one. Now, outflow tract formation. Neural crest migrations, truncal and bulbar ridges that spiral and fuse to form aorticopulmonary septum. It forms ascending aorta and pulmonary trunk. So the neural crest cells migrates and it forms aorticopulmonary septum. So what happens is with the formation of aorticopulmonary septum, now we have two vessels. First is ascending aorta and the second one is pulmonary trunk. And how it is formed? The truncal and bulbar ridges that spiral and fuse. So it is due to the fusion of truncal and bulbar ridges that we have two vessels, ascending aorta and pulmonary trunk. Now, what if the neural crest cells migrations does not happen, or the aorticopulmonary septum does not get formed? Then we will have just a single vessel, which is combination of ascending aorta and pulmonary trunk. We would not have two separate vessels. The conotruncal abnormalities associated with failure of neural crest cells to migrate. The first is transposition of great arteries, tetralogy of Fallot, and persistent truncus arteriosus. So I was talking about this one, the persistent truncus arteriosus. So there is a single vessel leaving both the ventricles. You can remember all these by 3 T's: transposition, tetralogy, and truncus arteriosus. Now, valve development. So first is aorticopulmonary valve, aortic valve and pulmonary valve, and second is mitral valve and tricuspid valve. First, we will see mitral and tricuspid valve. It is derived from the fused endocardial cushions of the AV canal. I told you here that these are the endocardial cushions. I told you somewhere here that there is endocardial cushions which will separate the atria. It will form the atrial septum. It will form the membrane muscular part of interventricular septum as well. So it is derived from the fused endocardial cushions of the atrioventricular canal, AV canal, because mitral and tricuspid valve are between the atria and ventricles, so you can remember it by the endocardial cushions of the AV canal. And then there is aorticopulmonary valve, aortic valve and pulmonary valve, which is derived from the endocardial cushions of the outflow tract. Aortic valve and pulmonary valve give rises to the vessels which form the outflow of the heart, right? The aorta and the pulmonary artery. So they both are the outflow tracts. So aortic valve and pulmonary valve are derived from endocardial cushions of outflow tract. Mitral and tricuspid from AV canal. Valvular anomalies may be stenotic, regurgitant, atretic, like tricuspid atresia, or displaced, like Epstein anomaly, in which tricuspid valve is displaced downwards. Aortic arch derivatives developed into arterial system. So this is pretty easy. Like the first is always maximal. First arch is maximal, so it is maxillary artery, which is a branch of external carotid. Second, second has S. Stapedial has S, so stapedial artery. Third, 3C. C is the third letter of the alphabet, so common carotid artery. And proximal part of internal carotid artery. So here's the common carotid artery and proximal part of internal carotid artery. This is the proximal part of internal carotid artery. Same on both the sides. Fourth, on left aortic arch, on right proximal part of right subclavian artery. So fourth arch, 4 limbs, systemic. So you can remember it by fourth arch we have 4 limbs. So the fourth arch will supply the vessels which supply the 4 limbs, like the systemic arteries. So on left it supplies the aortic arch. So this is aortic arch, and on right the proximal part of right subclavian artery. And sixth, the proximal part of pulmonary arteries, and on left only ductus arteriosus. So this is ductus arteriosus, and this is the proximal part of pulmonary arteries. Sixth arch is pulmonary and the pulmonary to systemic shunt. Yeah, so sixth arch gives rise to pulmonary artery, and pulmonary to systemic shunt. So this is ductus arteriosus, which forms pulmonary to systemic shunt in utero. Now, the right recurrent laryngeal nerve loops around the product of fourth arch. So the right recurrent laryngeal nerves loops around this arch, and left RLN loops around the product of sixth arch. So we would write here, this is right RLN and this is left RLN. We just have to mug up this section. So like as we talked about this earlier, the truncus arteriosus is a single vessel and it gives rise to 2 separate vessels, which is ascending aorta and pulmonary trunk. Now the difficult part to remember is this, like each chamber of the heart has a smooth part and a trabeculated part. So the trabeculated part of both the of all 4 chambers are formed by primitive. So the trabeculated part of left and right ventricle is formed by the primitive ventricle, and the trabeculated part of left and right atria are formed by primitive atrium. So now we'll talk about the smooth parts of both of them. So left and right atria, the smooth parts of left and right ventricle is formed by bulbus cordis, and the smooth part of right atrium is formed by the right horn of sinus venosus, and the smooth part of left atrium, where did it go? Yeah, smooth part of left atrium is formed by primitive pulmonary vein, because pulmonary vein enters the left atrium, so you can remember it by, it is formed by the primitive pulmonary vein, which gives rise to the smooth part of left atrium. Now we'll see the remaining ones. So right horn of sinus venosus gives rise to smooth part of right atrium. So what does the left horn of sinus venosus gives rise to? It gives rise to the coronary sinus, and there's endocardial cushion. It gives rise to atrial septum, membranous interventricular septum, AV, and semilunar valves, all of them, pretty much everything. Now the right common cardinal vein and right anterior cardinal vein, right common cardinal vein and right anterior cardinal vein, it gives rise to the superior vena cava. right anterior cardinal vein. So maybe this part is anterior, so it gives rise to the superior vena cava, and this subcardinal part, and the posterior cardinal, it gives rise to the inferior vena cava because it may be the posterior side also. You just have to mug up this part. Now we'll see the fetal circulation. First, we'll see the route of the blood. We'll see the blood circulation, how it enters the fetus, from where does it enter the fetus. So the fetal blood enters from umbilical vein, right? Not from umbilical artery, but umbilical vein, because it is coming from the mother. So it's a vein, and it has high O2. Now the umbilical vein here, it mixes with inferior vena cava, which has very low O2, and the umbilical vein mixes with IVC through ductus venosus. And yeah, so the umbilical vein mixes with inferior vena cava through ductus venosus, and it enters the right atrium. So most of the blood from right atria enters right ventricle, but some of it goes through foramen oval into the left atrium, from left atrium to left ventricle, and left ventricle to aorta. But there's also blood coming in from superior vena cava, which has very low O2, like IVC. There's also blood coming from SVC, superior vena cava, into the right atrium, which has very low O2. So the blood gets mixed up in right atrium, and the blood with very low O2 enters the right atrium, right ventricle, and then into the pulmonary arteries. So what happens is pulmonary arteries have blood with very low O2, and the aorta has blood with moderate O2 saturation. But there is another shunt called ductus arteriosus. First we saw ductus venosus, because the umbilical vein gets mixed with inferior vena cava. They are both veins, so this is ductus venosus, and here it is pulmonary artery and the aorta. Both are arteries, so this is ductus arteriosus. So what happens is, this is like right to left shunt in utero. So blood from this pulmonary artery gets mixed with the blood in aorta, and it forms blood with very low O2. And this is continued as aorta. So unlike in infants, the aorta has blood with very low O2, and through aorta it goes to internal iliac artery, then to umbilical arteries. Now this is umbilical artery, because it has blood from the fetus's heart to the placenta. It is carrying the blood from the heart to the placenta, so it is umbilical artery. It goes to the placenta. Now let's see the theory part of it. Blood in umbilical vein has a PO2 of 30 mmHg, and it is 80% saturated with O2. This is important. So it has high O2. 80% saturation is high O2. Umbilical arteries have low O2 saturation. Yes. Now the three important shunts are: blood entering fetus through the umbilical vein is conducted via the ductus venosus into the IVC, bypassing hepatic circulation. It bypasses this part. This bypasses the portal veins. Most of the highly oxygenated blood reaching the heart via the IVC is directed through the foramen oval into the left atrium. See, So the most of the highly oxygenated blood that enters the right atrium is shunted through foramen oval into the left atrium. And the deoxygenated blood from the SVC passes through the right atrium, right ventricle, main pulmonary artery, ductus arteriosus, and into the descending aorta. The shunt is due to high fetal pulmonary artery resistance. Why is there high fetal pulmonary artery resistance? It is because of there's amniotic fluids in lungs. So air does not offer that much of resistance, but when there is amniotic fluid in utero, it definitely provides more resistance than the air. So yeah, so we can draw lungs here. So it has amniotic fluid in here, so there is more resistance to it in pulmonary artery. So what it does is it has a route through which the blood can bypass. That route is ductus arteriosus. It prefers to bypass, so it prefers not going into the lungs, and it will prefer going into the aorta. That will form the shunt that is called the ductus arteriosus. And there's this mnemonic too, that through foramen oval highly oxygenated blood gets transferred, and through ductus arteriosus deoxygenated blood gets transferred if it helps. And at birth, infant takes a breath, so there is decreased resistance in pulmonary vasculature, increased left atrial pressure versus right atrial pressure. Foramen oval closes, now called fossa ovalis. There is increased in O2 from respiration and decrease in prostaglandins from placental separation. There is closure of ductus arteriosus. Yeah, so what we talked about, the amniotic fluid being in the lungs. So after birth, the infant takes the breath, so air replaces the amniotic fluid, and now there is air in the lungs, so it does not offer that much of resistance. So now blood can go from pulmonary artery into the lungs. From pulmonary artery into the lungs. And so now there is not much blood going through this shunt. The ductus arteriosus gets closed. And also after birth, there is increased left atrial pressure. Because earlier there was pressure due to amniotic fluid in lungs, which was being diverted into the right ventricle, into the right atria as well. So there was basically more pressure in the right side of the heart before birth. But now after birth, there is air in the lungs, so there is not much resistance. So the pressure in the right side of the heart has decreased in comparison to the left side of the heart. So there is more pressure in the left atria than right atria. So the foramen oval gets closed, and there is increase in O2 because the child starts its respiration, and there is also decrease in prostaglandins because the placenta is separated from the fetus, which will also close the ductus arteriosus. NSAIDs like endomethacin, ibuprofen, or acetaminophen help close the patent ductus arteriosus, which will then form ligamentum arteriosum. It is remnant of ductus arteriosus. It's a ligamentum arteriosum. It is the remnant of ductus arteriosus. Endomethacin ends the PDA, and prostaglandin E1 and E2 keep the PDA open. So in some cases, we do need to keep the PDA open in order to shunt the blood from right to left side in order to keep the child alive. So in those cases, we'll see those cases later on. So in those cases, we need to keep the PDA open. So by giving prostaglandins E1 and E2, we can keep the PDA open. Right, and And one more thing, the foramen oval closes because the septum primum and septum secundum fuses, as we saw earlier. So these are fetal postnatal derivatives. Like we saw, the ductus arteriosus gives rise to the ligamentum arteriosum. Ductus venosus gives rise to ligamentum venosum, which is on the liver, and the foramen oval gives rise to fossa ovalis. Allantois gives rise to urachus, and its postnatal derivative is median umbilical ligament, LAN, and median, it also has an AN. And urachus is a part of allantois between the bladder and the umbilicus, and if this urachus is patent, then we will have bladder leakage which comes out from umbilicus. So we have urine leakage from the umbilicus, and umbilical arteries gives rise to medial umbilical ligament, and umbilical vein gives rise to ligamentum teres hepatis, which is the round ligament, and it is contained in falciform ligament. Okay, so umbilical, medial, allantois, median, because the urachus is just behind the umbilicus, it is in the middlemost part, it is in the median position, so it gives rise to the median umbilical ligament. Umbilical arteries travel like these, which is medial, relatively medial, so it gives rise to the medial umbilical ligaments. Whatever helps you to remember all of these. Now we go to the anatomy. So left atrium is the most posterior part of the heart. Left atrium is the most posterior part of the heart, and the enlargement, and because of that, if the LA is enlarged, like in mitral stenosis, it can lead to compression of the esophagus, which causes dysphagia, or left recurrent laryngeal nerve compression, which can cause hoarseness, which is called Ortner syndrome. The right ventricle is the most anterior part of the heart and most commonly injured in trauma because it is the most anterior part, and LV is about 2/3 and RV is about 1/3 of the inferior cardiac surface. So LA forms the posterior part, RV forms the anterior part, and LV forms the inferior part. Okay. This will help you remember in the myocardial infarction section, like which wall gets infarcted. Pericardium. It consists of 3 layers from outer to inner. It is fibrous pericardium, parietal pericardium, and visceral pericardium. And the visceral pericardium is called epicardium. Yeah. So this is fibrous pericardium, this is parietal pericardium, and visceral pericardium. So when there are parietal and visceral layers, there is always space between parietal and visceral layers. So here that space is called pericardial space. This pericardial space lies between parietal and epicardium, which is visceral. Pericardium is innervated by phrenic nerve. Pericarditis can cause referred pain to the neck, arms, and one or both shoulders, often left shoulders. So here this pericardial, the pericardium is innervated by phrenic nerve. So when there is pericarditis, inflammation of this pericardium, it will, because it is innervated by phrenic nerve, it will cause referred pain to the neck, to the arms, or the left shoulder. And this pain to the neck is caused because there is involvement of muscle trapezius in pericarditis. trapezius is also innervated by the phrenic nerve. Now coronary blood supply. Left anterior descending artery, the artery Widowmaker's artery. Its branches supply anterior 2/3 of the interventricular septum, anterolateral papillary muscle, and anterior surface of the left ventricle. So mostly it supplies all of the anterior part of the heart: anterior interventricular septum, anterolateral papillary muscles, and anterior surface of LV, and it is most commonly occluded. Now PDA, the posterior descending artery. It supplies posterior 1/3 of the interventricular septum, posterior 2/3 wall of ventricles, and posteromedial papillary muscle. PDA supplies most of the posterior part. IV septum posterior part, posterior 2/3 of walls of the ventricle, and posteromedial papillary muscle. And RCA supplies AV node, SA node. Infarct may cause nodal dysfunction, bradycardia, or heart block. Okay, so RCA supplies SA and AV nodes. And the right marginal artery supplies right ventricle. Okay, so this is heart, this is RV, LV, RA, LA. So the anterior part, and this is anterior 2/3 of the interventricular septum. This is anterior wall of the left ventricle. It is supplied by LADA. And the posterior 1/3 of the interventricular septum and posterior part of left ventricle, it is supplied by RCA. And the lateral wall, this is the lateral wall, it is supplied by lateral circumflex artery. Yeah. So now if the circulation is right dominant circulation, the PDA arises from RCA. If it's a left dominant circulation, the PDA arises from left circumflex. And if it's a co-dominant circulation, the PDA arises from both LCX and RCA. The coronary blood flow to left ventricle and interventricular septum peaks in early diastole, and the coronary sinus runs in the left AV groove and drains into the RA. So here there is coronary sinus running into the left AV groove, and then it drains into the RA. And the coronary blood flow to left ventricle and interventricular septum peaks in early diastole. Okay. Now, cardiac physiology. So stroke volume. The stroke volume is the amount of blood ejected with each contraction, and stroke volume increases when there is increased contractility, increased preload, and decreased afterload. So when there is increased contractility, the ventricle contracts with more strength with each beat, so it can eject more blood with each beat. And contractility increases while with anxiety and exercise. Increased preload. So preload is basically the end diastolic volume. So when there is more volume filled in ventricle with each diastole, there will be more amount of blood expelled with each contraction. And preload increases in early pregnancy. And decreased afterload. So afterload is the mean arterial pressure of the aorta. So if the afterload is high, then ventricles would have to apply more pressure to overcome that mean arterial pressure. Ventricles would have to apply more force of contraction to force open the aortic valves in order to eject the blood. So when the afterload increases, stroke volume decreases, and when the afterload is decreased, there is less resistance against which ventricles has to push the blood the stroke volume increases. And there is this mnemonic 2 SV cap, and the failing heart has decreased stroke volume if it's systolic or diastolic dysfunction. So if systolic dysfunction, the heart can't eject more blood, hence the stroke volume decreases. And when there is diastolic dysfunction, the ventricles can't be filled to the proper amount, so the end diastolic volume decreases, hence the stroke volume also decreases. Now contractility. Contractility and stroke volume increases with catecholamine stimulation via beta-1 receptors, increased intracellular calcium, decreased extracellular sodium, and digoxin. So when catecholamine stimulation via beta-1 receptor occurs, so this is a cell, this is the beta-1 receptor. When catecholamines act to the beta-1, stimulate the beta-1 receptors, it activates protein kinase A, which in turn phosphorylates the phospholambane. And the phospholambane activates the calcium ATPase pump on the sarcoplasmic reticulum, which increases the calcium storage. So now there is increased calcium in sarcoplasmic reticulum, which will help in more forceful contraction. Okay. This activated protein kinase A, increased calcium channel phosphorylation, increased calcium entry, and increased calcium induced calcium release. So what happens is it increases the calcium storage in sarcoplasmic reticulum, and when that occurs, it induces calcium release into the cytoplasm. So this is called calcium induced calcium release. When there is intracellular calcium, we talked about this, when there is increased intracellular calcium in the cytoplasm, there is more contractility, decreased extracellular sodium. So when there is decreased extracellular sodium, the activity of sodium calcium pump decreases. So now there is decreased sodium on the extracellular, the pump will not function, hence the calcium will not move out of the cell. So the calcium will remain inside the cell, and hence increases the contraction and will increase the contraction. And the second is, the last one is digoxin. Digoxin blocks the sodium potassium pump, so it increases the intracellular sodium. When the intracellular sodium increases, it downregulates the sodium calcium exchanger activity. No, sorry, it does not downregulate, it increases the sodium calcium exchanger activity, and there will be increased intracellular calcium. I don't know why it's written that it decreases the sodium calcium exchanger activity, but it increases it. Here is the sodium potassium pump, and here is the sodium calcium pump exchanger activity. So digoxin blocks this pump. So now there is the potassium can't go in and the sodium can't go out, so there will be increased sodium. Now if there is increased sodium in the cell, it will increase the sodium calcium exchange. So now this increased sodium will exit through the sodium calcium pump, and in return the calcium will enter the cell. Okay. Now contractility decreases with beta-1 blockade. It decreases the cyclic AMP. It decreases with heart failure, with systolic dysfunction, decreases with acidosis, hypoxia, hypercapnia, and non-dihydropyridine calcium channel blockers. The non-dihydropyridine calcium channel blockers block the L type of calcium channels. it inhibits the L type of calcium channel, so there will be less formation of calcium calmodulin complex, and it will not stimulate MLC kinase. That we will see in the pharmacology section. Preload. The preload is approximated by ventricular end diastolic volume, and it depends on the venous tone and circulating blood volume. If the venous tone is good, there will be more venous return, so there will be more preload. And it decreases with vasodilators. Vasodilators dilates the peripheral vessels, so there will be more pooling of blood in peripheries. So due to the more pooling of blood in the peripheries, the blood will not come to the ventricle. The venous return will decrease. So what vasodilators does is decreases the venous return, and when there is decreased venous return, the preload also decreases. Afterload is approximated by mean arterial pressure. Increased wall tension per Laplace's law causes increased pressure and increased afterload. If this is a vessel, there is more mean arterial pressure, so these walls will have more tension. If there is more wall tension, there will be more pressure, and hence there will be more afterload. So ventricles, this is left ventricle, so left ventricle will have to apply more strength to overcome this increased afterload. LV compensates, and to compensate to that afterload, the left ventricle compensates for increased afterload by thickening, hypertrophy, in order to decrease the wall stress. So initially left ventricle will not be able to compensate against the more afterload. It will try to increase the strength of its contraction, but over time, as it cannot increase the strength furthermore, the walls of the left ventricle starts thickening. Okay, so that is called LV hypertrophy. And afterload is decreased by arterial vasodilators. If we dilate this wall, the mean arterial pressure itself will decrease. There will be less tension, there will be less afterload. Okay, so now the tension has decreased because of arterial vasodilators. And hydralazine is arterial vasodilators. All others are venous vasodilators. Like the nitroglycerin and all are this nitroglycerin is venous vasodilator, and hydralazine is arterial vasodilator. ACE inhibitors and ARBs both decrease preload and afterload. Okay, this is a point to remember that ACE inhibitors and ARBs decreases both preload and afterload, and chronic hypertension can also lead to LV hypertrophy. So yeah. Cardiac oxygen demand. So myocardial oxygen demand is increased by contractility, afterload, heart rate, and diameter of ventricle. So when there is increased contractility, the heart needs more oxygen in order to contract more. The contractility is the work done by the heart, right? So in order to do more work, the heart needs more oxygen demand. When there is increased afterload, the more work has to be done by the left ventricle to overcome that increased afterload. When there is increased heart rate, the left ventricle will need more oxygen. The left and right ventricle will need more oxygen in order to beat through that increased heart rate. And when there is increased diameter of ventricle, the diameter of ventricle increases, there is more wall tension, then there is more work to be done by the ventricle to overcome that tension and contract against that pressure to eject the blood. So yeah, it will need more oxygen to do that. And the coronary sinus contains more deoxygenated blood, in most deoxygenated blood in the body. Okay. Wall tension follows Laplace's law. Wall tension is equal to pressure into radius. T is equal to PR. And stress is PR by 2T. Pressure into radius divided by 2 times the wall thickness. This is stress. We had seen this formula in our physics classes, like T is equal to PR and stress is equal to PR by 2T. So when there is increased pressure in the ventricles, the wall tension will increase. When there is increased radius, the wall tension will increase. We saw that here, that the diameter of ventricle increases, which increases the wall tension. Okay, and when the pressure and radius increases, the tension increases, the wall stress also increases. And when the wall stress when the wall thickness decreases, the stress also increases. The thickness decreases and the stress increases. Stress is inversely proportional to the wall thickness. Stroke volume is equal to end diastolic volume minus end systolic volume. The blood after diastole minus the blood after the systole is the blood ejected at each contraction. That is the stroke volume. Okay. And ejection fraction is the stroke volume divided by end diastolic volume. So end diastolic volume is the blood we had after each diastole, and the stroke volume is the amount of blood that we ejected from that end diastolic volume. So that gives us ejection fraction, and it is an index of ventricular contractility, that how much of the amount of blood we ejected from our end diastolic volume. Okay. It decreases in systolic heart failure, obviously, and usually normal in diastolic heart failure, because there is initially in diastolic heart failure there is no problem with the contractility of ventricle. It can eject blood normally, so the stroke volume also remains normal initially. Ejection fraction also remains normal initially. Cardiac output, as we all know, stroke volume into heart rate, and this is fixed principle at rate of O2 consumption divided by arterial O2 content minus venous O2 content. Okay. In early stages of exercise, the cardiac output is maintained by increased heart rate and increased stroke volume. And in later stages, the cardiac output is maintained just by heart rate. And the stroke volume plateaus. So this is very important. It is asked in the multiple choice questions too, that in the initial stages of exercise, the cardiac output is maintained by the stroke volume. When the heart can't eject more blood, it can't increase the stroke volume any further, it increases the heart rate. And the diastole is shortened with increased heart rate. So in ventricular tachycardia, when there is increased heart rate, so ventricular diastolic time is decreased, and when ventricular diastolic time is increased, it impairs the filling of the ventricles, which itself will decrease the stroke volume and will decrease the cardiac output. So with increased heart rate, after some time, the stroke volume will decrease and the cardiac output will also decrease when the heart rate increases very much. The pulse pressure. The pulse pressure is systolic blood pressure minus the diastolic blood pressure. So if the blood pressure is 120 by 80, the pulse pressure will be 120 minus 80, that is 40 mmHg. And pulse pressure is directly proportional to the stroke volume and inversely proportional to the arterial compliance. So when there is increased stroke volume, it will cause increased systolic blood pressure. So this factor will increase and the pulse pressure will also increase, and inversely proportional to the arterial compliance. Pulse pressure is inversely proportional to the arterial compliance. How's that? So we would have to look it up. Arterial compliance mostly depends on the arterial intrinsic elastic properties and is a determinant of the propagation speed of the pulse pressure wave. So artery is responsible for both an increase in the incident pressure wave and the higher effect of reflected pressure waves. Stroke volume, a less compliant aorta will have a greater pulse pressure because the system. Okay. So when there is decreased arterial compliance, for example, there is decreased arterial compliance, so the aorta will be more stiff, it will be less compliant, so the stroke, the systolic blood pressure will increase, right? The aorta is stiff, so it will have to, the blood will have to apply more pressure to its wall, so that is systolic blood pressure. It increases when the aorta are less compliant, and the diastolic pressure remains the same or gets decreased. So if the arterial compliance decreased, the pulse pressure will increase because systolic blood pressure increases and diastolic blood pressure decreases, so the gap widens. Okay. The pulse pressure increases in hyperthyroidism, aortic regurgitation, aortic stiffening, isolated systolic hypertension in older adults, obstructive sleep apnea, anemia, and exercise. Pulse pressure increases in hyperthyroidism, aortic regurgitation. In aortic regurgitation, the blood regurgitates back into the left ventricle, so it will cause the decreased diastolic blood pressure, and when the diastolic blood pressure decreases, the pulse pressure increases. Yeah. When there is aortic stiffening, the systolic blood pressure increases. In aortic regurgitation, what happens? Diastolic blood pressure decreases. Yeah. In obstructive sleep apnea, there is increased sympathetic tone. When there is increased sympathetic tone, the systolic blood pressure increases, increasing the pulse pressure. In anemia and exercise, in anemia there is increased circulating blood volume, the preload increases. Right. And with exercise there is transient increase in the pulse pressure, and decrease in pulse pressure is caused by aortic stenosis. When there is aortic stenosis, the systolic blood pressure itself decreases because the ventricle is not able to eject more blood against a stenosed aortic valve. So there is so there is less stroke volume, which causes less systolic blood pressure. Cardiogenic shock, the heart is not able to function properly, not able to contract properly, so the stroke volume decreases, the systolic blood pressure decreases. In cardiac tamponade, the heart is not able to contract properly, and in advanced heart failure, the heart is not functioning properly, so it will not be able to eject the normal amount of blood it was. The mean arterial pressure is cardiac output into total peripheral resistance. Mean arterial pressure at resting heart rate is equal to 2/3 diastolic blood pressure plus 1/3 systolic blood pressure. Okay, you just have to remember this formula. Or diastolic blood pressure plus 1/3 pulse pressure. I prefer to remember this, the 2/3 dBp plus 1/3 SBP. Now Starling curves. The force of contraction is proportional to the end diastolic length of cardiac muscle fiber. So this is like that Frank-Starling law, that the force of the strength of a muscle fiber is proportional to the length of it, or something like that. So the force of contraction increases with increased preload. So when there is increased preload, increased end diastolic volume, the heart will increase its force of contraction to eject that increased preload, to eject that increased amount of blood it has. And increased contractility with catecholamines, positive inotropes, that is dobutamine, milrinone and digoxin. And the contractility decreases with loss of functional myocardium, that is in myocardial infarction, with beta blockers acutely, and non-dihydropyridine calcium channel blockers, and in heart failure. So now let's understand this graph. Yeah, the Starling's law is that when the muscle fibers are stretched more because of the end diastolic volume, it will result in more strength of contraction, that is increased stroke volume. I just remember it. So let's see this graph. First we'll see the normal graph. So with increase in ventricular end diastolic volume, with increased in preload, the stroke volume has also increased. Like for this point of ventricular end diastolic volume, the stroke volume is this. And when the end diastolic volume increased to this level, the stroke volume has also increased to this level. Now with exercise, the stroke volume will increase more. The person who exercises regularly, so with just a little bit of increase in end diastolic volume, it will increase the stroke volume much more. Okay, and with heart failure, let me just erase all of this. With heart failure, the ability of heart to contract to its full potential decreases. So even if the ventricular end diastolic volume increases to a certain level, now there is a plateau. So the heart can't contract further than its abilities. So the stroke volume does not increases from this stage. So normal was this, with exercise it was this, and with heart failure it is decreased. And if the patient with the heart failure is given positive inotropes, so there is little bit of benefit from it. There is positive inotropy, positive contractility of the heart, so it will cause a little bit of increase in stroke volume. So this is the effect we get with positive inotropes in the patients with heart failure. Okay. Now we'll see resistance, pressure and flow. First we'll see the volumetric flow rate, that is Q. Q is equal to velocity into cross-sectional area. Q is equal to V into A. Yep. And resistance is equal to driving pressure divided by ventricular flow rate. And what is driving pressure? It is viscosity into length divided by cross section divided by the ventricular flow rate. Yeah. And yeah, this. The ventricular flow rate is proportional to the radius to the power of 4. Q is proportional to the radius to the power of 4. So now if the radius of the vessel increases, this is a normal vessel, now increase its radius, the radius is increased, it will cause increase in the ventricular flow rate too. Okay, and this R is resistance. Resistance is inversely proportional to the radius to the power of 4. Now let me draw it here. Yeah, it is normal. We increase the radius by 4. The radius has increased, so what it will do is it will decrease the resistance. Okay, and it will increase the ventricular flow rate. Okay. And the capillaries have highest total cross sectional area. Remember, it is the total cross sectional area, not of a single capillary, but of all the capillaries combined. It has a highest cross sectional area. So if it has a highest cross sectional area, not because it has a highest cross sectional area, but it will have high cross sectional area and lowest flow velocity. Okay, and the pressure gradient drives flow from the highest pressure to low pressure. Why does it have lowest flow velocity? Okay, we just saw it here, that if the radius increases, the flow rate increases. The radius of the capillaries is very, very low, so that causes decreased flow rate. Okay, and the pressure gradient drives flow from high pressure to low pressure. Arterioles account for most of the total peripheral resistance. Veins provide most of the blood storage capacity, because the lumen of the vein is the highest. It provides the most of the blood storage capacity, and viscosity depends mostly on the hematocrit, HCT, and viscosity increases with hyperproteinemic states like multiple myeloma and polycythemia, and viscosity decreases in anemia. Viscosity decreases in anemia because the hematocrit decreases, because there is because the blood is diluted, it has less hemoglobin, and so the blood will be diluted. The blood volume is high, but the hemoglobin is low, so it will the blood will be diluted and the viscosity will decrease. And viscosity is increased by the proteins like albumin and all. So it will be increased in multiple myeloma, polycythemia. Polycythemia, there is increased hemoglobin, so it will increase the viscosity. And now the total resistance of vessels in series is this, just like a physics lecture, like R1 plus R2 plus R3, and when the vessels are in parallel, it is R1 1 by R1 plus 1 by R2 plus 1 by R3. So how they ask the questions is what happens to the cardiac output if one of the organs is removed. Like for example, I saw a question where it was given that nephrectomy was performed. Okay, so the kidney was removed, and all the organs are if we look at it from a perspective of an electrician, the blood supply to all of the organs is in parallel, right? This is heart, like one of the vessels goes to the kidneys, one of the vessels goes to the liver, so one of them goes to the intestines. So if we see through that perspective, all of the vessels are in parallel, right? So what happens is we remove the kidney. Okay, so we remove the kidney which was in the parallel arrangement. So one of the parallel arrangements gets decreased. So what will happen to the cardiac output? So if we remove one of the parallel organs in the parallel arrangement, there will be increased resistance to the other vessels, which will decrease the cardiac output. Okay, so removal of organ will decrease the cardiac output. The cardiac and vascular functional curves. So A is inotropy graph, B is venous return graph, and the C is combined. It is the total peripheral resistance affecting both inotropy and VR. So let's see the first graph. In the first graph, we have to focus on these red lines. So red lines indicate the inotropy, and the blue line indicates the venous return. Okay, so in inotropy, that is contractility. So we have to see the 2 points, that is 1 and 2. In 1 there is increased inotropy, that is increased contractility, and in point 2 there is decreased inotropy or decreased contractility. So for a particular right atrial pressure, we have to compare the contractility, okay, of two situations. So this is point 1 and this is point 2. So for a particular right atrial pressure, the point 1 has increased contractility. So how does that occur? So in point 1, we have given catecholamines, dobutamine, milrinone, digoxin, and exercise. All these things increases the contractility of the heart for a particular right atrial pressure. So that is point 1. And point 2, the heart failure with reduced ejection fraction, that is systolic dysfunction, narcotic overdose, this is very important, and sympathetic inhibition. All these things decreases the inotropy. That indicates our point 2. Here is the point 2. So see, this is the increased cardiac output and this is decreased cardiac output. Okay, and this is the normal one. Okay. So effect changes in contractility causes altered stroke volume. Altered stroke volume causes altered cardiac output, venous return, and right atrial pressure. You don't have to focus on these things. You just have to understand these graphs. So in the first graph, we focused on the red lines, that is cardiac function curve. In the second graph, we will focus on the blue lines, that is the venous tone, which it indicates the venous tone. The point 3, this is the point 3. For a particular cardiac output, for a particular right atrial pressure, there is increased, for a particular right atrial pressure, there is increased venous return. We have to focus on the blue lines. So the blue lines is the venous return. For a particular right atrial pressure, there is increased venous return at the point 3 and there is decreased venous return at the point 4. Now we'll see what causes these point 3 and point 4. So point 3, there is increased venous tone, increased volume, increased venous return. So that is caused by the fluid infusion, sympathetic activity, and atriovenous shunt. So if there is an atriovenous shunt, there will be left to right shunt that will cause more blood to be shunted from systemic side to the venous side, that is the right heart, and there will be increased venous return. So for a particular right atrial pressure in this graph, the venous return has increased because of fluid infusion, sympathetic activity, and atriovenous shunt. Now, how does this venous return decrease, or the volume of blood in our body decreases? So the volume of blood in our body decreases during acute hemorrhage, and second is spinal anesthesia. And also when there is increased venous return, like in point 3, increased venous return, it It will also cause increase in cardiac output eventually, right? Because increased venous return, the blood goes from the right ventricle to the pulmonary artery to the pulmonary vein to the left atrium to the left ventricle, and eventually it increases the cardiac output of the heart. Okay. This increases when circulating volume increases. And the C is TPR. There are 2 points, 5 and 6, like all the other graphs. The point 6 has decreased total peripheral resistance. Okay, so decreased total peripheral resistance is a good thing. So if the resistance is good, the cardiac output is going to be increased, and the venous return is also going to be increased because there is less resistance in the peripheral vessels. Okay, so we can see from the graph 2, if we trace this red, and we have to see both the lines now, we have to see both the colors now, red and blue. The red signifies the cardiac functional curve and blue signifies the venous return or the venous tone. So at the point 6 there is increased, if we see the red line, there is increased cardiac output too, and if we see the blue line, there is increased venous return too. Whereas in point 5, if we see, there is increased total peripheral resistance, which will cause decreased venous return and decreased cardiac output. Now let's see that from the graph. If we trace it back to the y-axis, there is decreased venous return, and if we see the red line, there is decreased cardiac output too. Okay. What causes these 0.5 and 0.6? So 0.5 is caused by the vasopressors. Vasopressors constrict the peripheral vessels, right? So if we constrict the peripheral vessels, automatically the resistance is going to increase. We saw that previously. Okay. If the radius of the vessel is decreased, it will cause increased resistance. Okay. So what vasopressors does is constricts vessels, which will cause increased total peripheral resistance. So that is 0.5. And what is 0.6? The exercise and atriovenous shunt inhibition. Okay. So when the person exercises, the total peripheral resistance decreases, and it will further increase the cardiac output and the venous return. Changes often occur in tandem and may be reinforcing, that is, increased exercise increases inotropy and decreases total peripheral resistance. We saw that here is exercise decreasing the total peripheral resistance, and here is exercise increasing here is exercise increasing the total decreasing the total peripheral resistance, and here is the exercise increasing the contractility, hence increasing the cardiac output. Okay. Decreasing total peripheral resistance to maximize cardiac output or compensatory. Like heart failure decreases inotropy. This is a compensation. This is not a bad thing, but this is a compensation by heart in heart failure, that it decreases the inotropy and it decreases the cardiac output, which causes fluid retention to increased preload to maintain cardiac output. Yeah. So in heart failure, the inotropy decreases, the contractility decreases. So what happens is heart is not able to eject more blood, so the more blood will be left in the ventricles. That will cause fluid retention, because that blood is not being ejected by the ventricles. What the retention of blood will cause in the next cycle is increased preload, right? If the blood is not ejected from the left ventricle, that unejected blood is the preload for the next cardiac cycle, right? So that increased preload will then cause increased cardiac output. So this is compensatory mechanism by heart, that it decreases its contractility, hence there is more retention of fluid, there is more retention of blood in the ventricles, so that will cause increased preload in the next cardiac cycle, increasing the cardiac output in the next cycle. Okay. Now we'll see the pressure volume loops. This is a pressure volume graph of the left ventricle. These we have to start looking from this point, right? When the mitral valve closes, and before the aortic valve opens, there is this phase called isovolumetric contraction, period between mitral valve closing and aortic valve opening. That is the period of highest O2 consumption. Okay. That is the period when the highest O2 consumption occurs by the heart. So the pressure increases inside of left ventricle during this stage. The volume is the same, that is the end diastolic volume. The volume that is being filled after the diastole into the left ventricle, the volume remains the same. But now, as both the valves are closed, the pressure inside the left ventricle increases hugely. So at this point, the aortic valves start opening. As soon as the aortic valve starts open, there is systolic ejection. This is a point of ejection where you can see the left ventricular pressure, it's increasing, but the left ventricular volume is decreasing. From this point to this point, the volume is decreasing, right? Okay, the left ventricular volume is decreasing because it is ejecting blood. There is systolic ejection, period between aortic valve opening and closing. This is aortic valve opens, this is aortic valve closes. So when the aortic valve has closed, it is called the end systolic volume. Okay, the volume of blood that is remaining after the ventricle has done the systole. Okay, so the end systolic volume is very less, but the pressure is high. Pressure is still high. Now what happens is aortic valve closes. As soon as the aortic valve closes, the mitral valve has not opened up yet, and the ventricle goes into the state of relaxation. But now it is called isovolumetric relaxation. Why it is called isovolumetric relaxation? Because the volume of left ventricle is remaining constant, because both the valves are now closed. So what will happen if the volume is being constant and the left ventricle is relaxing? It will cause decrease in pressure. There will be negative pressure created, right? So the pressure has decreased from this point to this point. Okay, that stage is called isovolumetric relaxation, period between aortic valve closing and mitral valve opening. And now what will happen when the mitral valve suddenly opens up? The ventricle has negative contraction, right? So whenever the mitral valve will open suddenly, it will cause rapid filling into the ventricles, period just after the mitral valve opening. And now, as the mitral valve has opened, the left ventricular pressure will not increase. But now, as the blood is being filled into the left ventricle, it will cause increase in the left ventricular volume. Left ventricle is now in diastole, so it will cause increased left ventricular volume, which will give rise to the end diastolic volume. And in the initial stage, there is rapid filling because there is negative pressure inside left ventricle, and then there is reduced filling, period just before mitral valve closes. So we are back to the square one, this point. Okay. Now we have to see the cases where there is increased preload, increased afterload, and all that. Okay. Let me just go to my own notes for this. Where are they? Where are they? Yeah, I think this is it. Okay. You might want to see the diagram of the first aid because I'm not very good with drawings. Okay, so now first we will see the case where increased preload occurs. Okay, so when there is increased preload, so preload is the end diastolic volume, right? So normally the end diastolic volume, this is the volume axis, x-axis is the volume, x-axis indicates the left ventricular volume. So normally this is the end diastolic volume. Now if the preload is increased, the end diastolic volume will also increase, right? That is preload. So we have increased the end diastolic volume. Now we so the graph will look somewhat like this. Okay, because we have increased the preload, so the end diastolic volume is increased. The graph will elongate only on the x-axis, not the y-axis, because y-axis is pressure. The pressure does not increases with increased preload. With what does it increase? What does pressure increases with? It increases with increased afterload, right? So now if we increase the afterload, there is increased aortic pressure, decreased stroke volume, and increased end systolic volume. Even after a systole has occurred, because the afterload is high, the ventricle will not be able to eject the same amount of blood it was initially. So now the end systolic volume will be increased. More volume of blood will be remained unejected in ventricles after the systole. The end systolic volume will increase. So how do we increase the end systolic volume? It is a volume, so it will get increased on the x-axis, right? Is left ventricular volume, it will increase in just on x-axis. So what was the normal end systolic volume? It was here, somewhat here, right? But now we have increased the end systolic volume because we cannot compensate the high afterload, we cannot compensate to the high aortic pressure. The ventricles can't eject the blood against that high aortic pressure. So there will be more blood left in the ventricles. There will be more volume of blood left in the ventricles. So now a new end systolic volume is this. Okay, so end systolic volume has increased by this much. This is a higher quantity than this one is. Okay, so the high afterload graph will look something like this, where the end systolic volume has come to the right side, and increased in preload will look something like the end diastolic volume has come to the right side, shifted to the right side. Okay, now let's see these notes. Yeah, now if preload increases, the preload is equal to the volume. So graph shifts to right on the x-axis. And yeah, one more thing. When afterload increases, afterload is equal to pressure, right? Afterload is mean arterial pressure. So how do we increase the pressure? We increase the pressure on the y-axis. So graph's height also increases on y-axis. That is why this graph is looking like this, because it has increased in height, because it has increased pressure. So when there is left ventricular pressure, increased left ventricular pressure, the stroke volume and cardiac output will both decrease, because more blood is left in left ventricular, that creates more pressure. Okay, the end systolic volume has increased. We saw it. The end systolic volume is increased, so that volume of blood that has remained in the left ventricle, it will cause more pressure in the left ventricle. Now if the contractility increases, there is one other thing left here, like this contractility. Now if the contractility of the heart increases, the stroke volume has to increase, the ejection fraction will increase, and there will be less blood left after a systole. There will be less blood remaining in the left ventricle after a systole. So what is that called? That is called end systole volume. The end systolic volume will decrease because the contractility of heart is now good. So how do we decrease the end systolic volume? First of all, that is volume. So we will indicate that on the, one second guys, it is a volume, so we will indicate that on the x-axis, right? So how do we decrease the end systolic volume? This was the normal end systolic volume. Now the end systolic volume has decreased, so the graft will move to the left, and there will be no change in the pressure. So the height of the graft will remain the same, but the graft will move to the left because the end systolic volume is now decreased. So more stroke volume, right? So less end systolic volume, less blood in left ventricle after systole. So graph moves to left on the x-axis. Okay, so we saw 3 changes in this graph. Let's just simplify this graph. Okay, this is volume, this is pressure. Now 3 things can occur. Preload can increase, afterload can increase, and the contractility can increase. What will happen if the preload has increased? First of all, let's see this, that this is end systolic volume, this is end diastolic volume. Okay. What will happen if we increase the preload? The graft will move to right axis, to the right side of the x-axis. Okay, so this is preload being increased. So now we will increase the end diastolic volume. When there is increased preload, the graft will move to the right. When there is increased afterload, there will be less end systolic volume. There will be less blood ejected with each systole. So the end systolic volume has to decrease. So the graft will move on the right. Okay, because the end systolic volume has increased. So graph will look somewhat like this. Okay, but now as afterload is increased, the mean arterial pressure also increases, the left ventricular pressure also has to increases, so we have to increase the height of the graph too. Okay, so this is what it looks like. So the end systolic volume has increased. Okay, no, that was not needed. And systolic volume has increased, and this is the pressure line on the y-axis. This was the normal left ventricular pressure, but now the pressure has also increased. So in afterload, when afterload is increased, the height of the graph will increase on y-axis, and the graph will move to the right side, decreasing the end systolic volume. Okay. In preload, this end diastolic volume has, in preload, this end diastolic volume has moved to the right side, and in increased afterload, this end systolic volume has moved to the right side. Okay. Don't confuse the both. And when there is increased contractility, there will be decreased end systolic volume. So how do we decrease end systolic volume? We decrease it on the x-axis. So the graph will move something to the left, decreasing the end systolic volume. Okay, just three things. Increased preload, the graph will move to the right. Increased afterload, the height of the graph will increase and it will move to the right. And increased contractility, the graph will move to the left. Now the heart sounds. There are four heart sounds like S1, S2, S3 and S4. The S1 is heard the best at the mitral and tricuspid valve. It is heard loudest at the mitral area, and it signifies the closure of mitral and tricuspid valve. S2 signifies the closure of aortic and pulmonary valve, and because it signifies aortic and pulmonary valve, it is heard loudest at the left upper sternal border. Okay. In S3, when do we hear S3? S3 is heard in the early diastole during rapid ventricular filling phase. Best heard at the apex with patient in left lateral decubitous position, and it is associated with increased filling pressures. Why do we hear S3? It is the sound of blood striking the left ventricular wall, and when we will hear the loud S3, we will hear a loud S3 when there is increased amount of blood striking the left ventricular wall, or when there is increased filling pressures, like blood is forcefully hitting the left ventricular wall like this. And when are those conditions? The increased filling pressures are mitral valve, mitral regurgitation, aortic regurgitation, heart failure, and thyrotoxicosis. Because in aortic regurgitation, the blood regurgitates back into the left ventricle, causing increased left ventricular volume of blood. Increased in mitral regurgitation increases the volume of blood in left atrium, which will eventually increase the volume of blood in left ventricle, which will cause increased filling pressures in the ventricle. And in heart failure, where systolic dysfunction is there, the blood is not able to eject much blood. It will remain unejected in the left ventricle, which will cause increased filling pressures. Okay, and it is also heard in dilated ventricles. So dilated ventricles can contain more blood, and it can be normal in children, young adults, athletes, and pregnancy. Turbulence caused by blood from LA mixing with increased and systolic volume. Yeah, so S3 is just the turbulence caused by the blood coming from left atrium and striking against the left ventricular wall. We are just hearing the turbulence that is caused by the blood. Okay, when do we hear S3? It is during this ventricular diastole phase, during the rapid filling, because the chances of blood striking the left ventricular wall more forcefully is during rapid filling, right? During reduced filling, it is not going to strike as powerfully as it was during the rapid filling. So we hear S3 during rapid filling, when the mitral valve opens, when the left ventricular pressure decreases. Okay. When that happens, there is increased in ventricular volume because the blood coming in is increased in ventricles. I hate this graph. Okay, now we'll see S4. So yeah, S4 is heard in late diastole. It is atrial kick. It is heard in late diastole. The turbulence caused by blood entering the stiffened LV. Best heard at apex with patient in left lateral decubitus position, just like in S3, and it is due to the high atrial pressure contracting against a stiff left ventricle. It is associated with ventricular non-compliance, example hypertrophy, and can be normal in older adults, considered abnormal if palpable. Okay, not auscultable but palpable. If you palpate the chest and you can hear the you can feel the S4, it is considered abnormal. So I'm going to tell you guys a thing which will help you in finding out if that condition will cause S4 or not. You don't have to mug anything up after this. So when is S4 heard? Okay, S4 is heard when atria is pushing blood across the normal valves atria is pushing blood across normal valves into non-dilated and non-compliant ventricle. Okay. So for S4 to be heard, the atria should be pushing blood across the valves that are normal. So the valves should be normal. That is the first condition. The mitral and tricuspid valve should be normal. They should not be stenosed. They should not be regurgitant into the non-dilated. So there should not be any dilated cardiomyopathy. The ventricles should not be dilated. It can be hypertrophied, right? We saw here that ventricular non-compliance is caused by ventricular hypertrophy. The ventricles has to be hypertrophied but not dilated, and the ventricles should be non-compliant. So now whenever there is a question will there be S4 heard in dilated cardiomyopathy, you just have to remember this statement that S4 is heard in non-dilated ventricles. Okay, so no, the S4 will not be heard in dilated cardiomyopathy. Will S4 be heard in mitral stenosis? No, it will not be heard in mitral stenosis because the blood has to go through the normal valves, and mitral stenosis, the mitral valve is not normal, so S4 will not be heard in that condition. Okay. Now we'll see the JVP, the jugular venous pulse. In jugular venous pulse, the waveform has 3 waves and 2 descents. So the waves are positive and the descents are negative. A wave is positive, C wave is positive, and V wave is positive. The X and Y are negative descents because X, and you can remember it like they are the last 2 letters of the alphabet, so they both are negative. So what is A wave caused by? A wave is caused by the atrial contraction. Let me just draw a diagram for you guys. This is the right atrium and this is the internal jugular vein. Okay, so what happens when the right atrium contracts? When the right atrium contracts, the blood will flow from right atria to right ventricle, right? And because of the pressure of the right atrium, that the pressure that is generated in the right atrium due to its contraction, that pressure also goes into the internal jugular vein, which causes increased pressure in the IJV, which will cause a positive A wave. Okay. So right atrium contraction generates pressure in right atrium into right ventricle and also into the internal jugular vein. Okay. Similarly, when right ventricle contracts, the right ventricle contracts when the tricuspid valve is closed, right? So when the right ventricle is contracting, this tricuspid valve is bulging into the right atrium, and this bulging of the right atrium creates a pressure into the right atrium as well as internal jugular vein. But this pressure is not of that high amplitude as the A wave that is caused by the atrial contraction, because it is just by the bulge of the tricuspid valve, bulge of the closed tricuspid valve into the atrium. So this is of low amplitude. See, the A wave is of high amplitude and C wave is of low amplitude. Now during the X descent, so X descent is caused by the atrial relaxation. So when there is atrial relaxation, there is negative pressure in the right atrium, right? The atria relaxes, there is negative pressure, and this negative pressure also travels to internal jugular vein. Okay, so now there is a descent. It is because of the atrial relaxation and the downward displacement of the closed tricuspid valve during rapid ventricular ejection phase. And even when there is so when the right atria relaxes, the tricuspid valve now bulges into the right ventricle, which again creates a little bit of more negative pressure. So this is what negative pressure looks like. It is pulling the walls of the internal jugular vein from inside, and the positive, if there is a positive pressure like in A wave and C wave, it will push the wall of the internal jugular vein outside. This is positive pressure and these are negative pressure. Okay, so X descent is caused by the atrial relaxation, X downward displacement of closed tricuspid valve during rapid ventricular ejection phase. Reduced or absent in tricuspid region. Okay, yeah, so we forgot this thing. The A wave is caused by atrial contraction, right? So when will the A wave be absent? Whenever the atria is not contracting. When is atria not contracting? Atria does not contract in atrial fibrillation. It does contract, but that contraction is not that powerful to generate an A wave. So A wave is absent in atrial fibrillation. Okay, and now the X descent. X descent is reduced or absent in tricuspid regurgitation and right heart failure because pressure gradients are reduced. So we talked that when the right atria relaxes, right, and the tricuspid valve bulges into the right ventricle. But now if the tricuspid valve is regurgitant, okay, so it will not bulge into the right ventricle that effectively, and the blood is also going to regurgitate back into the right atria and into the internal jugular vein. So it will cancel these pressures out. Okay, it will cancel all the negative pressures out, because this was internal jugular vein, this was negative pressure because of the tricuspid valve bulging into the right ventricle, and because now the tricuspid valve is regurgitant, there will be blood flow, and so the blood flow into the internal jugular vein, which will cancel all these waves out. Okay, so the X descent will reduced or absent in tricuspid regurgitation and right heart failure because the pressure gradients are reduced, right? We talked about this, the pressure gradient. This is the pressure gradient. Like it was negative here, it was positive here, but now there is regurgitant valve, so the blood goes from here to here, and so the gradient is reduced. Third is the V wave. V wave is again positive. It is due to the increased right atrial pressure due to increased volume against the closed tricuspid valve. Okay, and V is due to, you can remember V by filling or willing. Okay. when the right atrium is filled with blood incoming from superior vena cava and inferior vena cava, so the blood is being filled in the right atria, right? So it will the filling of the blood in the right atria will increase the right atrial pressure. So filling of right atria increases the right atrial pressure, which in turn reflects into the internal jugular vein. If the pressure here increases, the pressure here will also increase. So it will cause a minor positive V wave. Okay, it is due to atrial filling or atrial willing. Now there is Y descent, which is negative wave. It is right atrium emptying into the right ventricle. So when there is when the tricuspid valve, this is right ventricle. Whenever this valve will open, this is tricuspid valve, and when it will open, the blood will gush from right atrium to right ventricle, emptying the right atrium, decreasing the pressure inside the right atrium, which in turn decreases the pressure inside the jugular vein, which causes a negative wave. It is called Y descent. RA emptying. You can remember it by RA emptying into the RV. And it is prominent in constrictive pericarditis and absent in cardiac tamponade. Why is it prominent in constrictive pericarditis? Because let's see that. Prominent constrictive pericarditis. Pericardium causes elevated atrial pressure. Diastolic filling. Okay, so in constrictive pericarditis, there is inflammation of pericardium. Okay, the pericardium is surrounding the right atrium, and it is constrictive. It constricts the right atrium, so it will increase. It will result in the additional increase in the pressure of right atrium. It will increase the pressure by which right atrium fills the blood into the right ventricle. So overall there will be increased in the right atrial pressure because the pericardium is constricting the right atrium. So that increase in the right atrial pressure will reflect on the jugular vein. So the Y descent will be more prominent. Okay, and it is absent in cardiac tamponade because in cardiac tamponade the ventricular filling is impaired. So when the ventricular filling is impaired, the pressure is decreased. The pressure through which RA empties into the RV is also decreased. So it will cause in absent Y descent. Okay. These are the pressure volume loops, like we saw earlier, the pressure volume loop of the left ventricle, and now we will see how these valvular diseases affect those pressure volume graphs. We will mostly focus on the left ventricular pressure and left ventricular volume. So in aortic stenosis, firstly let's remember what these 2 points were. This was end diastolic volume and this was end systolic volume, right? So what happens in aortic stenosis is that the end systolic volume is increasing, right? So as the aortic valve is stenosed, the left ventricle will not be able to eject much blood through that stenosed valve. So more blood stays in the ventricle even after systole has occurred. So what is that called? That is called end diastolic volume. So the end diastolic volume increases in aortic stenosis. More blood is staying in the left ventricle. Okay. And as more blood is staying in the left ventricle, It will also cause increased in the left ventricular pressure, right? Because the aortic valve is stenosed, the left ventricle has to do more work against that stenosed aortic valve to eject blood. Okay, so LV pressure also increases. So this is the increase in that LV pressure. Earlier at the end of the contraction, the LV pressure was this, but now the LV pressure has increased. Okay, so the graph will move to the right, the end systolic volume will move to the right, it will increase, and the height of the graph will also increase, and this is LV pressure, and LV pressure will be more than aortic pressure. The pressure gradient across the aortic valve increases. So the pressure in left ventricle is more than the pressure in the aorta to overcome the stenosed valve, and obviously the stroke volume will decrease. And when there is increased volume in the left ventricle has to hypertrophy. Left ventricle has to undergo hypertrophy in order to do more work to eject that blood. Okay, in order to eject blood through the stenosed valve, it has to do more work, and to do more work it undergoes hypertrophy. So okay, ventricular hypertrophy, decreased ventricular compliance, and increased end diastolic pressure for given end diastolic volume. For this given end diastolic volume, the end diastolic pressure has increased, right? Now, aortic regurgitation. So what happens in aortic regurgitation? During the diastole, during the diastole, the blood travels from left atria to left ventricle, but because the aortic valve is regurgitant, the blood from aorta also travels back into the left ventricle. So now, after the end of the diastole, there is blood coming in from left atria as well as the aorta. Okay, so the end diastolic volume is going to increase. And how do we show the increase in end diastolic volume? This was end diastolic volume. So now the end diastolic volume will shift to the right. The graph will shift to the right. This is the increase in the end diastolic volume, right? And as there is increase in end diastolic volume, there is no problem with the ventricular valve. There is no problem with ventricular compliance as we saw in aortic stenosis. The stroke volume is going to increase in order to compensate for the increased end diastolic volume, in order to compensate for the increased preload. Okay, we saw that if we have to increase the preload, the graph moves to the right. If we have to increase the afterload, the graph moves to the end systolic volume moves to the right, and the height increases. And if we have to increase the contractility, the graph will move to the left and decrease the end systolic volume. So this is the case where end diastolic volume or the preload is increasing, so the graph will move to the right. Okay, and there will be large pulse pressure because the stroke volume is increasing, so it will cause more systolic blood pressure, increase in systolic blood pressure. Okay, so that will widen the pulse pressure. And now, as the aortic valve is not stenosed, there will be no loss of pressure gradient across the aortic valve, so the left ventricular pressure and the aortic pressure both will remain more or less the same. Okay, now mitral stenosis. Mitral stenosis. So in mitral stenosis, just like in aortic stenosis, the left ventricular pressure increased. In mitral stenosis, the left atrial pressure is increased. Okay, so now because the mitral valve is stenosed, during the ventricular diastole, there will be less filling of the blood. There will be less blood coming from left atria to left ventricle. Okay, so the end diastolic volume is decreased, that is preload. The preload is decreased, right? And if the preload is decreased, the stroke volume also decrease, right? And how do we decrease the preload? How do we decrease the end systolic how do we decrease the end diastolic volume? This was end diastolic volume, right? Now when we wanted to increase the preload, we shifted this graph to the right side. We shifted the end diastolic volume to the right side. Now we want to decrease the preload. Now we want to decrease the end diastolic volume. So what we will have to do? We will have to shift the graph towards the left side. The end systolic volume is also little bit decreased. And it's natural, because whenever the end diastolic volume decreases, whenever the preload is decreased, end systolic volume is also a little bit decreased, because if the ventricles does not have blood filled in it, it will also eject the same amount of blood, but it will be less amount of blood compared to the normal. Okay, so end systolic volume also decreases. And what is this? Yeah, so this is the green one, is the left atrial pressure. So left atrial pressure is increasing, okay, and there is no effect in the left ventricular pressure or the aortic pressure, and the left atrial pressure is more than left ventricular pressure. Wow. Okay, this is important in the MCQs as well, that in mitral stenosis the left atrial pressure is more than left ventricle pressure, and in aortic stenosis the left ventricular pressure is more than the aortic pressure. Okay, now in mitral regurgitation, like we saw in aortic regurgitation, that the blood was regurgitating back into the left ventricle during the diastole. So now in mitral regurgitation there will be no true isovolumetric phase. So during the isovolumetric relaxation of the ventricle, what was happening was that there was negative pressure being built in the left ventricle, but now as the mitral valve is regurgitant, there will not be negative pressure building up that much, because whenever the ventricle is trying to diastole, the blood will regurgitate from left atria to left ventricle, because the mitral valve is impaired, the mitral valve is regurgitant. So there will not be true isovolumetric phases ever, isovolumetric relaxation or isovolumetric contraction, because the mitral valve is staying open always. So there will never be a closed chamber formation. There will always be an opening, that is mitral regurgitation. And so now as there is an opening, let's see this graph. This is end diastolic volume. The end diastolic volume is going to increase, because the blood is coming in before even the mitral valve gets opened completely, right? Because the mitral valve was regurgitant, the blood is always continuously coming in from left atria to left ventricle, and when the mitral valve opens completely, the blood coming in earlier will be added to the end diastolic volume. So in total the end diastolic volume will increase, and the end systolic volume decreases due to decreased resistance and increased regurgitation into LA during systole. Decreased end diastolic volume due to increased LA volume pressure from regurgitation. Okay. So due to regurgitant mitral valve, there will be increased ventricular filling. Yeah, this is the correct word. This is the correct term I wanted to use. That there will be increased ventricular filling during the diastole due to the regurgitant mitral valve. And now, whenever the ventricular systole occurs, whenever the ventricle tries to eject blood from left ventricle into the aorta, because this this mitral valve is regurgitant, most of the blood will go into the aorta, but some of the blood will also go back into the left atria because the mitral valve is regurgitant. The mitral valve can do nothing about it. It will remain somewhat open always. So some blood also gets regurgitant into the left atria, right? So what happens is the normal amount of blood that should be coming out of left ventricle into the aorta, that is the stroke volume. Some amount of it is going into the left atrium. So what happens is stroke volume decreases. Okay. No. Wait. Okay. Yeah. So what is happening here is, as some amount of blood is also going into the left atrium. Okay, so normally there will be some amount of blood remaining in the left ventricle after systole, right? That is called the end systolic volume. So now that volume will decrease because if there is blood remaining in the left ventricle after systole, now there will not be any blood remaining in the left ventricle after systole because the blood is regurgitating back into the left atrium. Okay, I've complicated it too much. Like, this is left ventricle, this is aorta, this is left atrium, and this is mitral valve, which is always open because it is regurgitant. So now normally after every systole there is a certain amount of end systolic volume. Okay, but now as the mitral valve is regurgitant, that volume too is being regurgitant back into the left atrium. It is going back into the left atrium, which will decrease the end systolic volume. And how do we decrease the end systolic volume on the graph? We move the graph little bit to the left side. See, you can see this is that increased end systolic volume, and the end diastolic volume also increases. And the stroke volume increases because the forward flow into the systemic circulation plus back flow into the left atrium. So now you have to understand that stroke volume is not just the blood going from LV into the aorta. Stroke volume is just the blood ejected by the LV, rather be it in aorta or be it in LA. So now there is blood going into the aorta as well, into the left atrium as well. So we can say that the stroke volume of the left ventricle has increased. It is ejecting more blood, right? Not just at the right place. And as it is ejecting more blood, there is also a less, due to that reason, less end systolic volume, because the blood is being ejected into the aorta as well as into the left atrium. So now there will be decreased blood in the left ventricle after every systole. Okay. Let's just summarize this. In aortic stenosis, the end systolic volume will increase and the left ventricular pressure will increase. Okay. In aortic regurgitation, because the blood is regurgitating back into the left ventricle with each diastole. Okay, the blood is coming into the left ventricle from atria as well as from the aorta, because the aortic valve is regurgitant. So the end diastolic volume is going to increase. Okay, then as there is increased end diastolic volume, there is increased preload. The stroke volume is also going to increase. In mitral stenosis, just like in aortic stenosis, the LA pressure increases as opposed to increased LV pressure in the aortic stenosis. There will be decreased end diastolic volume because of impaired ventricular filling. Okay. Blood can travel from LA into LV during the diastole. And as end diastolic volume preload decreases, the ESV is also going to decrease and the stroke volume is also going to decrease. Okay. And in mitral regurgitation, blood is regurgitating from the ventricle to the aorta during the systole. So the stroke volume is increasing, and as the stroke volume is increasing, the end systolic volume is going to decrease, and there is increased end diastolic volume because the mitral valve is is open always. So there is more blood coming in from LA into LV and from LA into LV at all times, right? Okay. So if you want to differentiate between all these graphs like quickly, just remember that if the pressure is increased, the graph has become taller, it is always aortic stenosis. If the end diastolic volume has increased, the graph has this is the normal shape of the graph. If the graph has moved to the right side, okay, that is aortic regurgitation. And if the graph has moved to the right side as well as little bit to the left side, like this has moved to the right side, it is aortic regurgitation. If it has moved to the right side as well as little bit to the left side, it is mitral regurgitation. And mitral stenosis if the graph has moved to the left side. Okay, then it is mitral stenosis. Okay, so tall graph aortic stenosis, right shift aortic regurgitation, right and left shift mitral regurgitation, and just left shift mitral stenosis. Okay. Okay, now we'll see the splitting of S2. So when there's inspiration, there's a drop in intrathoracic pressure. So drop in intrathoracic pressure creates a negative pressure, right? The drop is negative pressure. So the negative pressure sucks in more blood, and that is why there is increase in venous return, increased in right ventricular filling, increase in right ventricular stroke volume, and increase in right ventricular ejection time. So as right ventricle has to eject more blood, there is increased stroke volume, the right ventricle will take more time to eject that increased amount of blood, right? So there is RV ejection time is increasing, and because the ejection time of right ventricle is increasing, there is delayed closure of the pulmonic valve, and there is decreased pulmonary impedance. There is increased capacity of pulmonary circulation also occurs during inspiration, which contributes to delayed closure of pulmonic valve. So during inspiration, two things are happening. The first is RV ejection time is increasing, and second is pulmonary resistance is decreasing in order to welcome more blood coming in from right ventricle. So that causes the delayed closure of pulmonic valve during inspiration. So you can see that here, this is inspiration, and during expiration, the A2, the aortic valve closing and pulmonic valve closing are both very near to each other, but during inspiration there is a normal delay that occurs due to this mechanism, and there is a delay in the closure of P2 valve during inspiration, and this is a normal delay. This occurs every time we inspire. Okay, but now we'll see the pathology behind it. Sometimes there is wide splitting. What is wide splitting? That P2 should normally be here, right? But the wide splitting is when P2 is more further away from A2 than normal conditions. Wide splitting is seen in conditions that delay right ventricular emptying, like pulmonary stenosis, right bundle branch block. All of these are right heart conditions which delays the right ventricular emptying into the pulmonary artery. It causes delayed pulmonic sound, especially on inspiration. It will be heard, the wide splitting will be heard more clearly during the inspiration, and it is an exaggeration of normal splitting. Then there is fixed splitting. It is heard in atrial septal defect. So in atrial septal defect, there is left to right shunt. The blood is coming in from left atria to right atria, and from right atria to right ventricle, and increased flow through the pulmonic valve. So there is blood coming in from left atria, extra blood coming in from left atria, which will add on to the amount that is normally present there. So now there is extra amount of blood in right ventricle, and that will cause delayed pulmonic valve closure. And it is independent of respiration, right? Because earlier we saw that physiological splitting is just because of inspiration, and the inspiration which causes drop in the intrathoracic pressure, and it increases the venous return in right ventricle. So there is increased venous return in right ventricle just during the inspiration. But if there is an atrial septal defect and left to right shunt, it will not depend on the inspiration or expiration. It will occur at both the times. So because it is occurring at inspiration as well as expiration, there will be a split. Yeah, there will be a split, but it will be a fixed split. So what does a fixed splitting means? That there is equal amount of gap between aortic and pulmonic valve closure during expiration as well as inspiration, right? So that is called fixed splitting, and it is seen only in ASD. Okay. Now paradoxical splitting. So what does paradoxical splitting means? That normally what happens is aortic valve closes earlier than pulmonic valve, but in paradoxical splitting, the pulmonary valve will close earlier to the aortic valve, or in other words, aortic valve will close later than the pulmonic valve. So why does this happen? This can happen because of the left heart conditions, right? So wide splitting of pulmonary valve was because of the right heart conditions. Now if aortic valve closure is delayed, it will be because of the left heart conditions, like aortic stenosis. Here we saw pulmonary stenosis for wide splitting of pulmonary valve. For splitting of delayed closure of aortic valve, it will be aortic stenosis and left bundle branch block. This is just opposite of this condition. Like pulmonary stenosis, here it is aortic stenosis, here it is right bundle branch block, here it is left bundle branch block. Normal order of semilunar valve closure is reversed. So that is called paradoxical splitting. P2 occurs before A2. On inspiration, P2 closes later and moves closer to A2, paradoxically eliminating the split. And on expiration, the split can be heard. So normally the wide splitting and physiological split is heard more during inspiration, but paradoxical split is heard more during the expiration. Why does that occur? So normally this is expiration, this is inspiration, this is S1, and normally this is A2, and this is P2, right? That is normal. This is physiologic split during the inspiration. Now as P2 closes earlier than A2, so then P2 will move forward in this direction. So now if this is A2, and because during expiration the gap is very minimal, so now if the pulmonary valve is closing before the aortic valve, it will come in front of the A2. It will come in front of the A2, right? And this is A2. But as there is okay, let me use a different color. As you can see, the gap is larger in inspiration, right? The gap between the aortic and pulmonary valve during inspiration is larger than during expiration. So what happens is P2 has to move in this direction, right? So now this is A2, but P2 will move forward but will not be able to move in front of the A2, right? So P2 will move close to the A2 but not in front of it, and it will move so close to the A2 that the split is eliminated, right? During, we are talking about inspiration, the split is eliminated, but now because the P2 is in front of A2 during expiration, we can heard the split. But now as P2 is in front of A2, that is a paradoxical split, or the physiologic split is reversed. Okay. Now the auscultation of the heart, you don't have to remember this mnemonic or anything. If you place the heart in its position, you can know that we'll first talk about the mitral area. That mitral area is at the apex. It is at the mitral valve area is at the apex. The tricuspid valve area is at the left sternal border, fourth or fifth intercostal space. Like if this is the heart and this is the sternum. Okay, and so this is the apex. So the apex is at the mid-clavicular line at fifth intercostal space, I think, a little lateral to the mid-clavicular line. So this is mitral area, and the tricuspid valve is on the right side, right? So it will be on the right side of the mitral area. So tricuspid valve area is somewhat here, which accounts for the left sternal border of the fourth intercostal space, fourth or fifth intercostal space. Yeah, it's fourth intercostal space. This is pretty easy, right? And one thing you have to be careful about is we'll think that the aorta arises from the left ventricle, so aortic area will be on the left sternal border, right? That's not the case. Like if this is the left ventricle, aorta rises like this. So the aortic area is on the right sternal border. Here is at the second intercostal space, and the pulmonic area, the pulmonary artery arises like this. So pulmonary area is on the left sternal border here. Now if there's any question about the murmurs, you first have to identify its position and position of its auscultation of the murmur. That will always be given in the question, and if you know the position of the murmur, you can figure out which valve they are talking about. Like they will state in the question that there is a systolic murmur in the right sternal border at the second intercostal space. So now you have to think that the right sternal border, second intercostal space, is the position for the aortic valve auscultation, and at the aortic valve it is stated that this is a systolic murmur. So systolic murmur at the aortic valve, that must be the aortic stenosis, right? So that is aortic stenosis. You have to approach the murmur questions in that way. First you have to identify the valve they are talking about. Yeah, then it's just very easy. Murmur questions are the most easiest questions in the cardiovascular system. Other thing you have to keep in mind is there's your ASD murmur and the VSD murmur. ASD is heard at the pulmonary area, and VSD is heard at the tricuspid area. So both the septal defects murmur are at the left sternal border. Okay. Yeah. And the other one is hypertrophic cardiomyopathy. So that is also heard at the left sternal border, but it is heard in between the pulmonary area and the tricuspid area, around the third intercostal space. So there are three conditions apart from the valvular pathologies. Like we know, aortic stenosis, regurgitation, mitral stenosis, regurgitation, tricuspid, and all that. But these three are the extra conditions: ASD, VSD, and hypertrophic cardiomyopathy. All three are heard at the left sternal border. Okay. Moving on to the maneuvers, so the thumb rule for these maneuvers are, if we increase the preload, most murmurs are going to increase. Okay. Except there are just three exceptions. If we increase the preload, most murmurs are going to increase because there will be increased blood flow. And what is murmur? But it's just a turbulence of the blood flowing. Okay, so now if we have more blood, there will be a lot more turbulence, and it will cause increase in the intensity of the murmurs. So if we are increasing the preload, the murmurs are going to increase, except in mitral valve prolapse and hypertrophic cardiomyopathy. And if we increase the afterload, there will be increased pressure in the aorta, and that will cause the blood, that will decrease the gradient. Okay. And if there is increased pressure in the aorta, the blood will flow back. There will be a reverse flow through the aortic valve, which will again increase the amount of blood in left ventricle. So there will be increased amount of blood that will result in increased intensity of murmur. But that occurs only in the left side of the heart, because aorta is just supplied from the left ventricle, right? And the blood comes back in the left ventricle. So all of the murmurs that are left-sided murmurs will increase in intensity. Except aortic stenosis and HOCM. Because in aortic stenosis, the aortic valve is stenosed, right? So it will not allow the blood from aorta to regurgitate back into the left ventricle and increase the amount of blood in the left ventricle. Okay. So now the first one, standing and Valsalva. So when we are standing, there is blood pooling in our peripheries, right? So if the blood is pooled in our peripheries, the preload is going to decrease. Okay. There is blood pooling in limbs. Blood has pooled in the limbs, so that will cause decreased preload. Now if the preload is decreased, most murmurs are going to decrease, right? Most murmurs decrease with this maneuver, standing and Valsalva. But there are two murmurs that will increase with decreased preload. We saw this here, right? It is MVP and hypertrophic cardiomyopathy. So why does that occur? In mitral valve prolapse, the murmur will increase with decreased preload because there is less blood in left ventricle, right? So mitral valve will prolapse sooner and severely. Let me just write that down for you. Due to less blood in LV, mitral valve will prolapse sooner and severely. So that will cause increase in the intensity of murmur. And in the case of HOCM, when there is less left ventricular volume, even more outflow obstruction will occur. When we'll study the hypertrophic cardiomyopathy, we'll understand that we'll see that there is outflow obstruction of the left ventricle in hypertrophic cardiomyopathy, because the walls are very thick. Walls of the left ventricle are so thick that it itself obstructs the aortic valve outflow. Okay, so now if there is even less left ventricular volume, the obstruction will increase and the outflow itself will decrease. Okay, so that will cause increase in intensity of this murmur. Let's just remember that less left ventricular volume due to HOCM, it will cause even more LV outflow obstruction. Yeah, there is decreased left ventricular volume due to decreased preload, and that will cause even more LV outflow obstruction. Okay, now during passive leg raise and squatting, during passive leg raise, all the blood that has pooled in the limbs will come back to the heart, increasing the preload. So that will increase the intensity of most murmurs, right? And because there is more blood flowing through the stenosis or regurgitant valve, it will increase the intensity of the murmurs. And during squatting, during squatting, the limbs are at the position of the heart, right? If you imagine yourself squatting, your knee level will be, if you are able to do a perfect squat, your knee level would be somewhat equal to the heart level. So that will cause increased venous return, and that will itself increase the preload. And during squatting, you are flexing your knees and your hips, right? So that will also cause increased afterload, because the arteries are getting compressed. So there will be increased pressure in those arteries, and that pressure will be reflected back into the aorta, and it is increasing the afterload. Okay, so we know why the preload is increased. I will write here why is the afterload is increasing during squatting, due to your legs are flexed and hips are also flexed. Okay, it is somewhat similar to the hand grip we'll talk about. Squatting is somewhat similar to the hand grip. Okay, and most murmurs are going to increase because the preload is increasing, and just mitral valve prolapse and hypertrophic cardiomyopathy will decrease because the preload is increasing. And during hand grip, there is no increase in preload, there is just increase in afterload. So because we are flexing our wrist, the arteries will get compressed, that so the pressure in those arteries will increase, and that increased pressure will be reflected to the aorta, increasing the afterload. So if there is increased pressure in the aorta, now the blood will flow back into the left ventricle. There will be reverse flow across the aortic valve, and that will increase the left ventricular volume. So now if the left ventricular volume is increased, there will be more blood flowing through the aortic or regurgitant valve of the left side only, because from aorta the blood goes just into the left ventricle, not into the right side. Okay, so the murmurs of the left side will only increase. So what are the murmurs on the left side that are going to increase? It is aortic regurgitation, mitral regurgitation, and when VSD. Okay, you have to remember VSD per se, because you are not going to figure out through these technique why VSD murmur is increasing with hand grip. Yeah. And aortic stenosis, murmur is going to decrease because we talked about that. Because the aortic valve is stenosed, the blood is not reverse flowing from aorta into the left ventricle because of the stenosed aortic valve. So it will not amount to increase in blood volume in the left ventricle. So the blood is going to so there will be less blood flow from through the stenosed aortic valve, which will decrease its murmur. Okay. The transaortic valve pressure gradient has decreased, because this is LV, this is aorta. So normally what is the scene that this has positive pressure, aorta has negative pressure. So blood flows from aorta to from left ventricle to aorta. Now if we perform hand grip, there is positive pressure in aorta as well, and here it is a stenosed valve. Okay, so now that gradient was previously there from positive to negative, now it is positive on both the sides, so blood will not be able to flow through that gradient. Okay, so in aortic stenosis, the intensity of the murmur decreases with hand grip. And in hypertrophic cardiomyopathy too, because now there is more blood coming into the left ventricle, there is more blood, more left ventricular volume, so there will be less LV outflow obstruction. Okay. Now during inspiration, there is increased venous return into the right heart, right? So there will be increased intensity of the most right-sided murmurs, and there will be decreased intensity of the more left-sided murmurs. It is opposite to the hand grip. And during hand grip, only left-sided murmurs increased in the intensity, but now during inspiration, only right-sided murmurs are going to increase in the intensity. Aortic stenosis, it is a crescendo decrescendo, which means that it first is going to increase in intensity, then it's slowly going to decrease in intensity. These are all our systolic murmurs, so they will be heard between S1 and S2 sounds, and it is an ejection murmur. It is loudest at a heart base, and it radiates to the carotids. Okay, this is important, where it is going to radiate. And the S2 is going to be soft, and it can have ejection click. It may or may not have an ejection click. And there is pulsus parvus et tardus. So pulsus parvus et tardus is, let me show you. Like if this is a wave of a normal pulse, during pulsus parvus et tardus, the pulse will have a low amplitude, so the height of the pulse is also going to decrease, and the pulse is going to be delayed as well. So if this is a normal pulse, this is pulsus parvus et tardus. So the amplitude has decreased and the peak is also delayed. There is also another term called pulsus parvus. I'm not sure, but in pulsus parvus, only the peak is delayed or something like that, or you guys would have to look it up yourselves. Okay, and this is seen mostly in the older patients because of the aortic sclerosis. Old age causes sclerosis, and it causes age-related calcification. In younger patient, most commonly due to early onset calcification of the bicuspid aortic valve, and if it is occurring in the young patient, it is going to be a bicuspid aortic valve, and there will not be a soft S2. So there is, if you want to imagine what a soft S2 sound is heard like if you have a fresh rupee note, if you have a fresh currency note, and if you flick it, there will be a sharp noise coming in. So that is a valve, that is a sound of valve of the younger patient. And if you take an old currency note, a used currency note, and then if you flick it, there will be a little softer noise. So that is a valve of a sclerosed old patient. Okay. So if you hear a soft S2 sound, it is due to sclerosis of the valve, and it is in the older patients. But if you do not hear a soft S2, it might be of a younger patient, and it might be because of the bicuspid aortic valve, not the sclerotic valve. Now, what is the symptoms of aortic stenosis? It's SAD, syncope, angina, and dyspnea. And the LV pressure is higher than the aortic pressure because it has to compensate for the stenosed aortic valve to push blood through the stenosed aortic valve. Okay. And it is heard during systole because whenever a ventricle tries to push blood through that stenosed valve, it is during systole, right? The ventricle contracts to eject blood through that valve. You hear that murmur. You will hear murmur whenever there is blood flowing through that pathological valve, right? Because if the aortic valve is stenosed, you will only hear a murmur when blood is flowing through that valve. So when is blood flowing through that valve? When ventricles contract during the systole, the blood is going to flow through that aortic valve to go into the aorta. Okay, that is the basic science behind hearing the murmur. That flowing of the blood through a pathology causes a murmur. Okay. Now, mitral and tricuspid regurgitation also causes a systolic murmur, but now it's holosystolic, that the amplitude of the murmur is same throughout the systole. It is a high-pitched blowing murmur, like it's something like that, and it is loudest at the apex. Okay, at the apex is the mitral area, and mitral regurgitation, it is loudest at the apex. It is the mitral area, and it radiates towards the axilla because the axilla is more near to the apex than the carotids. Aortic stenosis murmur was heard at the heart base, and the heart base is much nearer to the carotids than the apex. So whichever area is near, it will radiate to that area. And tricuspid regurgitation is loudest at the tricuspid area, which is the left sternal border at the fourth intercostal space. Mitral regurgitation can occur due to ischemic heart disease like post-MI, MVP, left ventricular dilatation, and rheumatic fever. Okay. Due to MI, during MI, if that area of the heart is infarcted, which contains the mitral valve, it will cause dysfunction of that mitral valve, and it will not close properly, which will eventually lead into a regurgitant mitral valve. In LV dilatation, the left ventricle is dilating, right? So it will pull the mitral valve through it and pull open the mitral valve at all times, which will cause a regurgitant mitral valve. Rheumatic fever affects mitral valve, and tricuspid regurgitation is often due to right ventricular dilatation. Just like I told in left ventricular dilatation, right ventricular dilatation will pull apart the tricuspid valve and cause a regurgitant tricuspid valve. Either MR or TR, infective endocarditis. Infective endocarditis is a single condition that can affect either mitral valve or tricuspid valve. Now, mitral valve prolapse. Mitral valve prolapse is a late crescendo murmur with mid-systolic click that occurs after the carotid pulse. It is best heard over apex, loudest just before S2. Okay. So first we saw it was a crescendo murmur, then it was a holosystolic murmur, and now it's the murmur like fading away. So it is just in the later part of the systole. It is a late crescendo murmur. Crescendo means it is increasing in the intensity murmur, and there is a Initially there is a mid-systolic click. Okay, that mid-systolic click is I think it is due to the when mitral valve prolapse occur, the wall of the mitral valve crashes with the wall of the heart, which causes the mid-systolic click. Okay. Is best heard over apex, that is mitral valve area, and it is loudest just before the S2. It is usually benign but can predispose to infective endocarditis. It can predispose to infective endo. Infective endo was causing MR or TR, but MVP can cause infective endo, and it can be caused by rheumatic fever, chordae rupture, or myxomatous degeneration, primary or secondary to connective tissue diseases. Connective tissue diseases that are rheumatological diseases like SLE, and other. Okay. See, due to sudden tensing of chordae tendineae, most common due to sudden tensing of chordae tendineae as mitral leaflets prolapse into the left atria. So why does this mitral valve prolapse occur? Because the chordae tendineae, that is, if this is the valve, these are the chordae tendineae. So now if the chordae tendineae is suddenly stretched, it will cause the mitral valve to prolapse into the left atria, that is causing this murmur. Okay, that is causing this click, mid-systolic click. It is due to the sudden tensing of chordae tendineae. If there's an MCQ which asks about the reason of the mid-systolic click heard in the mitral valve prolapse, it is because of the tensing of chordae tendineae. And VSD also has a holosystolic murmur, but it is harsh sounding. Okay, in MR or TR it was a blowing murmur, like, but in VSD it is a harsh sounding murmur, and it is heard loudest at the tricuspid area, and it is VSD, so its murmur will be heard in young ages too. It is congenital murmur. Okay, and larger VSDs have a lower intensity murmur than the slower VSD, because you have to understand that if the defect is very small, the blood flow is going to be more turbulent. Okay, and if the defect is larger, the blood can flow easily through that defect, which will cause less turbulence relative to the smaller defect. So larger VSDs have a lower intensity murmur than the smaller VSDs. Now we'll see the diastolic murmurs. First is the aortic regurgitation. So during diastole, there is negative pressure in the left ventricle, right? And as the aortic valve is regurgitant, it will suck in the blood from left atria as well as from the aorta. It will suck in blood from the aorta as well, because the aortic valve is regurgitant, right? It is not closed completely. There is an opening in the aortic valve, which will allow the blood flow from aorta to the left ventricle back during the diastole. Okay. Early diastolic decrescendo, high-pitched blowing murmur, best heard at the base of the heart, that is aortic area. Aortic root dilatation can cause aortic regurgitation or left sternal border valvular disease. Okay, so if it is heard at base, it is due to aortic root dilatation, and if it is heard at left sternal border, it is due to valvular disease. Okay. So what are the causes of aortic regurgitation? It is bare, bicuspid aortic valve endocarditis, aortic root dilatation, and rheumatic fever. So if this is the aortic valve, these are the aortic roots. Okay. Now, due to some aneurysm or something like, or some other pathology, if this aortic root dilates, this is connected to the aorta, right? So during syphilis, during Marfan syndrome, or during aortic aneurysm. If there is an aneurysm like this, it is going to pull apart the aortic roots, and if the aortic roots are pulled apart, the opening of the aortic valve is going to increase, which will cause a regurgitation. Okay. And due to aortic regurgitation, there will be wide pulse pressure, because the diastolic blood pressure has now decreased, because during the diastole the blood is flowing back from the aorta to the left ventricle, so that will cause decrease in the diastolic blood pressure, so that will widen the pulse pressure. And there is pistol shot femoral pulsing nail bed, that is called Quincke's pulse. You can hear this pulse, hyperdynamic pulse throughout the body. Now I don't remember the name of the signs, but you can hear those hyperdynamic pulses. You can see those pulsating arteries in retina, in femoral pulses, in carotids, and that can cause head bobbing. And there's that Lincoln sign in the popliteal, where there is hyperdynamic pulse in the popliteal artery, which causes the bobbing of leg. Your leg can't stand still if you're sitting. It is named after Lincoln. It is Lincoln sign, because during a photograph, when they were capturing Abraham Lincoln, so in one of the photograph, his leg was blurry, and when the photographer asked Abraham Lincoln to keep his leg still, he was not able to, because he had Marfan syndrome, and due to that he had aortic regurgitation, and due to that he had a hyperdynamic pulse in the popliteal artery, so that was keeping his leg bobbing. You can search that image, or I can search that image for you. This is very vague search. Okay, yeah, here's that. Okay, you can see the leg is you can see the leg is kind of moving. The leg is kind of blurred. Okay, the whole picture is blurred, but the leg is more blurred than relative to the picture. Okay. It happens when the aortic regurgitation has become severe and chronic, and it can progress to left heart failure. Let's again see the causes. B is bicuspid aortic valve, infective endocarditis, aortic root dilatation, and rheumatic fever. Now, during mitral stenosis, murmurs occurs because during the diastole, we are talking about the ventricular diastole, right? During the ventricular diastole, the atria are in systole. The atria are contracting against the stenosed mitral valve. It is trying to push blood from left atria to left ventricle during the atrial contraction, and that atrial contraction is known as the diastolic phase of ventricles, right? So mitral stenosis murmur is heard during the diastole phase, and there is opening snap. Okay. And yeah, one more thing, you hear the aortic regurgitation murmur during the rapid filling phase. Okay, because that's when there's the most negative pressure in the left ventricle, so that is when it can suck the most amount of blood from the aorta back into the LV. Okay. And mitral stenosis has an opening snap and delayed rumbling, mid to late murmur. There is decreased interval between S1 and OS correlates with increased severity. If the interval between the opening snap and the S1 sound is less, it will correlate with more severity, increased severity. Late and highly specific sequel of rheumatic fever. It is highly specific of rheumatic fever. Okay, and chronic mitral stenosis can lead to LA dilatation, pulmonary congestion, atrial fibrillation, Ortner syndrome. Ortner syndrome is hoarseness, dysphagia, because the enlarged left atria or dilated left atria is compressing the left recurrent laryngeal nerve, and it is compressing the esophagus as well. Okay. And hemoptysis and right heart failure. Okay, it causes mitral stenosis causes right heart failure. It never causes left heart failure. Okay, because this is the heart, this is the mitral stenosis. The blood is, this is pulmonary vein, and this is pulmonary artery incoming. Okay, so the blood is pooled into the left atria. Because of the left atrial dilatation, it will cause more blood congestion in the lungs. There is more blood congestion in the lungs, which will revert back to the pulmonary artery, which will go to the right atria, eventually into the right ventricle. Okay. So that will that also causes hypertrophy of right ventricle and right heart failure. And the opening snap is due to the abrupt halt in leaflet motion in diastole after rapid opening due to fusion of leaflet tips. Okay. As the mitral valve is stenosed, okay, the left atrium is trying to push blood from left atria into the left ventricle, right? But as the mitral valve is stenosed, it is not going to open up completely. So after some point of time, after some point of diastole has occurred, there is abrupt halt of leaflet motion, there is abrupt halt of the mitral valve, because it is stenosed, it cannot open up furthermore. So that will cause halt in leaflet motion in diastole after rapid opening due to fusion of leaflet tips, and the left atrial pressure is higher than left ventricular pressure during diastole. And PDA, now patent ductus arteriosus, there is a continuous typical machine-like murmur, which is best heard at the left infraclavicular area. Like this area is new. Only this murmur of this condition is heard at the infraclavicular area, and it is loudest at S2. Okay. And it is often due to, there are just two causes: congenital rubella and prematurity. Okay. And this is a very harsh sounding murmur. It is continuous machine-like murmur, like a machine gun-like murmur. Okay. Now we'll see the myocardial action potential. So first you have to keep in mind that sodium and calcium always comes inside the cell, and potassium always leave the cell. Okay. Sodium, calcium always comes in, potassium always goes out. And there's another mnemonic that I've made. It's in Hindi, like naak ka kaam. So it goes like naak ka kaam. Sodium, potassium, calcium, again potassium. Okay. So now there are 4 phases of myocardial action potential. That is, there are 5 phases like 0, 1, 2, 3 and 4. So now you just have to arrange those numbers: 0, 1, 2, 3 and 4. 3 and 4 both are due to potassium. Now it's just very simple for you. Now you have to just keep in mind these two things, that sodium and calcium always comes inside the cell and potassium always goes outside the cell. And nak ka kam 0, 1, 2, 3, 4. Okay, let's write those here, like sodium, potassium, calcium, potassium, potassium. Okay, now let's just read this thing. So phase 0, these are color coded too, like phase 0 is green, so it is for sodium is green. And we saw that sodium always comes in and calcium also always comes in, so there will be sodium channels opening up in phase 0, which will result in sodium coming in. And if the sodium is a positive ion, if it's coming inside the cell, there will be depolarization of that cell. There will be positive charge inside that cell. So from minus 85 millivolt, we are going to positive side, right? So that is phase 0. Now during phase 1, the phase 0 is called rapid upstroke and depolarization. Initial depolarization, resting potential. Okay. Phase 0 is called rapid upstroke and depolarization. Depolarization because we are going from negative charge to positive charge, and it is a rapid upstroke, like it is inclined, it is 90-degree inclined, it is very rapid. Okay. Then there is phase 1. It is initial repolarization. Now the voltage gated potassium channels begin to open, and we saw that potassium always goes out of the cell. And now if the potassium channels are open, the potassium will leave the cell, so there will be little bit of decrease in the positive charge that was brought about by the sodium channels, so the graph will dip. Okay, that is phase 1 due to potassium channels, voltage gated potassium channels. Now the phase 2 is the calcium influx through voltage gated calcium channels balances potassium efflux. So potassium is still going out, okay, but now the calcium channels will also open up, and what we saw is called calcium always comes inside the cell. So during phase 2, the potassium keeps going out, but now the calcium starts coming in, so it will somewhat balancing the charges, right? The potassium is leaving, calcium is entering, so it will balance the gradient across the membrane. So it is called a plateau stage. Okay, this is plateau stage, but it's in the positive side, right? Because the sodium is also inside the cell, now calcium is also inside the cell, and just potassium has left, so there is still positive charge inside the cell, so it is on the positive axis. Okay. Calcium influx triggers calcium release from sarcoplasmic reticulum and myocyte contraction. Okay, that is called excitation contraction coupling, and it is called calcium induced calcium release, which is very unique to the myocytes. Okay, that does not occur anywhere else. It does not occur in skeletal muscle. We'll see that later on. Now during the phase 3, nak ka kam. Okay, now during phase 3 and phase 4 is just about potassium. Now during rapid repolarization, that is massive potassium efflux, the potassium channels are still open, and potassium always goes out of the cell. So massive potassium efflux due to opening of voltage gated slow delayed rectifying potassium channels. Oh, such a long name. Voltage gated slow delayed rectifier potassium channels and closure of the voltage gated calcium channels. So the calcium channels that have been opened up in the phase 2 now gets closed, and now there is just potassium channels open, which will cause potassium efflux, massive potassium efflux, which will throw the graph from the positive to the negative axis, that is called repolarization. So phase 3 is repolarization, rapid repolarization. And during phase 4, that is all of the potassium has now left, and now the potassium channels are still open, so they are still permeable, so which maintains the resting potential. So resting potential is due to the high potassium permeability through potassium channels. Okay. And these phases occur in all of the cardiac myocytes, but it does not occur in SA and AV node. Okay. Now, as I talked earlier, that there is calcium induced calcium release from sarcoplasmic reticulum, from SERCA. It is unique to the myocytes. Now we'll compare myocytes to the skeletal muscle cells. Okay. Now cardiac muscle action potential has a plateau due to calcium influx and potassium efflux. Okay. Now cardiac muscle contraction requires calcium influx from extracellular fluid to induced calcium release from sarcoplasmic reticulum. That is called calcium induced calcium release. And cardiac myocytes are electrically coupled to each other by gap junction. If these are two myocytes, there is a gap junction. Okay, and they are electrically coupled. Now pacemaker action potential. Let's just highlight this amazing mnemonic that I've made. Now pacemaker action potential. In pacemaker action potential, there are just 3 phases, like phase 0, phase 3 and phase 4. And phase 0 is depolarization in both of them. Here it was phase 0 depolarization because sodium channel is opening and sodium influx. Okay, so phase 0 is also depolarization here. So let's just write that down. Phase 0 is depolarization in both. Okay. And pacemaker action potential is obviously occurs in the pacemakers that are SA and AV node. And the key differences from ventricular action potentials include phase 0, that is upstroke. Phase 0 is due to the calcium channels, phase 3 is due to the potassium channels, and phase 4 is due to all of them. So there is not really any mnemonic needed here. You just have to understand this, that in phase 0 there is L-type calcium channels opening. These channels are important, that it is L-type of calcium channels, it is opening, which causes influx of calcium, which is causing the depolarization. So phase 0 is upstroke, opening of voltage gated calcium channels. The fast voltage gated sodium channels are permanently inactivated because of the less negative resting potentials of these cells. Okay. Results in a slow conduction velocity that is used by the AV node to prolong transmission from atria to ventricles. Okay. So the membrane potential of the pacemakers is just around here, -60. We saw the negative potential of the myocardial action potential was -85. So what they are trying to say is, in pacemakers the negative potential is not that negative as compared to the myocytes. It is less negative resting potential of these cells. Okay. So because it has a less negative resting potential, we don't need the fast gated sodium channels. And as there are no fast gated sodium channels, there is delayed opening and closing and delayed influx and efflux of other ions apart out of the sodium channels, right? If there are voltage gated sodium channels, the conduction would have been very fast, but we don't want that fast conduction. We need slow conductions in pacemaker, uh, because it is used by the AV nodes to prolong transmission from the atria to ventricle. Because there is slow conduction, slow channels in pacemaker action potential, there is the AV node takes longer time to transmit the impulses from atria to ventricle, and phase 1 and 2 are absent. Phases 1 and 2 are absent in the pacemaker potentials. Okay, phase 1 and 2 in the myocytes for initial repolarization by the potassium, and then plateau by the calcium and potassium both. Okay, now the pacemaker action potential is rather very simple. It's initially there's depolarization, then there's just repolarization. No plateau stage, no initial repolarization, that is phase 1 and 2. They are both not present here. This is just depolarization, this is repolarization. And you have to keep in mind that there are no sodium channels in pacemakers. So what two other ions are left? Calcium and potassium. Only these two ions are left. You have to do depolarization and repolarization with only these ions, not sodium. So now, as I've said earlier, that potassium always goes out of the cell and calcium and sodium always goes inside the cell. So now if we want to perform depolarization, what is your ion of choice? We want to make the inside of the membranes positive, that is called depolarization. So we have to take a positive ion, travel from outside to inside. And what is the ion that travels from outside to inside? It is calcium and sodium, but sodium isn't there. There is just calcium available. So calcium has to travel from outside to inside of the cell in order to perform depolarization of the cell. So it is because of the depolarization. And repolarization is making the inside of the cell more negative again. And if we can make the inner inside of the cell negative only because if we take a positive ion inside of the cell out. And which ion has that capabilities? Only potassium can travel from inside of the cell to the outside of the cell. So in order to do repolarization, we have to use potassium. The potassium will travel outside of the cells. Okay, so here is repolarization. There has to be inactivation of the calcium channels and increased activation of the potassium channels. So there will be increased potassium efflux. Okay. Phase 4, it is slow spontaneous diastolic repolarization due to the funny currents. IF channels, funny current channels, responsible for slow mixed sodium inward. See, sodium is inward, potassium is always outward current, and different from I sodium channels in phase 0 of the ventricular action potential, accounts for the atomicity of sodium SA and AV nodes. So what is the reason behind the atomicity of the SA and AV nodes? That we do not have to provide any impulse to the SA and AV nodes. It beats on its own. It is generating impulses on its own. The reason for that is the slow mixed sodium inward and potassium outward current. The reason for that is funny current channels. So due to funny current channels, that is IF, there is sodium inward and potassium outward current. Okay. The slopes of phase 4 in the SA node determines the heart rate. Okay. Like acetylcholine and adenosine decrease the rate of diastolic depolarization and decreases the heart rate, while catecholamines increases the depolarization and heart rate. And sympathetic stimulation increases the chance that IF channels are open and thus increase the heart rate. Okay, it's just that acetylcholineadenosine will decrease the heart rate, and catecholamines by sympathetic stimulation will increase the heart rate. It's just that simple, and this slope determines the heart rate. Okay, how fast this slope is. If this slope is like really steep and really fast, all of the pacemaker potential will occur quickly. That will increase in the heart rate. Okay, and if this slope is not very inclined and it is longer, it will take more time to perform the whole pacemaker action potential, and it will decrease the heart rate. Okay. Also, there's a mnemonic that I've made. It's called Kalki. So Kalki is a presumed next avatar of Vishnu. So this mnemonic is after that. Kalki. The spelling is really different from the one you'll see on the web. So phase 0, phase 3, and phase 4. So phase 0 is calcium L-type channels. Phase 3 is potassium, and phase 4 is IF currents due to the IF funny currents. Okay, so this is a mnemonic that might help. Electrocardiogram. So conduction pathway is from SA node to the AV node, SA node to the first atria, then to AV node, then the bundle of His. Bundle of His is the common bundle between the ventricles. From that, the current is separated into the right and left bundle branches. From bundle branches, it travels into the fibers, that is Purkinje fibers, then into the ventricular wall. Okay. And the left bundle branch divides into left anterior and posterior fascicles. Now, SA node is located at the junction of right atria and superior vena cava. This is the right atria, this is the superior vena cava, this is inferior vena cava. So SA node is present somewhat here. Okay. Located at the junction of right atria and superior vena cava. Pacemaker inherent dominance with slow phase of upstroke. Okay, and SA node has a slow phase of upstroke. I didn't really get it. Okay, moving on, the AV node is located in the posterior inferior part of the interatrial septum. If this is the interatrial septum, AV node is located here, somewhat here, in the posterior and inferior part of interatrial septum. The blood supply usually is from the RCA. Now, if during myocardial infarction the right coronary artery is obstructed, it will result in the infarction of the wall containing the AV node. So that will cause bradycardia, because now the impulses can't travel fast enough from SA node to atria to AV node. There will be slowing of the heart rate that will cause bradycardia. Okay, and 100 millisecond delay allows time for ventricular filling. Because the AV node is slow, there is delay from SA node to it reaches ventricles, and that delay is 100 milliseconds or 0.1 second. The pacemaker rates are SA node, then AV node, then bundle of His, and then Purkinje and ventricles. It is in the chronological order of the impulse travel, the conduction pathway. Like first the conduction is from SA node, then to AV node, then bundle of His, then to Purkinje, and then to ventricles. And speed of conduction is highest in his Purkinje fibers, atria, then ventricle, then AV node. Okay, that is really random. Like the speed of conduction is the highest in his Purkinje fibers, then in atria, then again in the ventricles, and then again the AV node. So here is his Purkinje. Okay, first is his Purkinje, then second is again atria, then third is again ventricles, and the fourth is again AV node. So it is like this. Okay. And P wave stands for atrial depolarization. PR interval. So PR interval is from starting of P to starting of QRS. Time from start of the atrial depolarization to start of ventricular depolarization. That is why it's called an interval. It is normally 120 to 200 milliseconds. So it is around 4 to 5 small boxes, small squares. QRS complex is standing for ventricular depolarization, and it is normally less than 100 milliseconds, that is less than 2 to 3 small squares. You need to remember the QRS complex mostly, because you have to figure out if it's a broad QRS complex or a narrow QRS complex. Narrow QRS complex is called normal, and if it's a broad QRS complex, you might be facing the ventricular tachycardias and all. And the QT interval is ventricular depolarization. This is QT interval, starting from ventricular depolarization to the end of ventricular repolarization. Okay, it shows the mechanical contraction of the ventricles. This QT interval comprises of QRS complex, the ST segment, the T wave, all of them. So everything related to ventricle, its depolarization, its repolarization, all of that is in the QT interval. Now T wave stands for ventricular repolarization. Okay, T wave inversion may indicate ischemia or recent MI. Okay, it can also indicate many other things like hypokalemia, Brugada syndrome in some leads. And J point is the junction between the end of QRS complex and the start of ST segment. So here is the J point. And ST segment is isoelectric, and even if it's not isoelectric, it is ST elevation. It is ST segment elevation. Even if it's just 0.1 even if it's just one small square elevation, if it's not isoelectric, it is ST segment elevation. And U wave is prominent in hypokalemia. Okay, think hypokalemia and bradycardia. Okay, so here is SA node, AV node, SA node to atria, then to AV node, then to bundle of His, which is a common bundle, then left and right bundle, then Purkinje fibers, these are Purkinje fibers, and then to ventricular wall. And on the left atria, there is another bundle called Bachmann bundle, and the left bundle branch divides into left anterior fascicle and left posterior fascicle as well. Another atrial natriuretic peptide. ANP and BNP. BNP is brain natriuretic peptide, which is just a misnomer, I think. Atrial natriuretic peptide is released from the atrial myocytes in response to increased blood flow and increased atrial pressure. It acts via cGMP. Okay. So what it actually does is ANP and BNP and naziretide, they all activate guanylate cyclase. This is guanylate cyclase, and activating guanylate cyclase increases the conversion of GTP to cGMP. Now what cGMP does is it causes relaxation of the smooth muscle. Okay, let's just remember that, because the cGMP activates the MLC phosphatase. Okay, we'll see that further in pharmacology. It activates the MLC phosphatase, so that dephosphorylates the myosin and actin chains, so that causes relaxation in the smooth muscles. Now if there is relaxation in the smooth muscles, it will cause vasodilatation and it will cause sodium reabsorption at the renal collecting tubule, because now the renal collecting tubule is also dilating, so it will reabsorb all the sodium, and it dilates efferent renal arterioles and constrict the efferent renal arterioles, promoting diuresis. So if this is kidney, this is efferent, this is coming in, and this is efferent leaving out. So it dilates the efferent arterioles and constricts the efferent arterioles. So the GFR will increase. There is more blood going into the kidneys and less blood coming out of the kidneys. It will increase the diuresis, which will eventually promote diuresis, contributing to the aldosterone escape mechanism. Okay. And it is increased in response to increased blood volume and atrial pressure. So which condition has this? Heart failure has increased blood volume. Like if it's a systolic dysfunction, it cannot eject more blood, so there will be increased blood volume in the atria and ventricles as well. So that will also cause increase in atrial pressures, and increase in atrial pressures causes release of ANP from its atrial myocytes. Okay, and BNP, it is released from the ventricular myocytes in response to increased tension. Okay, this was released due to the increase in blood volume and atrial pressure, and BNP is released as a result of increased tension. Similar physiological action to ANP with longer half-life. BNP blood test used for diagnosing heart failure, it is a very good negative predictive value. What is the meaning of very good negative predictive value? That if BNP is normal, you have a very less chances of having heart failure. Okay, so if BNP is normal, there is no heart failure. And nowadays there is a test called pro-BNP, which is used to diagnose heart failure. Okay. Now the baro and the chemoreceptors. So basically there are two sites of baro and chemoreceptors. One is the aortic arch and second is the carotid sinus body. Both of them have chemoreceptors and the baroreceptors in them. And the aortic arch transmits via vagus nerve to solitary nucleus of medulla, and carotid sinus transmits via glossopharyngeal nerve to solitary nucleus of medulla. So the end site of both of them is solitary nucleus of medulla, and they both respond to the changes in BP. Okay. So here you can see the aortic, from the aortic arch, impulses travel through vagus nerve, that is 10th cranial nerve, and from the carotid sinus the impulses travel through glossopharyngeal nerve, which is the 9th cranial nerve, to the solitary nucleus. This pathway is efferent because it is going into the CNS. Okay. Now we'll see the chemoreceptor part of both of these receptors. Like chemoreceptors are peripheral and central. The carotid and aortic bodies are both peripheral chemoreceptors, and it is stimulated by increased PCO2, decreased pH of blood, which is acidosis, and hypoxia. So hypoxia, acidosis, and hypercapnia. And central chemoreceptors are stimulated by changes in just pH and PCO2 of brain interstitial fluid, which in turn are influenced by arterial PCO2, as hydrogen ion cannot cross the blood-brain barrier. So arterial carbon dioxide is what eventually will influence the central chemoreceptor firing. Okay, and do not directly respond to hypoxia or PO2. The central chemoreceptors becomes less responsive with chronically increased PCO2, that is in COPD. So increased dependence on peripheral chemoreceptors to decreased hypoxia to drive respiration. So in the later stages of a COPD patients, even if there is hypercapnia in its body, it is the COPD has an expiration problem, right? It is obstructive lung disease. So in the obstructive lung disease, there is problem with expiring the air. So what happens if you can't expire the air properly? The amount of carbon dioxide increases in your blood. But the chronically ill patients of COPD, its central chemoreceptors do not respond to the increased carbon dioxide in the blood. So now even if there is increased carbon dioxide in the blood, it will not increase the rate of respiration in those patients. Okay, that is bad. So now to compensate that, now the peripheral chemoreceptors have to take charge and detect the hypoxia that is in the patients of to detect the hypoxia and the hypercapnia that is in the patients of COPD to drive the respiration. Okay. Now baroreceptors. What baroreceptors actually does is it causes hypotension. Just remember this. Hypotension that can also cause syncope. Okay. Now let's see a case where there is already hypotension in the body. If there is hypotension, the arterial pressure obviously is decreased, that is hypotension. There is decreased stretch of the wall of the arteries. So what it will do is it will inhibit the baroreceptor firing, because what baroreceptor was doing is baroreceptor causes hypotension, right? I told you to remember this. The baroreceptor causes hypotension. So now if there is already hypotension, the baroreceptors will be inhibited. And if the baroreceptor, that is the efferent path, this is the efferent pathway, is inhibited, the efferent pathway will get more excited. The efferent pathway will be activated. And what is the efferent pathway? Efferent pathway is of sympathetic chains, of sympathetic nerves. So it will activate the sympathetic firing. And what the sympathetic system does, it causes vasoconstriction, increased heart rate, increased contractility of the heart, increased BP. Okay, so that is how it works. And it is important in response to hypovolemic shock. It is through this mechanism that there is increased heart rate and increased BP in the initial stages of hypovolemic shock. Okay. Now carotid massage. Carotid massage occurs when someone grabs you by your neck or they are massaging your neck. There will be MCQs where it is stated that someone was massaging the neck or something like that. The barber was massaging the neck. The masseuse was massaging the neck area. And that causes syncope in the patients. So why is that so? So now we'll see why is that. So the carotid massage increases the carotid sinus pressure. Here is the carotid sinus baroreceptor. If you are going to massage that area, there will be more firing of the baroreceptors, and if there is more firing of that baroreceptors, it will cause hypotension in that patient, which in turn will cause syncope in that patient. Yeah. So there is increased afferent baroreceptor firing, increased AV node refractory period, decreased heart rate, decreased cardiac output also leads to peripheral vasodilatation. It can cause pre-syncope or syncope, and exaggerated in underlying atherosclerosis. Okay. So we are vasodilating the peripheral arteries, so we are decreasing the preload, and we are also decreasing the cardiac output. Now if the patient already has atherosclerosis, or if the patient is older, the condition is already worse due to atherosclerosis, that there is an obstruction of the arteries, and now if we are even more decreasing the cardiac output, it will be exaggerated. That scenario will be more exaggerated in atherosclerotic or older patients. Okay. And components of Cushing reflex, it is triad of hypertension, bradycardia, and respiratory depression. Okay. How does that occur? So when there is increased intracranial pressure during due to the head trauma or something like that, there is increased intracranial pressure. Okay. And due to increased intracranial pressure, the arterioles are getting compressed in the brain if the arterioles are getting compressed, it will cause ischemia, and due to ischemia there is less PO2, increased PCO2, and decreased pH. Okay, there is hypoxia during ischemia, right? So that will cause activation of the stimulation of the central chemoreceptors. Now what central chemoreceptors will do is it increases the BP. Okay. And if now the BP is increased in the small vessels of the brain, that will cause the stretch in those vessels, right? And if there is stretch in those vessels, it will cause firing of the baroreceptors. We saw that here, that increased stretch causes firing of baroreceptors. So in this case, in the case of head trauma where intracranial pressure has rise, both of the receptors, the chemo and the baroreceptors, are fired. And what is the effect due to them? That the chemoreceptors will increase the BP, that will cause hypertension, and due to firing of baroreceptor, there will be bradycardia or respiratory depression. Okay. I'll write that down for you too after we read through this. There is increased intracranial pressure, which constricts arterioles. It causes cerebral ischemia. It causes increased PCO2 and decreased pH, and central reflex sympathetic increasing perfusion pressure, which is causing hypertension, cause increased stretch, increased peripheral reflex baroreceptor, induced bradycardia, and respiratory depression. Let me write that down again for you. So there is increased intracranial pressure, the arterioles are constricted, ischemia. In ischemia, what happens is there is hypercapnia, acidosis, and hypoxia. That will activate central sympathetic chemoreceptors. Now the sympathetic pathway will increase the BP. The increased BP will cause will cause increased stretch in vessels. Increased stretch will activate the baroreceptors. So the activated baroreceptors will now decrease the heart rate, decrease the cardiac output, and cause respiratory depression. Okay. And these comprises of the Cushing reflex. Increased BP, decreased heart rate, and respiratory depression are the three components of Cushing reflex triad. Now the normal resting cardiac pressures. What are the cardiac pressures? The most important is this, the pulmonary capillary wedge pressure, through which we can know that if the patient is in pulmonary hypertension or not. Okay, and it is also good because it is pulmonary capillary wedge pressure, that same pressure will be reflected into the left atria. Okay, except in mitral stenosis when PCWP is increased than left ventricle. Okay, the PCWP is left atrial pressure, and we know that in mitral stenosis left atrial pressure is higher than the left ventricular pressure. So in mitral stenosis too, the pulmonary capillary wedge pressure can increase. In pulmonary hypertension too, it can increase. Okay. And it is measured by the pulmonary artery catheter, that is Swan-Ganz catheter. It is put into the pulmonary artery, not the pulmonary vein. Now, normally the pulmonary capillary wedge pressure PCWP is 4 to 12 mmHg. So the left atrial pressure is also less than also less than 12 mmHg. But in the left ventricle, the systolic pressure is 120, because the left ventricle has to have more pressure than the aorta. And what is the pressure, normal pressures in the aorta, in the arterial system? It is 120 by 80, right? So left ventricle has to have at least 120 mmHg of systolic pressure. Okay, the diastolic, we don't care about the diastolic pressures because we have to eject blood during the systole, right? So systolic blood pressure has to be high. So it is 120, but diastolic is still less than 12. Okay. So the lowest pressure in the heart is in the right atrium. It is less than 5 mmHg. And in right atria, it is 25 by less than 5 mmHg. In right ventricle, the pressure increases a little bit because it has to push blood into the pulmonary arteries, and to push blood into the pulmonary arteries, it needs a little bit of systolic blood pressure as well. So it is 25 by 5. It is still very, very less than the systolic pressures needed in the left ventricle to push blood into the aorta. Okay. So if this is 25 by 5, and it is pushing blood into the pulmonary artery also will have somewhat similar blood pressure, that is 25 by 8. Okay. Now, how does autoregulation works? Okay. How blood flow to an organ remains constant over a wide range of perfusion pressure. So even if perfusion pressure increase or decrease, how does the organ react to it? We'll see that. And in lungs, the hypoxia causes vasoconstriction, which is very unique to lungs, because in all the other organs, hypoxia causes vasodilation in order to get more perfusion from the arteries. But in lungs, it is causing vasoconstriction. Now we'll see how. Okay. If this is a lung, and these are the arteries supplying the lung. Now if there is ischemia or infarct here, there is pulmonary embolism here, the blood can't go through this, okay, and the lungs has lobes, right? Then there are segments of blood. So if there is embolism here, what lungs will do is it will vasoconstrict that vessel, okay. It will vasoconstrict this vessel. So now if it has vasoconstrict this vessel, even less blood is coming here. But if there is less blood coming here, it's okay if there is less blood coming in here because it has embolism here, right? So the lung is saving the blood for the other well perfused segment, okay. This is a well perfused area. So now if this vessel is getting vasoconstricted, all of the blood that it was eating up can be used to perfuse all other well perfused area, okay. It's as simple as that. The pulmonary vasculature is unique in that the alveolar hypoxia causes vasoconstriction, so only well ventilated areas are perfused. These are the well ventilated areas, so now they will get more blood because the infarcted area is now not getting any blood. But in other organs, the hypoxia is causing vasodilation. In heart, the local metabolites are nitric oxide, carbon dioxide, and hypoxia. They all will cause vasodilation in the coronary arteries. In brain, carbon dioxide is the only factor, okay, because we earlier saw that hydrogen ion cannot cross the blood-brain barrier. So its receptors are only dependent, its chemoreceptors are only dependent on the carbon dioxide levels, okay. Kidney has myogenic and tubuloglomerular feedback. These are stretch reflexes of the afferent arterioles. And skeletal muscle has local metabolites during exercise. During exercise, these all metabolites are released in the body, which will cause vasodilation in the body. These metabolites are chalk, like carbon dioxide, hydrogen ion, adenosine, lactate, and potassium. And at rest, there is sympathetic tone in the arteries. Okay. Blood regulation is maintained by the sympathetic tone of arteries in skeletal muscle. And in skin, the blood flow is regulated by sympathetic vasoconstriction. It is most important mechanism for temperature control. If the temperature is rising and the blood vessel is in the normal position, normal tone of the blood vessel, and if the temperature is rising, there will be sympathetic vasoconstriction, okay. So it will cause cooling of the skin, so temperature gets normal. Okay, last topic of physiology, that is capillary fluid exchange. If you want to memorize the formula, it's up to you. You can just memorize it like PCPI, pi CPI. Okay. PCPI, pi C, pi I. Now you just have to figure out what is P and what is pi. So P is the hydrostatic pressure and pi is, we all know that it's the oncotic pressure. Now if it's C, it is capillary, and if it is I, it is interstitial. Okay. So what does P stands for? It is hydrostatic pressure of the capillaries minus hydrostatic pressure of the interstitium minus the oncotic in bracket oncotic pressure of the capillaries and oncotic pressure of the interstitium. Okay. Now there are a few thumb rules that I want you to understand. They are silly, they are made up, but it is that will help you understand this and remember it for long. Like, fluid stays where oncotic is, and fluid does not stay where hydrostatic is. So hydrostatic pressure is always going to push the fluid out of it, and oncotic pressure is always going to pull fluid into it. So now let's see this PC, capillary hydrostatic pressure. It is hydrostatic pressure, so it will push fluid out, but out of where? It is capillary hydrostatic, so it will push fluid out of the capillary. Okay. PI, it is interstitial hydrostatic, so it will push fluid out. Okay, but out from where? It is interstitial space. So what it actually means is pushing fluid out of the interstitium, so into the capillaries. Okay, I don't need a separate diagram. Into the capillaries. This is interstitium, this is capillaries. Now plasma oncotic pressure. So oncotic always pulls fluid. Okay, but pulling fluid into what? It is plasma oncotic. So plasma is in the capillaries. So pi is oncotic. CI. Plasma oncotic is pulling fluid into the capillaries. Interstitial fluid oncotic pressure. Oncotic is pulling fluid in. Pulling fluid in where? It is interstitial oncotic pressure. So it will pull fluid out of the capillaries. Okay. So now we have two forces that is pushing fluid inside the capillaries, and two forces that is pulling fluid out of the capillaries. Okay. What are the forces that is pushing fluid into the capillaries? So the two forces are interstitial hydrostatic pressure, that is pushing fluid into the capillaries, and plasma oncotic pressure. These both forces, and these forces are pulling fluid out of the capillaries. Now we will see this formula and what does it mean. So the fluid flow is the net fluid flow from outside to inside of the capillaries. It is of that fluid flow. What is the flow of the fluid that is coming into the capillaries? So in order to figure that out, we have to calculate the pressure to keep fluid out minus pressure to keep the fluid in. Okay. So PC and PC and PI will account to the pressure that is keeping the fluid out. PC is capillary hydrostatic pressure, that is pushing the fluid out of the capillaries, and PI is pushing the fluid into the capillaries. So it is the ultimate pressure that is pushing fluid out of the capillaries. PC is a higher quantity than PI, and pressure to keep the fluid in is pi C minus pi I. Plasma oncotic pressure, that is pulling the fluid inside the capillaries, that is a higher quantity than the pi I. Okay. And Kf is a capillary permeability to fluid, and the sigma is a reflection coefficient. It is measurement of capillary impermeability to protein. So if Kf increases, the permeability will increase, and if the sigma increases, the capillary impermeability to proteins will decrease. Now we'll see how the edema occurs. So edema is fluid outflow into the interstitium. The first case is increased capillary pressure in heart failure. So what happens in heart failure is there is increased blood volume in capillaries. So if there is increased blood volume in capillaries, the PC is going to increase. Okay, so this whole term is going to increase, and if this term increases, the flow rate is going to increase, and the fluid will come out of the capillaries. Second is capillary permeability. So Kf was capillary permeability and sigma was capillary impermeability. What are the cases when capillary permeability or the Kf can increase? When there are toxins, infection or burns which can cause endothelial damage of the capillaries, right? So it will increase the capillary permeability. So second case is increasing the Kf. So again this whole thing increases and the flow rate increases. Third is interstitial fluid oncotic pressure. The oncotic pressure in the interstitium is increasing. When does that occur? It occurs during the lymphatic blockage. Now if this is the vessel and these are the lymph nodes, lymphatic channels that are draining it, okay, but now if there is lymphatic blockage, okay, there will be increase in the oncotic pressure, right? Because oncotic pulls fluid. The lymphatic channels were pulling fluid out, but now there is lymphatic blockage. So the oncotic pressure inside these lymphatic channels are going to increase. And when did this lymphatic pressure channel increased? During the lymphatic blockage. When there was a blockage in the lymphatic channels, it increased. It caused increase in the interstitial fluid oncotic pressure. So this is the term that is increasing. And if you know mathematics, if you increase this term, this whole bracket is going to decrease, and if this whole term is going to decrease, there will be increased flow rate, right? Because we are subtracting this term from this term. Okay. And the last is decreased plasma proteins, like in nephrotic syndrome, liver failure, protein malnutrition. What does this cause? So the oncotic pressure in the capillary is due to the proteins, right? Proteins account for the most oncotic pressure, which is the pi C. And oncotic pressure in the capillary is pi C. So now if there is less protein, like in nephrotic syndrome, liver failure and protein malnutrition, the pi C is going to decrease. And if this term is going to decrease, this whole bracket is going to decrease and the flow rate is going to increase. which will cause edema. Okay. So PC is the hydrostatic pressure inside the capillaries. It can be caused by increase in the blood volume, like in, let me change the color. Okay, it can be caused in heart failure. Okay, then increased permeability of the capillaries, which can be caused by burns, infections, trauma. Okay, then there is increased interstitial oncotic pressure. There is more pressure of pulling the fluid out of the capillaries, that is increased interstitial oncotic pressure. And what channels pulls fluid out of the blood vessels? Those are lymphatic channels. And if it is pulling the fluid out, it is called oncotic pressure, interstitial oncotic pressure. When does that increase? During lymphatic blockade. And when does this pi c, that is oncotic pressure inside the capillaries, when does that decrease? Decreases when the proteins inside the capillaries will decrease. Okay, when does that occur? It occurs during nephrotic syndrome, during liver failure, during protein malnutrition. Okay, so we are done with the physiology part. Next we'll see the pathology section. So congenital heart diseases. First we'll see the right to left shunts. In right to left shunts, there is early cyanosis, and the babies born with right to left shunts are also called blue babies because of the early cyanosis, and they can be diagnosed prenatally or they became evident immediately after the birth. So there is cyanosis immediately after the birth, and usually they require urgent surgical treatment or maintenance of a patent ductus arteriosus. So if the ductus arteriosus is present and we know that there is another right to left shunt defect, we often keep the ductus arteriosus open. And how do we keep them open? By administering prostaglandins E1 and E2. PGE1 and E2 keeps the PDA open. Okay. And the right to left shunts consist of 5 conditions, all starting with T. Truncus arteriosus, so it one vessel, so it's first and it has one vessel. So truncus arteriosus basically means that there is just one vessel, that is truncus arteriosus, which has not separated into aorta and pulmonary artery. Okay. And second is transposition of great arteries. So there is a switching of the two vessels. It is two switched vessels. So aorta is leaving the right ventricle and pulmonary artery is leaving the left ventricle. Third is tricuspid atresia. Fourth is tetralogy of Fellow. And 5 is TAPVR, total anomalous pulmonary venous return. Yeah, it has 5 letters, so it's in the 5th position. So first, truncus arteriosus, persistent truncus arteriosus. So it fails to divide. It's pretty simple that the truncus arteriosus fails to divide into pulmonary trunk and aorta due to the failure of aorticopulmonary septum formation. So if this is truncus arteriosus, this is something like aorticopulmonary septum which spirals and then fuses with the endocardial cushion and forms the interventricular septum. Okay, so but there is failure of aorticopulmonary septum. Okay, so there's nothing like this, and this vessel remains patent. This remains as it is, and it is called truncus arteriosus. So when the patient does have a ventricular septal defect also, because as I told you that this aorticopulmonary septum fuses with the endocardial cushion and forms the interventricular septum. So now if there is no aorticopulmonary septum, there will be eventually a gap in the ventricles, in the interventricular septum, which is called the VSD. Okay. Second, transposition of great arteries. So in this, aorta leaves the right ventricle and pulmonary trunk leaves the left ventricle posteriorly. And separation of systemic and pulmonary circulation. Not compatible with life unless a shunt is present to allow mixing of blood, that is VSD, PDA, or patent foramen oval. So what happens is, if this is heart, this is LV, this is RV. So now, and this is lungs. Now what's the problem with this is pulmonary artery is leaving the left ventricle, right? So this is pulmonary artery leaving, and this goes to aorta. Right ventricle goes to aorta. But now pulmonary vein from lungs will enter left ventricle. Okay, and the inferior vena cava and superior vena cava will enter the right atrium. So you see there are two hearts have formed. There are two systemic circulation. This is a separate cycle and this whole is the separate cycle. Okay, so it is not compatible with life unless there is a shunt in between, right? So if there is a shunt in between, like VSD or PDA, okay, or the patent foramen oval, so it allows mixing of blood in systemic and venous circulation between the two separate circulations that have been formed. If there are any shunt present, the fetus can survive further. Okay, and due to failure of the aorticopulmonary septum to spiral. Okay. So first, this is the aorticopulmonary septum. It remains this way. Okay. It remains this way, and it does not spiral. And if it is not spiraling, the aorta and pulmonary artery is not formed in. The spiraling has not occurred, so both the vessels are not kept at the proper position they were meant to be. So if something like this happens, and then so this is now aorta and this is now pulmonary artery. So they both are formed at the wrong places. Okay. And okay, it is due to the failure of aorticopulmonary septum to spiral, and it has a classical egg on a string appearance on chest X-ray. This is a egg, this is a string. Egg on a string appearance. Without surgical intervention, most infants die within the first few months of their life. Tricuspid atresia. It is due to the absence of tricuspid valve and hypoplastic RV. And it requires both ASD and VSD for viability. So as there is no tricuspid valve and the tricuspid valve is absent, so the right ventricle has been atrialized. Okay, the whole right side of the heart has been converted into a large right atrium because the right ventricle is now also now hypoplastic. Tetralogy of Fellow. So there are four things happening in tetralogy of Fellow because it is tetralogy. So first is the pulmonary stenosis. Second is right ventricular hypertrophy, because obviously if there is pulmonary stenosis, there will be right ventricular hypertrophy. The third is overriding aorta. Okay. You can see that overriding aorta here. So what does overriding aorta means? It carries blood from both LV and RV. Okay. And fourth is ventricular septal defect. Okay. It is caused by the anterosuperior displacement of the infundibular septum. So there is this infundibular septum. It has moved anterosuperiorly. So it moves anteriorly and superiorly. Okay. And it is the most common cause of early childhood cyanosis. Pulmonary stenosis forces right to left flow across the VSD, and which causes right ventricular hypertrophy. And TED spells, often caused by crying, fever, exercise due to exacerbation of right ventricular outflow obstruction. So as there is pulmonary stenosis, so this is pulmonary stenosis. So if this pathway is closed, the blood is forced to go from the VSD through the defect from right ventricle into the left ventricle. Okay. And it causes right ventricular hypertrophy. There are TED spells also. It is caused by crying. Whenever child is crying, there is fever, exercise. Okay. And squatting increases systemic venous return, and decreased right to left shunt, and improves cyanosis. No, this is systemic vascular resistance, okay, not venous return. Okay. This is going into the systemic circulation. Now if squatting is performed, there is increased afterload, right? There is more mean arterial pressure, so that pressure will be reflected back into the left ventricle. So now left ventricular pressure has increased, so now the blood coming in from right ventricle into the left ventricle through the defect will be decreased. So it will result in decreased right to left shunt. There is less blood going from right to left, and that will improve the cyanosis, because now not much deoxygenated blood is going from right ventricle into the left ventricle and into the systemic circulation. So squatting improves cyanosis. Okay. And it is associated with 22q11 syndromes. I think that's DiGeorge syndrome. Okay. Yes, so total anomalous pulmonary venous return. On this, the pulmonary veins drain into the right heart circulation. Now the right heart circulation can be superior vena cava, the coronary sinuses, or hepatic veins, portal veins, inferior vena cava. Okay, it can be anything, and it is associated with ASD and sometimes PDA to allow for the right to left shunting to maintain the cardiac output. Now it's not given here, but there are three types of TAPVR. First is supracardiac. Second is cardiac, and third is, you guessed it right, infracardiac. So in supracardiac, the pulmonary veins drain into the superior vena cava. Superior vena cava is supracardiac, right? And in cardiac, the pulmonary trunk drains into the right atrium. And in infracardiac, the pulmonary trunk drains into the inferior vena cava, or hepatic vein, or portal vein. And there is also a fourth type, that is mixed. Okay. Now Epstein anomaly, it is the displacement of tricuspid valve leaflets downward into the right ventricle, artificially atrializing the ventricle, and it is associated with tricuspid regurgitation, accessory conduction pathways, and right-sided heart failure. Okay. So the right ventricle has atrialized, and it can be caused by lithium exposure in utero. Okay. So you have to, even I have to, we have to remember the causes of each of these conditions. Like they are the mostly asked questions, like what is the pathology behind all these conditions. So we will go over them once again. Like what is the reason of persistent truncus arteriosus? Let me just highlight all of them. Why does persistent truncus arteriosus develop? So it is due to failure of aorticopulmonary septum formation, like transposition of great arteries. It is due to failure of aorticopulmonary septum to spiral. Okay, this was due to the formation, and this is second one, transposition of great arteries, is due to failure of AP septum to spiral. Tricuspid atresia is due to absence of tricuspid valve. Tetralogy of Fellow, it is due to anterosuperior displacement of the infundibular septum. Okay, and which is the most important point in the tetralogy of Fellow, that there is pulmonary infundibular stenosis, and it is also the most important determinant for prognosis of TOF. And TAPVR is caused due to pulmonary veins draining into the right heart circulation. An Epstein anomaly is displacement of tricuspid valve leaflets downward into the right ventricle. Yeah. Now, the left to right shunts, they are acyanotic at presentation, and cyanosis may occur years later. It is not seen at birth. The cyanosis can be forming years later. Okay, and VSD is the most common, ASD is the second most common, and PDA is third most common. So this is a mnemonic, like right to left shunts, early cyanosis RL, and left to right shunts, later cyanosis LR. Okay. And ventricular septal defect, it is asymptomatic at birth. It may manifest weeks later or remain asymptomatic throughout the life. They mostly self-resolve. If it's a smaller defect, it can self-resolve. And the larger lesions may lead to LV overload and heart failure. Okay, because if the defect is large, there will be it will cause LV overload, because initially the blood is traveling from left to right shunt, right? So from left ventricle to right ventricle, but the blood from right ventricle goes into the pulmonary circulation, and it reverts back into the left atrium and eventually into the left ventricle. So it will cause left ventricular overload and heart failure eventually. And the O2 saturation is increased in right ventricle, because oxygenated blood from left ventricle is traveling into the right ventricle and pulmonary artery. And larger lesions can also lead to Eisenmenger syndrome later in life. Okay. And VSD is most commonly caused with fetal. It is a part of fetal alcohol syndrome. Now ASD. So ASD is the defect in the interatrial septum, and it is wide fixed split S2, right? We talked about this, that there is just one condition which has fixed split of S2, and that is atrial septal defect, because it does not depend on inspiration or expiration. There is an atrial septal defect, so blood will go from left to right side all the time, which will cause delayed closure of the pulmonary valve all the time, despite of inspiration or expiration. It does not depend on that. So this is S1, this is A2, this is A1, sorry, and okay, that is A2. A2, and there will be fixed splitting. Okay, if this is inspiration and this is expiration, there is fixed splitting. And the ostium secundum defects, most common. This point is important, that atrial septal defect is caused by the defect of ostium secundum to fuse, and usually an isolated finding. Ostium primum defects are rarer and usually occurs with other cardiac anomalies. Symptoms range from none to heart failure, and it is distinct from patent foramen ovale, which is due to the failed fusion. Okay. So in patent foramen ovale, it is due to the failed fusion of ostium secundum. So ostium secundum has failed to fuse in patent foramen ovale, but here it has fused, and then a defect has occurred into the ostium secundum, which is leading to atrial septal defect. And O2 saturation increases in RA and RV both. Here in VSD only, in RV the O2 saturation is increasing, and in atrial septal defect O2 saturation is increasing in both RA and RV, as well as pulmonary artery, and it may lead to paradoxical emboli. So systemic venous emboli use ASD to bypass the lungs and become systemic arterial supply. So why is it called a paradoxical emboli? Because the shunt is from left to right. So blood is traveling from left side to the right side, but it is a paradoxical emboli. So the emboli which has formed in the venous system, that is the right side, uses that shunt to travel into the left side. So it bypasses the lungs that way and enters the systemic circulation, and it becomes an arterial emboli, and it is associated with Down syndrome. Now patent ductus arteriosus. In fetal period, this shunt is right to left, because there is more pressure in the pulmonary system than in the aorta. So the shunt is right to left in utero. And in neonatal period, there is decreased pulmonary vascular resistance. We talked about this, that the amniotic fluid in the lungs is now replaced by oxygen after birth. So oxygen offers less resistance as compared to the amniotic fluid. So the pulmonary vascular resistance is decreased, and shunt becomes left to right. And as the shunt is left to right, okay, if the ductus arteriosus is patent, then the shunt becomes left to right, and it can cause progressive right ventricular hypertrophy, because eventually all the blood from the left side is filling up in the right side, and right ventricle has to hypertrophy in order to compensate for all the blood coming in. And it can also cause left ventricular hypertrophy, because eventually all the blood comes into the left ventricle, and it can also cause heart failure. It is associated with continuous machine-like murmur, a machine gun-like murmur, and patency is maintained by prostaglandins E synthesis and low O2 tension in utero. This is, we are talking about in utero. So in utero, the prostaglandins are secreted from the placenta, so it maintains the patency of the ductus arteriosus. But after birth, the prostaglandins E, as soon as the placenta is removed The prostaglandins also decreases, and as soon as the child starts breathing, the O2 tension has also decreased. An uncorrected PDA can eventually result in late cyanosis in the lower extremities. That is called differential cyanosis. Okay. So what is differential cyanosis? There is cyanosis in lower limbs and it is normal in upper limbs. Okay. Now let's see why that happens. It is explained very well in the Pathoma lectures. So I'm just stating that, like, if this is RV, this is LV, this is aorta, and this is pulmonary artery. Okay. So, and there's this patent ductus arteriosus, and after birth, if the ductus arteriosus is patent, that is the case of PDA, the shunt is from left to right. Okay. The subclavian artery and the brachiocephalic trunk leaves from the aorta before the ductus arteriosus is there. So the subclavian and brachiocephalic trunks, that are the blood arterial circulation to the upper limbs, right? So they leave proximal to the ductus arteriosus. So they are not affected by the shunting of the blood. Okay. So blood deoxygenated blood eventually enters the aorta distal to subclavian and brachiocephalic trunk, and that deoxygenated blood will go into the systemic circulation of the lower limbs. Okay. So there is just cyanosis in the lower limbs, which is called differential cyanosis. Okay. It is different from the cyanosis that occurs in the Eisenmenger syndrome that we will see now. Okay. And PDA is normal in utero and normally closes only after birth. Okay. Now Eisenmenger syndrome, it is uncorrected left to right shunt, rather it be VSD, ASD, or pulmonary PDA. Increased pulmonary blood flow leads to pathological remodeling of the vasculature. It increases the pulmonary artery hypertension, and right ventricular hypertrophy occurs to compensate. So the shunt now becomes right to left. Okay. Now let's see. Okay. This is right ventricular, left ventricular, aorta, and let's form a VSD here. So what was happening is, if there is VSD, it is left to right shunt, right? It's because the left ventricular pressure is higher than right ventricle, so blood is traveling from left to right side. But now over the years, what happens is, because there is so much blood coming into the right ventricle, the compensation occurs in the form of right ventricular hypertrophy and pulmonary artery thickening or stiffening or fibrosing or whatever you want to call it, but it's basically just thickening of pulmonary artery happening. So now, as the walls of right ventricles and the pulmonary artery is very thick, it reverses the direction of the blood. So now, as the walls are thick, it can have more contractility, and it pushes the blood from right ventricle again into the left ventricle. Okay. There is remodeling of the pulmonary artery and the wall of right ventricle occurring. So that will cause the shunt to become right to left when right ventricular pressure increases more than left ventricular pressure. And now, if there is right to left shunt, suddenly cyanosis will start occurring, but it is very late. Like if the patient is suffering from left to right shunt from the birth, this Eisenmenger syndrome will set in years later, like 15 to 20 years later. This RV hypertrophy and pulmonary artery remodeling will occur, which will cause shunt to go from right to left side, and which will cause late cyanosis. Okay, it will also cause clubbing due to hypoxia and polycythemia. Because there is hypoxia, polycythemia will occur as a result of it. And the age of onset varies depending on size and severity of initial left to right shunt. Yeah, it is different than the differential cyanosis we talked about. Okay, in differential cyanosis there was cyanosis in just lower extremities, but in Eisenmenger syndrome there will be cyanosis in the upper extremities as well as lower extremities. Okay, and the differential cyanosis occurs only in patent ductus arteriosus, but Eisenmenger syndrome can occur in ASD, VSD or PDA. Okay. Now coarctation of aorta. Coarctation is just the narrowing of aorta near the insertion of ductus arteriosus. Okay. Associated with bicuspid aortic valve, other heart defects and Turner syndrome. Hypertension in upper extremities. Lower extremities are cold with weak delayed pulses, and there is brachiofemoral delay. Brachiofemoral delay is the delay in the pulse of brachial artery and the femoral artery. So why does this occur? Why does there is hypertension in upper extremities and hypotension in lower extremities? Let's see that. This is the aorta. Now there is coarctation somewhere here. Okay. So the lumen has now become very narrower, as you can see here. The lumen has become very narrower. Okay. So blood gets filled all here, and there is just subclavian artery and brachiocephalic trunk here. Okay. Brachiocephalic trunk on the right side and subclavian on the left side. So what happens is there is increased blood flow into the subclavian arteries and the brachiocephalic trunk, which will cause hypertension in the upper limbs. But now as very less blood is able to travel through that coarctation into the descending aorta, there will be less blood going into the lower extremities, which will cause hypotension, and hypotension causes cold and weak and delayed pulses. So there is brachiofemoral delay. And with age, intercostal arteries enlarge due to collateral circulation. Okay, yeah. And proximal to the coarctation, okay, there are intercostal arteries which goes into the ribs. So as the blood is going more into the subclavian and brachiocephalic arteries, the blood will also go more into the intercostal arteries into the ribs. So those arteries enlarge over the time, and arteries erodes rib, and you can see the notched appearance of the ribs on chest x-ray. If the normal ribs are like this, it will now be seen like this. So this is notching due to the enlarged dilated in ICA. Okay. Complications include the complications include heart failure. There is increased risk of cerebral hemorrhage because of the Barry aneurysms. There can be aortic rupture. There can be positive infective endocarditis. Okay. So cerebral hemorrhage is because there is increased blood flow through the internal carotid artery and external carotid artery. Basically through the carotids, there is increased blood flow through the carotids into the brain. So that can lead to Barry aneurysms. Okay, in the circle of Willis, there can be aortic rupture because, as we saw, if this is the coarctation, there is so much blood here that can cause the aorta to rupture if the pressure increases more. And as there is so much blood here, it is causing somewhat stasis of blood, and whenever there is stasis of blood, it is prone to infection, and that can lead to infective endocarditis, right? And we saw that coarctation of aorta is near the insertion of ductus arteriosus. It is distal to aortic arch but proximal to PDA or D, just DA, ductus arteriosus. So it is near the insertion, it is proximal to DA. Okay. So prenatal alcohol exposure, that is fetal alcohol syndrome, it can lead to VSD, ASD, PDA, tetralogy of Fellow, anything. So these three are left to right shunts, and tetralogy of Fellow is right to left shunts. And congenital rubella can cause patent ductus arteriosus, pulmonary artery stenosis, or septal defects. Yeah. This is the most important one. With congenital rubella and prematurity, these are two reasons for PDA. These are two causes of PDA. And Down syndrome mostly leads to atrioventricular septal defect. So that is endocardial cushion defects, VSD, ASD. In infants of patients with diabetes during pregnancy, it can lead to transposition of great vessels. Let's just write it here. So diabetes during pregnancy can cause transposition of great vessels, truncus arteriosus, tricuspid atresia, and VSD. All of them are right to left shunts, and VSD is left to right shunt. Marfan syndrome can affect the aortic root, mitral valve, all of that. It mainly involves mitral valve and the parts of aorta. So if it's affecting mitral valve, it will cause mitral valve prolapse. If it is affecting the aorta, it can lead to aortic root dilatation, which will lead to aortic regurgitation. And due to dilatation of aortic root, it can also cause dissection and thoracic aortic aneurysm. Okay. So aneurysm, dissection, and regurgitation. And perinatal lithium exposure, this is very specific to the Epstein anomaly. Turner syndrome, it is a bicuspid aortic valve. It can cause bicuspid aortic valve and coarctation of aorta. So what were the causes of coarctation of aorta? There was Turner syndrome, then there was bicuspid aortic valve and other heart defects. Williams syndrome causes supravalvular aortic stenosis. Okay. There are two types of aortic stenosis, that is supravalvular and subvalvular. Okay. So it causes supravalvular aortic stenosis. 22q11 syndromes, that is, I think, Dijod syndrome. It leads to truncus arteriosus and tetralogy of Fellow. Okay. Yeah. In tetralogy of Fellow, we did saw that it is due to 22q11 syndrome, and in persistent truncus arteriosus can also be caused by 22q11 syndromes. Now hypertension. So what is hypertension? That it is BP is more than 130 by 80. Okay. The risk factors are age, obesity, diabetes, physical inactivity, high sodium diet, excessive alcohol, tobacco, family history. Family history is quite important, right? And incidence is greatest in blacks, then whites, and then last is Asians. And features 90% of the hypertension is essential and related to increased cardiac output or increased total peripheral resistance. Okay, and the remaining 10% is mostly due to secondary, due to renal or renovascular diseases such as fibromuscular dysplasia that has characteristic string of beads appearance. Like this is beads. Like this, if this is a string, there are beads on that string appearance of renal artery, and it is usually seen in adult females. Okay, so only 10% of the hypertension cases are due to secondary, and it is caused by renal or renovascular diseases such as fibromuscular dysplasia and atherosclerotic renal artery stenosis, or due to primary hyperaldosteronism. Yeah. So if there is more aldosterone, there is more reabsorption of sodium and water, and if there is more reabsorption of water, it will increase blood volume. Eventually it will increase the cardiac output, which will cause hypertension. Okay. Increased aldosterone can also cause increased BP directly. Okay. So what is the difference between hypertensive urgency and emergency? So in urgency, the BP is more than 180 by 120, but there is no acute end organ damages. Okay. And in emergency, there are signs of acute end organ damages, formerly called malignant hypertension, and severe hypertension with evidence of acute end organ damage. So what are these end organ damages? It can be encephalopathy or stroke. It can be in eyes, that is retinal hemorrhages and retinal exudates. It can be papilledema. It can be end organ damage in the heart. So what are the conditions that can occur in heart? It is MI, heart failure, aortic dissection, and in kidney it is kidney injury, acute renal kidney injury. There is microangiopathic hemolytic anemia. There is eclampsia during pregnancy, and arterioles may show fibrinoid necrosis. Okay. We'll see fibrinoid necrosis here somewhere. Okay. This is fibrinoid necrosis. This is onion skin appearance. It is caused by severe hypertension. We'll see that later on. And hypertension can predispose to coronary artery disease, left ventricular hypertrophy. To compensate for the increased afterload, it can lead to heart failure. It can lead to atrial fibrillation, aortic dissection, aneurysm, stroke, CKD, retinopathy. Okay. So how does atherosclerosis of renal artery, this one, can lead to hypertension? So let's see that pathogenesis. If there is atherosclerosis, it will cause renal artery stenosis, right? And if there is renal artery stenosis, the GFR is going to decrease automatically. Now if there is decreased GFR, it will activate the RAS, it will activate the renal angiotensin aldosterone system. Okay. it will activate renin release. Now if renin is increased, it will convert angiotensin 1 into angiotensin 2 because it is activating the angiotensin converting enzyme ACE. Okay. Now if the angiotensin 2 is increased, it will do two things. First is it will contract the smooth muscles of the arteries. So it is arteriolar smooth muscle contraction. Okay. Now if the arterial smooth muscle contraction is occurring in the peripheral arteries, so there will be vasoconstriction, right? So it will result in peripheral total peripheral resistance. Okay. And as we've seen here that hypertension can also primary hypertension was occurring due to increased cardiac output or increased total peripheral resistance. So increased total peripheral resistance causes hypertension. And the second thing angiotensin 2 does is it increases the aldosterone. Aldosterone will cause sodium reabsorption and it will increase the BP. That is hypertension. Hyperlipidemia signs. So first is xanthoma. Xanthoma is plaques or nodules composed of lipid-laden histiocytes in the skin. So histiocytes is just the macrophages that are present in the skin. Okay. So when these macrophages are filled with lipid, especially the eyelids, it causes these kind of bumps in the skin. And tendinous xanthoma is when these xanthomas are present in the tendons. Okay. And xanthoma is mostly present around the eyelids. Okay. And tendinous xanthoma is when the xanthomas are present in the tendons of the upper limb. Mostly it is present in the Achilles tendon and the upper limb, that is finger extensors. Okay. And corneal arcus, that is lipid deposits in cornea. It is common in older adults. It is called arcus senilis, but appears earlier in life with hypercholesterolemia. If the patient is younger and has a family history of hypercholesterolemia, or he has familial hypertriglyceridemia, familial hypercholesterolemia, it can be seen earlier in life as well. And it is this ring. Okay. Now moving on to the arteriosclerosis. It is hardening of arteries with arterial wall thickening and loss of elasticity. Arteriolosclerosis, it is common there are two types. The first is arteriolosclerosis and the second is Mockenberg sclerosis. So arteriolo, it is the sclerosis of arterioles. Okay. And arterioles is the small arteries and the arterioles itself. There are two types, hyaline and hyperplastic. So in hyaline arteriolosclerosis, there is thickening of vessel wall secondary to the plasma protein leak into the endothelium in essential hypertension or diabetes mellitus. In diabetes mellitus, we all know that there is non-enzymatic glycosylation of the basement membrane, right? So if this is the basement membrane, there is non-enzymatic glycosylation occurring in that basement membrane, which will make it weak. And if now the basement membrane is weak, the plasma proteins can leak out of it, and it will cause the thickening of the vessel wall. The plasma protein does not leak out of it completely into the interstitium, but it leaks into the endothelium from the lumen. If this is the lumen and this is the endothelium. Okay, so now if the basement membrane is here, this is the basement membrane. Now if the basement membrane is weak, it will allow plasma proteins to leak into the endothelium, and that accumulation of plasma proteins into the endothelium will thicken the wall. Okay. There is thickening of vessel walls secondary to plasma proteins. Okay, and it is due to hypertension as well as diabetes mellitus. And keep in mind that this hypertension is essential. This hypertension is not severe. Okay, and in the second kind, the hyperplastic kind, there is onion skinning, and it is because of severe hypertension with proliferation of smooth muscle cells. So there is chronic hypertension. So to compensate that hypertension, to overcome that hypertension, the smooth muscles cells of the vessel wall will start to proliferate, and it will cause similar thickening. That is called hyperplastic arteriolosclerosis. And how do we differentiate both of them in the histo images? Okay, so yaw-line will be seen something like this, and hyperplastic will be seen something like this. Okay. Yeah, so first we'll see the hyperplastic kind. There is proliferation of the smooth muscle, right? So you can so that is called onion skinning or onion skin appearance. So you can figure out these cells, that these are proliferated smooth muscle cells. So you can figure out these different layers of smooth muscle cells on top of each other. And in yaw-line arteriolosclerosis, there is just plasma protein being accumulated into the endothelium. So plasma proteins are not that big enough to be seen like these smooth muscle cells. So plasma proteins will just accumulate inside the inside the endothelium, and it will be seen somewhat smoother. Okay, this is the yaw-line accumulation. And this is onion skinning appearance because of the proliferation of the smooth muscle cells. Okay. And the second is Mockenberg sclerosis. Mockenberg sclerosis occurs in the medium-sized arteries, and it is due to the medial calcific sclerosis. So artery has 3 layers, right? It is IMA, Indian Medical Association, intima, media, and adventitia. So in Mockenberg sclerosis, there is medial calcific sclerosis. So it affects the medial layer. There is calcification of the medial layer. But keep in mind that there is calcification of just the medial layer. The intima and the adventitia are normal. So it will not obstruct the lumen. So the lumen is normal. It is not getting smaller like in arteriolosclerosis. And it is pretty uncommon. And the calcification of the internal elastic lamina and media of arteries. It causes vascular stiffening without obstruction. Vascular stiffening without obstruction. And it causes pipe stem appearance on X-ray. So this is pipe stem appearance. Yeah. And it does not obstruct the blood flow, and the intima is not involved. So if you see this image, keep in mind that there is no obstruction of the blood flow in the lower limbs or nothing like that is happening. It is just the calcification of the medial layer. Now This is a cholesterol emboli syndrome. So microembolization of cholesterol displaced from atherosclerotic plaque in large arteries, usually the aorta. It results in end organ damage due to small artery emboli and an inflammatory response. So livedo reticularis, digital ischemia, acute renal failure, cerebrovascular accident, gut ischemia. And the pulses remain palpable because the larger of arteries are unaffected and it may follow invasive vascular procedures. So it is very simple, but yeah, and I remembered another point that in hyaline arteriolosclerosis, it is this ring will be seen as basophilic. This is typical basophilic ring. Sorry, not in this hyaline, but in Mockenberg sclerosis, this ring will be seen as basophilic ring around the medial layer. Let's see some images of it. Okay. Okay, the Wi-Fi is pretty weak, so we'll just skip that. You can search it for yourselves. So yeah, in the cholesterol emboli syndrome, there is a large artery, mostly the aorta. This is the thrombus, and these are the small arteries that is giving rise from the aorta. So now what happens, a part of this thrombus is dislodged, and it becomes an microemboli, and then it will obstruct the small arteries. So the small arteries are the eventual arterioles, and it supplies the end organs, right? So these small artery emboli can cause obstruction as well as inflammatory response, like livedo reticularis in fingers. It can cause digital ischemia, that is blue toe syndrome, because of the obstruction and infarction of the digits. It can cause acute renal failure. It can cause cerebrovascular accidents like strokes. If it obstructs cerebral vessels, it can cause gut ischemia if it obstructs the mesenteric vessels. And the pulses remain palpable because when we palpate the pulses, for example, if we palpate the radial pulse, the brachial pulse, okay, if the dorsalis pedis artery, they are all large vessels, right? And the large vessels are not that affected with cholesterol emboli. Cholesterol emboli is formed is microemboli. It will not affect the large arteries. Okay. The large arteries are unaffected, and it may follow an invasive vascular procedures. It is called, which is angiography, angioplasty, and endovascular grafting. So in questions there will be history given of the patient undergoing angiography or angioplasty of for myocardial infarction or for angina or something like that, and a few days later presents with blue toes, or presents with acute renal failure, or presents again with the stroke. Okay, so but we know that angiography or angioplasty has performed, and the thrombus has been taken out or the stent has been placed. So it cannot be due to that thrombus. It cannot be secondary to that MI or anything. But we have to figure out that microcholesterol emboli may have dislodged and reached the smaller arteries. Okay. Now, atherosclerosis is a very common disease, and it is a disease of large and medium-sized muscular arteries, while the arteriosclerosis was a disease of small arteries, okay, small and medium-sized arteries. And it is a form of arteriosclerosis caused by the buildup of cholesterol plaques in tunica intima. Okay. And the most common location atherosclerosis occurs is in abdominal aorta, then the coronaries, then popliteal artery, carotid artery, and circle of Willis. And this is the mnemonic, a copycat named Willis. Abdominal aorta, coronary artery, popliteal artery, carotid artery, and circle of Willis. And risk factors are modifiable and non-modifiable. The modifiable risk factors includes the hypertension, tobacco smoking, dyslipidemia, which is increased LDL and decreased HDL, and diabetes. We can reverse or control all these risk factors. Okay, that is why they are called modifiable risk factors. And non-modifiable risk factors include age, male sex, postmenopausal status, and family history. And the symptoms of atherosclerosis are angina, claudication, and they can even be asymptomatic. So progression occurs by, first there is inflammation, which is important in pathogenesis. So there is endothelial cell dysfunction, and when there is endothelial cell dysfunction, it will attract all the macrophages and LDL accumulation occurs. So when this LDL gets oxidized, okay, and that mixes with the macrophages to form a foam cell formation, and a lot of foam cells together make a fatty streak, and the fatty streak causes the smooth muscle cell migration, proliferation, and extracellular matrix deposition, which will form a fibrous plaque, and these fibrous plaques will form complex atheromas, which will eventually form calcifications. Yeah. And smooth muscle cell migration occurs with the help of PDGF and FGF. Okay. And the calcium and eventually the calcification occurs. Now the calcium content correlates with the risk of complications. If the calcification is higher, the risk of complications is also higher. Okay. And what are the complications of atherosclerosis? It is aneurysm, ischemia, infarcts, peripheral vascular disease, thrombus, and emboli. So now, how does aneurysm occur due to atherosclerosis? So imagine there's an atheroma here. Okay, this is the atheroma. So now if we magnify this atheroma, if we magnify this wall, there are three layers, right? Intima, media, and adventitia, and this is the atheroma. So now there is an atheroma, so blood can't reach the inner levels or the outer layers, that is media and adventitia. So oxygen can't reach both of these external layers, and intima as well. The oxygen can't reach all the three layers. So eventually what happens is it will cause wall weakness, because the wall is not getting enough oxygen. And when the wall weakness and there is increased blood pressure, it will cause the wall to form an aneurysm. Okay, it causes ballooning of the wall, aneurysm of the wall. And here you can see there is intima and media and adventitia involved in atherosclerosis. Okay. Now, aortic aneurysm. Aortic aneurysm is a localized pathological dilatation of the aorta. It is localized dilatation of aorta. It may cause abdominal or back pain, which is a sign of leaking, dissection, or imminent rupture. And thoracic aortic aneurysm, it is associated with cystic medial degeneration. And the risk factors include hypertension, bicuspid aortic valve, connective tissue diseases like Marfan syndrome, also associated with tertiary syphilis. I explained earlier that tertiary syphilis affects the aortic roots and the ascending aorta and all. And how does tertiary syphilis causes thoracic aortic aneurysm? It is due to the obliterative endarteritis of the vasa vasorum. So if this is the aorta, vasa vasorum are the vessels that supply the wall of the large artery. Okay? So here vasa vasorum is supplying the wall of the aorta, and in tertiary syphilis, that is arteritis. That means the inflammation of vasa vasorum. Okay, so there is inflammation of vasa vasorum, so that obstructs the blood flow in the vasa vasorum. So now there will be decreased blood flow to the wall of the aorta. So now the wall weakening will occur, and eventually the wall ballooning and wall aneurysm will occur, just like we saw earlier in the atherosclerosis complications. Okay. And it is a medial degeneration, cystic medial degeneration. The medial layer gets affected. Only the medial layer gets affected, while in abdominal aortic aneurysm, it is transmural. So all three layers get affected. Yeah, so associated with transmural, all three layers inflammation and extracellular matrix degeneration. Risk factors include tobacco use, increased age, male sex, family history, and it may present as a palpable pulsatile abdominal mass. Okay. Right here, this is the aortic aneurysm. And rupture may present as pulsatile abdominal mass, acute abdominal back pain, and resistant hypotension. Okay. There is acute abdominal back pain. So we saw here that if there is abdominal or back pain, it is a sign of either leaking, dissection, or imminent rupture. So the aneurysm has now ruptured, and it is causing acute abdominal or back pain, and there is resistant hypotension because of the blood loss from the dissection of that aortic aneurysm. It is most often infrarenal. Okay. And most often it is infrarenal, but it is above the aortic bifurcation. Okay. So if this is aorta, this is the renal arteries coming out, so it is infrarenal but above the aortic bifurcation, so it is somewhat here. Because the distribution of vasa vasorum is reduced infrarenally. And the pathogenesis behind abdominal aortic aneurysm is the same as we talked earlier in atherosclerosis, that there is an atheroma. So there will be less O2 going into the layers of all the three layers of the artery, which will cause wall weakness and wall rupture, and wall aneurysm, and eventually wall rupture. Okay. And if the aortic aneurysm is more than 5 centimeter, the prognosis is very poor. Okay, that is the worst case. traumatic aortic rupture due to trauma or deceleration injury, most commonly at aortic isthmus, proximal descending aorta, just distal to origin of left subclavian artery. X-ray may reveal widened mediastinum. Okay. It is mostly occurs due to trauma or deceleration injury, like if you are sitting in a car that has and then an accident happens, so that is a deceleration injury. Okay, so the deceleration of the car is very quick, and it occurs most commonly at the aortic isthmus. If this is the aorta, this is the descending aorta, this is ascending aorta, this is the arch, this is the subclavian artery, this is brachiocephalic trunk. It occurs proximal in the proximal descending aorta, just distal to the origin, so somewhat here. This is the most prone zone for aortic rupture. Okay, and the blood is coming out of it, so it will be seen as a widened mediastinum. Okay. Now aortic dissection. Aortic dissection, there is a longitudinal intimal tear. Yeah. I previously thought that aortic dissection is like complete rupture of the aortic wall, but that's not the case. Only there's an intimal tear. So out of the 3 layers of the arteries, intima, media and adventitia, only the intimal layer has ruptured. So now what happens is, this is the vessel, right? So now the blood can enter through the intimal layer that is ruptured into the media and adventitia. Okay. So there will be blood accumulation in the wall. So you can see that here there is intimal tear here, so blood is traveling through the wall of the aorta. Okay. And it forms a false lumen. So this is a false lumen. Is associated with hypertension, obviously, bicuspid aortic valves, inherited connective tissue disorders, Marfan syndrome. It can present with tearing, sudden onset chest pain radiating to the back. This is very important. This is the key word. It is a sudden onset chest pain which radiates to the back. Okay, the chest pain in myocardial infarction is not very sudden. It is acute to subacute, but aortic dissection pain is sudden onset, and the patient history will be given like the patient was having dinner and suddenly he was suffering from chest pain which radiated to the back, and there will be unequal BP in arms. Yeah. Because obviously if the intimal tear is here, then the subclavian artery and brachiocephalic trunk has already left the aorta, so the BP will be unequal in the arms, and the chest X-ray can show mediastinum widening. It can result in organ ischemia, aortic rupture, death. And there are 3 types, and the classification is of 3 types. No, it's just 2 types, type A and type B. Stanford type A is the proximal. It involves the ascending aorta, and it may extend to the aortic arch or descending aorta, and it may result in acute aortic regurgitation or cardiac tamponade. Okay. Acute aortic regurgitation or cardiac tamponade. And in Stanford type B, it involves only the descending aorta below the left subclavian artery. Okay. So this is type A, this is type B. Type A arises, the aortic dissection occurs the ascending aorta, and in type B it is below the subclavian artery. This is the subclavian artery, so intimal tear occurs below the subclavian artery, right here. And the treatment of Stanford type A is definitely surgery, and of type B is beta blockers and then vasodilators. To cause aortic dissection, there should always be hypertension present. Okay. So first, there should be hypertension present, and second, there should be wall weakness present. So how does hypertension causes aortic dissection? Right. So if there is hypertension, there will be hyaline arteriosclerosis of vasa vasorum. It is causing arteriosclerosis, right? Because the vasa vasorum are the smallest arteries possible. Yeah. And because of arteriosclerosis of vasa vasorum, the there will be less O2, and there will be wall weakness. And if there is wall weakness, we got the second thing we wanted. We talked about first, there should be hypertension present, and second, there should be wall weakness present. So now we've got both the things to cause an aortic dissection. Yeah. Now, subclavian steal syndrome. So there is stenosis of subclavian artery proximal to the origin of vertebral artery. So that causes hypoperfusion or distal to stenosis. So there is reverse blood flow in ipsilateral vertebral arteries. So there is stenosis of subclavian artery proximal to the origin of vertebral artery. So this is the origin of vertebral artery, and there is stenosis proximal to it. So this is the stenosis. So due to that, there is hypoperfusion distal to the stenosis, and so yeah, there will be hypoperfusion here in the left limb. Okay, but if there is stenosis here, there will be reversal of flow. The flow is supposed to go this way, right? But there is stenosis, there is hypoperfusion here, so the blood flows in the reverse direction and into the lower limbs. So the name itself suggests that the subclavian steal syndrome. The subclavian arteries steals blood. From whom does it steals the blood? It steals the blood from the cerebral perfusion. Yeah. So whenever this arms is exerted more, it needs more blood. The subclavian artery steals the cerebral perfusion. Okay. And the symptoms of subclavian steal syndrome is arm ischemia, pain, paresthesia, vertebrobasilar insufficiency, which will cause dizziness and vertigo because of decreased cerebral perfusion. And there is more than 15 mmHg difference in systolic BP between arms. The systolic BP will be normal here, but less here. Okay, less on the affected side. And it is associated with arteriolosclerosis, Takayasu arthritis, and heart surgery. Ischemic heart disease manifestations. So first we'll see angina. Angina is a chest pain due to ischemic myocardium secondary to coronary artery narrowing or spasm, and it does not have any kind of necrosis. Okay, myocardial infarction has necrosis, but angina does not have any necrosis. So there are three types of angina. There is stable, unstable, and vasospastic. So First we'll see stable. Stable is usually secondary to atherosclerosis when there is more than 70% of occlusion, and it causes exertional chest pain in classic distribution, and it is possibly with ST depression on ECG resolving with rest. This is very important that it resolves with rest. And stable angina always occurs when the patient is on exertion. Okay, it is resolved with rest or nitroglycerin. Now, if we speak of pathology, in stable angina there is reversible injury of myocytes. So the injury is reversible if the predisposing factor or the risk factor is removed. Okay, and why is there ST depression? Because whenever ST depression occurs because of subendocardial ischemia, and if there is ST elevation like in MI, it causes transmural ischemia. Transmural means it affects all three layers of the heart. Second is unstable angina. So unstable angina is due to the thrombosis with incomplete coronary artery occlusion. Stable angina was due to atherosclerosis, and unstable is due to thrombosis with incomplete coronary artery occlusion. It can have ST depression or T wave inversion on ECG, but there are no cardiac biomarker elevation, unlike NSTEMI, and it increases in frequency or intensity of chest pain or any chest pain at rest. Okay, so in stable angina there was chest pain only with exertion, and in unstable there is a chest pain without exertion at rest also. And third is the vasospastic. So vasospastic was formerly known as Prinzmetal or variant angina, and it does not occur due to atherosclerosis or any kind of thrombosis, but it occurs due to secondary to coronary artery spasm, and it results in transient AST elevation on ECG. Tobacco smoking is a risk factor. Hypertension and hypercholesterolemia are not. So only tobacco smoking is the risk factor. Hypertension and hypercholesterolemia causes atherosclerosis, but atherosclerosis does not cause vasospastic angina, so they both are not the risk factors for vasospastic angina. And triggers include cocaine because it causes vasoconstriction, alcohol, triptans, and it can be treated with calcium channel blockers, nitrates, and smoking cessation if applicable. So now we'll see the table. So in stable angina, as we talked about, pain is on exertion. In unstable, it is on mild exertion or even at rest. So troponin level is not increased in any kind of angina. If the troponin levels are increased, it will be called myocardial infarction. Okay, it is only when the myocardial cells are infarcted, it releases the cardiac biomarkers. Okay, unless they will not. And there is no infarction here. There are no ECG changes. There might be some ST depression. Okay, here too possible ST depression. So the key difference between stable and unstable angina is just that the pain is on exertion in stable angina and pain is at rest too in unstable angina. And there can even be T wave inversions in stable angina. Okay. And how do we differentiate myocardial infarction from angina? So myocardial infarction will be of subacute onset. It will be at rest too. So, and the most important factor is the cardiac biomarkers will be elevated. Now, what is NSTEMI? NSTEMI. So NSTEMI is non-ST elevation. So when does ST elevation occurs? ST elevation occurs only when all the three layers are involved in the MI. So that is transmural infarction. But NSTEMI, so there is no ST elevation, so there is no transmural involvement. There is just subcardial involvement. Okay, that will cause ST depression. And in STEMI, all three layers are, you can see here, all three layers are involved. That is called transmural, and it will cause ST elevation. Okay. And yeah, vasospastic angina is reversible too. Okay. Now coronary steal syndrome. First we saw subclavian steal syndrome, now we see coronary steal syndrome. Distal to coronary stenosis, vessels are maximally dilated at baseline. So administration of any vasodilators like dipyridamole and regadenoson dilates the normal vessels. So blood is shunted towards well perfused area, and ischemia in myocardium perfused by stenosed vessels. So principle behind pharmacological stress test with coronary vasodilators. So see, it is coronary steal syndrome. So it is not like subclavian steal syndrome where subclavian was stealing. In coronary steal syndrome, the normal vessels steals from the coronary vessels. Okay, so the normal vessels steals from stenosed coronaries. Stenosed coronaries. And why does that occur? So imagine if this is the coronary artery, there has been stenosis. So initially to compensate that stenosis, the coronary artery will dilate, and it will dilate maximally. Okay, so there is now no further room for any dilatation. So now if vasodilators are given like dipyridamole and regadenoson, it will dilate the other normal vessels. Okay. Here it was stenosis, so it has already maximally dilated, as we said. But now if we give vasodilators, there are other arteries that can be more dilated, right? So what happens is, now it has vasodilated. Now it will steal blood from that stenosed artery into the vasodilated arteries. So blood is shunted towards the well perfused areas, and ischemia in the myocardium perfused by stenosed vessels. So whatever limited amount of blood the stenosed coronaries were getting, now they will not get that blood too. So this area here of the area which was supplied by the stenosed coronaries will undergo ischemia. Okay, and that is the principle behind the pharmacological stress test with coronary vasodilators. So when the stress test is performed, when we are suspecting an ischemia, but there are no signs of it on the ECG. Okay, so then we give coronary vasodilators. So the normal vessel will steal blood from the stenosed coronaries, and the area supplied by the stenosed coronaries will undergo ischemia, which will cause chest pain and which will cause changes in the ECG, so that we can know that that area is undergoing ischemia and there is a clot present, or there is an obstruction present in the coronaries. Okay. And sudden cardiac death. So sudden cardiac death is the death that occurs within 1 hour of symptoms, most commonly due to lethal arrhythmia. What are the lethal arrhythmias? They are ventricular fibrillation. It is associated with coronary artery disease in up to 70% of the cases. Cardiomyopathy, hypertrophic or dilated, and hereditary ion channelopathies, that are long QT syndrome, Brugada syndrome, and it can be prevented by ICD. Okay. Implantable cardioversion device. Okay. So what all can cause sudden cardiac deaths? There are lethal arrhythmias like VFib. Then there is CAD, which amounts to 70% of the cases of the sudden cardiac death. Second is cardiomyopathies and ion channelopathies, that is long QT syndrome and Brugada syndrome, all that. Now chronic ischemia, heart disease. Progressive onset of heart failure over many years due to chronic ischemia, myocardial damage. Myocardial hibernation, so that potentially reversible LV systolic dysfunction in the setting of chronic ischemia. contrast with myocardial stunning. It is a transient LV systolic dysfunction after a brief episode of acute ischemia. Okay. So due to chronic ischemic myocardial damage, over the few years, the heart will start functioning low, which is called heart failure. And there are two terms to be understood here. First is myocardial hibernation and second is myocardial stunning. So imagine if there is an acute ischemic attack. This is the acute ischemic attack. So what happens immediately or transiently is myocardial stunning. So for some time the LV systolic dysfunction will be present, but it will recover over the period. Okay, but what happens if this is a chronic ischemia? Okay, if this is a chronic ischemia, it will cause myocardial hibernation in the long run, and it is possibly reversible. It is possibly reversible LV systolic dysfunction in the setting of chronic ischemia. So if this is a chronic ischemia, over the few years myocardial hibernation will occur. So both causes LV systolic dysfunction. It's just that stunning causes a transient LV systolic dysfunction and hibernation is hibernation, so it will cause long-term reversible LV systolic dysfunction in the setting of chronic ischemia. Now the myocardial infarction, so most often due to rupture of coronary artery atherosclerotic plaque, which causes acute thrombosis and there is increase in biomarkers. And if you go by the textbook definition, it should involve increased cardiac biomarkers like CK-MB and troponins. Without the increase in cardiac biomarkers, it cannot be called myocardial infarction. And we talked about this earlier, that N stemmi is subendocardial, stemmi is transmural. N stemmi is subendocardium inner 1/3, which is vulnerable to ischemia. So this is the part that is inner 1/3. It is more prone to ischemia. And stemmi involves full thickness of the myocardial wall. ECG changes ST depression and ST elevation, and it can also have pathological Q waves. Okay. So what is the evolution of myocardial infarction pathologically? So most commonly occluded coronary artery is LADA, that is the artery of Widowmaker. Because it is called artery of Widowmaker because it is the most commonly occluded coronary artery. Second is right coronary artery. Third is circumflex. And symptoms are diaphoresis, nausea, vomiting, severe retrosternal pain, pain in the left arm or jaw, shortness of breath, fatigue, anything. Now in simple terms, what happens to the heart pathologically we'll first see. Okay, then we'll go through this theory part. So there is coagulative necrosis, right? Because it is an infarction. It is due to ischemia. So we'll divide the period over three time periods. First is 1 day, 1 week, and third is 1 month. What happens on 1 day to 1 week? There are neutrophils and macrophages, and on 1 week to 1 month, granulation tissue forms. Yeah. So whenever there is an ischemia or whenever there is an infarction, first of all there will be necrosis, right? That coagulative necrosis which is caused by the infarction. So first we will see the coagulative necrosis, and as there is coagulative necrosis, then it will be followed by an acute inflammation, right? Because we have to remove that debris and all that. So what is the marker of the acute inflammation? What cells causes acute inflammation? So it is neutrophils, right? So on 1 to 3 days, the neutrophil arrives at the section, which causes an inflammation. Neutrophils causes acute inflammation. So now after three days to 1 or 2 weeks, macrophages arrive, because macrophages will clean all the debris and all that, right? And on cleaning all that debris and debris, it will also cause wall thinning, which causes wall weakness, and it might lead to wall rupture too. Okay? It is the complication of myocardial infarction caused by the macrophages. And after macrophages has cleaned everything, there will be granulation tissue formation, which is called scarring. There will be scar present at the site of the infarction. Okay, it is very simple. Like if you want to write it down here, first there is coagulative necrosis. Then there is neutrophils, which causes acute inflammation. Then macrophages come in, it clears the debris. And the last is granulation tissue, that is scarring. It's that simple. So now let's see the theory part of it. So 0 to 24 hours, the infarction has occurred, the coagulative necrosis has occurred. So on first 4 hours, there are wavy fibers present. And on 4 to 24 hours, there is coagulative necrosis present, which is seen in here. So how do you identify that there is coagulative necrosis has occurred? So histologically, there are no nuclei present, okay, in the myocytes. So you can see here there are no nucleus present. There should have been here nucleus like these, but as you can see, there's just necrosis all over here. So if they give you a histological slide and you can't see any nucleus, it is coagulative necrosis, and it is the first 24 hours of stage. And if you can figure out there are neutrophils in this, it is 1 to 3 days. And if you can figure out macrophages with huge nucleus, okay, with high nuclear to cytoplasmic ratio, that is in macrophages, the nucleus is covering most of the cytoplasm. That is how you identify macrophages. If there are macrophages present, it is 3 to 14 days. And if there is just waves, there is just contraction, these are just scarring, and there are few neutrophils and macrophages in between. Okay. So that is the last stage of contracted scar. Let's get back to the first 24 hours. So coagulative necrosis occurs in the 4 to 24 hours. So that leads to cell content released into the blood. It causes edema and hemorrhage and reperfusion injury. So why does reperfusion injury occurs? Reperfusion injury occurs because of the free radicals that are released by those dying cells, and it increases the calcium influx. So now if calcium influx is increasing in the myocytes, what will happen? It will contract more. There will be hypercontraction of the myofibrils. So as you can see, those hypercontraction of myofibrils by dark eosinophilic stripes. These are the dark hypereosinophilic stripes. So you can figure out, okay, these are the strips. And this is the necrosis part. Okay. This is all the necrosis part. And there will be there's this occluded artery, and there will be dark mottling which will be seen pale with the tetrazolium stain. Okay. Why will there be dark mottling? Because of the coagulative necrosis and again the reperfusion injury. So the blood is entering that infarcted area which is causing the reperfusion injury. So it seems dark mottling area. And the complications include ventricular arrhythmia, heart failure, or cardiogenic shock. So this is very specific. The ventricular arrhythmia is very specific to the first 24 hours. If first 24 hours passes without having any kind of arrhythmia, it is very less likely that arrhythmia will occur after 24 hours. Because why does ventricular arrhythmia occur? It is because if the conduction system of the heart is involved in any kind of infarction, only then ventricular arrhythmia will occur. Okay. It can also cause cardiogenic shock due to systolic dysfunction of the heart. Okay. So now 1 to 3 days there will be extensive coagulative necrosis, but now the tissue surrounding infarct shows acute inflammation because of the neutrophils. Neutrophils have started coming in at that site, which will cause acute inflammation. And what are the signs of the acute inflammation? The sign of acute inflammation is hyperemia, right? Reddening of the site. So it will cause hyperemia. And because and as a complication, it also causes post-infarction fibrinous pericarditis. So why does that pericarditis occurs? Because if there is transmural ischemia, that is STEMI. I'm not talking about N-STEMI here. No, we are not talking about the subendocardial ischemia. This pericarditis, fibrinous pericarditis, only occurs if there is a transmural ischemia. So now if there is a transmural ischemia, so neutrophils have started gathering at all these sites, right? But there is also pericardium that surrounds the heart. But now these neutrophils that have started gathering around the site of infarction will also come in contact with the pericardium and will start an inflammation there. So this pericarditis is caused by the neutrophils. Okay. And keep in mind that it only occurs with transmural ischemia, that is STEMI. It will not occur in subendocardial infarction. And due to pericarditis, we can also hear the friction rub, like because of both the pericardial layers, the visceral and parietal, are rubbing against each other. Yes, that will cause friction rub. Now the third stage is the macrophages starts arriving at the site. Okay. And macrophages form the granulation tissues at the margin. So first there was hyperemia here, right? This area was hyperemic because of the acute inflammation caused by neutrophils. But now as macrophages arrive at the center, it will start yellowing. So granulation tissue, if you have seen the ulcer patients in surgery wards, the granulation tissue is first yellow to bright pink. Okay, so first yellowing will occur here because of the granulation tissue formation, but there will still be an hyperemic border because the neutrophils have not cleared up completely and macrophages have started arriving through the center. So the granulation tissue forms first at the center and then it surrounds to the boundaries as well, and the hyperemic border will disappear over the time. Now the what is the function of macrophages? That macrophages clears all the debris. It clears all the debris, and in doing so it will weaken the wall too, because it eats all the debris. So by eating all the debris, if this is the wall, it had debris all over it. Even if it's a debris, it was supporting the wall that has undergone the infarction. This wall has gone under the infarction, but because of the debris it was being supported. But now if the macrophages starts eating all the debris, it will weaken the wall too. So now this wall has weakened. Okay, what happens if there is a weak wall? It can lead to wall rupture. So that is free wall rupture. And what will happen if there is a free wall rupture? The blood will go out into the pericardial cavity. That will lead to cardiac tamponade. Okay, and if it ruptures the papillary muscles, if the papillary muscle is somewhat involved in the infarction and it had debris on it too, the macrophage will eat it too, and the papillary muscles will be ruptured, which will cause mitral regurgitation. If the macrophages eats up interventricular septum, it will cause IV septal rupture, which will cause left to right shunt. It will cause left to right shunt because left ventricular pressure is higher than the right ventricle. Okay, and it can and if the left ventricular wall has now weakened, it can also lead to pseudoaneurysm, and pseudoaneurysm is always at the risk of rupture. Okay, and when does all these occur? Like papillary muscle rupture can occur with RCA or PDA. No. Papillary muscle rupture can be caused in if there is left anterior descending obstruction or the PDA obstruction, because LADA supplies the anterolateral papillary muscles and the PDA supplies the posteromedial papillary muscles. Okay, and IV septal rupture is caused in left anterior descending block. Okay. You know, right, why the papillary muscle rupture can cause mitral regurgitation. So if this is the mitral valve, these are the papillary muscles, and if these rupture, now the mitral valve will not be able to close properly or functional properly, so it will become regurgitant. Okay. And the last stage, that is 2 weeks to several months, there is contracted scar. Okay, this is type 1 collagen, and it can cause Dressler syndrome, heart failure, arrhythmias, true ventricular aneurysms. Here it was pseudoaneurysm, but now true ventricular aneurysms can also occur because there is risk of mural thrombus. And why does mural thrombus occurs? Because this is a scarred wall. Okay, and scar is not that strong. Okay, scar is a weak wall, and the weak wall, as it is scarred, it is also not very movable. Okay, not very movable. And if it's not very movable, it will cause stasis, which will lead to mural thrombus. Now, what is Dressler syndrome? Yeah, Dressler syndrome is, remember when the neutrophils were attacking the pericardium? Okay. So when neutrophil inflames the pericardium antigens are introduced to the blood, and if the now the pericardial antigens are introduced to the blood, and it will create an immune response, an autoimmune response to the pericardium, which will cause pericarditis after 3 weeks. it will not cause pericardium immediately, like in 1 to 3 days. It was because of the neutrophils inflammation. But if the pericardium is occurring after 21 days, it will be because of the autoimmune reaction to the pericardial antigens. Okay. Let me just write it down here. Are introduced to blood. It forms antibody against pericardial antigen. So it will cause autoimmune pericarditis. Just remember these timelines. Okay. Like we said, this is the 0 hour. This is 1 day. You can remember this as 1 week, because 1 week comes in between the 3 and 14 days, and you can remember this as 1 month. Let's see few histological images of this. Yeah, so this is the viable myocardium, and here you can see there is in the necrotic picture there is myofibrils, the hypereosinophilic contraction myofibrils, it is these, and granulation tissue, you can figure out there are macrophages present here. Okay, these images are not very clear. I wanted to show you the contracted scar, how it looks under histology, but there are no clearer images present. This one was a bit clearer. Okay. Anyways, so how do we diagnose myocardial infarction? So the definite diagnosis occurs by the cardiac biomarkers. We diagnose it as myocardial infarction only if there is an elevation in the cardiac biomarkers. Okay. And which is the most specific cardiac biomarker? It is troponin I. Okay, it is cardiac troponin I. which is called tropi in the wards. So, cardiac tropi is there, CKMB is there, but cardiac tropi is more specific because it rises after 4 hours. It is increased for 7 to 10 days. Okay, so and it peaks at 24 hours. It is more specific than other protein markers. But if there is reinfarction happening, we cannot use cardiac troponin I because it is increased for 7 to 10 days. So now imagine if there is a myocardial infarction. Yeah, we did trop I and it was increased, so we diagnose it as MI. But after 4 days, the symptoms reappeared. The patient got worse, and we are suspecting that there is a reinfarction. Okay, it is just 3 or 4 days after the first episode. But now if we again do the tropi, we know that the tropi stays increased for 7 to 10 days. So there will not be a major change in the tropi levels with the reinfarction occurring. So in that case, we can use CKMB because CKMB increases after 6 to 12 hours. It peaks at 24 hours and then it is decreased. Okay. So now that is it returns to normal after 48 hours. So at 48 hours, that is 2 days after the first attack, CKMB has now gone down to the normal level. So now if there is a reinfarction occurring at 3rd or 4th day, if we can check CKMB, it will again rise. Okay, so we can be sure that it is a case of reinfarction because CKMB has gone down at 48 hours, but now as reinfarction has occurred, it has again increased. Okay, this is reinfarction. Both increases after 4 to 6 hours. The peak of both the biomarkers is at 24 hours, but tropi stays increased for 7 to 10 days and CKMB stay increased for 48 hours. It is predominantly found in myocardium but can also be released from skeletal muscle. Okay. And it is useful in diagnosing reinfarction following acute MI. In ECG, changes can include ST elevation, STEMI, yes. If it's a transmural infarct, ST depression. If it's a subendocardial infarct, if it is hyperacute, that is peaked T waves, T wave inversion, pathological Q waves, or poor R wave progression. What is poor R wave progression? So from V1 to V6, the R wave's height should be increasing, but in poor R wave progression, that height will not increase much. Okay, and now we'll see the stages of ECG. Okay, stages of ECG in MI. So first, if there is hyperacute MI, so here peaked T waves. So let's draw an ECG. This is T wave. It is tall T wave. Okay. It is hyperacute. Now the second is acute MI. Okay. Now slowly, first the T wave increases, and then slowly this all ST segment will also increase. So let's draw that. This is acute MI, where ST elevation is present. Here it was just T wave. Now, as the T wave started increasing in height first, it will decrease in the height first too. Okay, so now there is T wave depression, but ST segment is still elevated. that is called evolving MI. So the ST segment is still high, but there is T wave inversion, that is called evolving MI. Now we'll see the evolved MI. In evolved MI, there is pathological Q waves. So what is pathological Q waves? It is just very deep Q waves. So normally it was this. Now pathological Q wave is this. And everything else will be normal. It is also called QS pattern, okay, which is used to identify if there is any past history of myocardial infarction. There will be QS waves present on the ECG. Sometimes the Q waves are so deep that the ECG looks like this. Okay, so that is QS. Now ECG localization is very easy. You just have to remember the mnemonic SAL, septal, apical, lateral. The first V1, V2 is septal, V3, V4 is apical, and V5, V6 is lateral. And lateral LCX is 1 AVL, inferior is 2, 3 AVF, and the posterior PDA is the posterior leads V7, V9. So V7, V9 is here. So there is V7, V9 elevation and posterior descending artery involvement, and there will be ST depression in V1 to V3. So here is V1 to V3, that is called reciprocal changes. So there is, if there is ST elevation here, there will be ST depression here with tall R waves. Let's see, yeah, here it is. This is tall R waves. Okay, and this is there's this ST depression. No, I don't think that's ST elevation. It's just showing the tall R waves. In V1 and V3 there will be ST depression with tall R waves, and in V7, V9 is ST elevation. Okay, and now there is left anterior descending artery involvement. So it will cause tachycardia plus hypertension. Why? Because left anterior descending artery is also supplying the IV septum and endocardial cushions and all that, and the papillary muscles. So due to infarction, there will be formation of re-entry circuit, which will cause tachycardia and hypertension. And if there is RCA, right coronary artery, it supplies SA, AV nodes. And if there is infarction in the SA and AV nodes, the conduction of the impulse will be slowed down, which will cause bradycardia and hypotension due to decrease in cardiac output, because the heart rate is decreasing. And other examination points, if you want to remember, like the heart sounds and all, so there will be the S1 and S2 will be dull, and there can be S3 and S4 present. Why will S4 be present? Because atria is pushing blood through a normal valve into the non-dilated, the ventricles are not dilated in MI, right? Non-dilated, non-compliable ventricles. Non-compliable because if the ventricular wall has undergone infarction and it's not functioning properly, it becomes non-compliant. So that will give rise to S4. Okay. And S3 is heard because there is increased ventricular filling, the blood gushing through the valves into the ventricle, crashing into the There can be murmur present too. If it has caused mitral regurgitation, there will be a systolic murmur. Okay, there can be a friction rub due to pericarditis. The temperature is slightly increased. Okay. I think there can also be some paradoxical S2 splitting present because the left ventricle is being involved, the left bundle branch block can occur. Okay, and if there is left bundle branch block, the aortic valve will take longer time to close than pulmonary valve, which will cause paradoxical split heard on expiration. Okay. Now the tachycardias. The arrhythmias are very interesting if we understand it completely. Yeah, first we'll see narrow complex tachycardia. What is narrow complex? It is narrow QRS complex. So narrow is normal, okay. And then we'll see wide complex tachycardia. So wide complex is not normal. Narrow complex is normal. First we'll see the atrial fibrillation. What is atrial fibrillation? The atria has stopped contracting completely. There are just some small contractions occurring. So you can see here, these are due to these fibrillatory waves are due to the small contractions that are occurring in the atria at irregular rate and rhythm, and they are not very powerful. They are not very strong to push the blood through the left atria into the left ventricle. These are fast, weak contractions, if you might say. So there is irregular rate and rhythm with no discrete P waves. You may these atrial fibrillations patients are very common in emergencies, and if you take a pulse of those patients, you can immediately figure out that the the rhythm is irregular of that patient, and you can immediately know that this patient is in AFib. Okay. It is very common. And common risk factors include hypertension and coronary artery disease. Mostly AFib is seen in the patients presenting with MI in emergencies. It may predispose to thromboembolic events. Why thromboembolic events? Because, as I said, that atria is not contracting completely. Yes, there are fast contractions, but they are very weak contractions. So atria is pretty much staying static. It is not contracting much, so that will give rise to stasis of blood, as the blood is not going into the LV completely. Blood is staying into the left atria, which will cause stasis of blood, which will cause thromboembolic events, and that emboli can travel into the brain and cause stroke. And so what is management? We have to control the rate and we have to control the rhythm. So rate is controlled by the beta blockers, calcium channel blockers, digoxin and all that, and the rhythm is controlled with cardioversion. And definitive treatment is ablation of pulmonary vein, ostia or left atrial appendage. And consider anticoagulation like warfarin based on stroke risk. Warfarin will prevent these thromboembolic events from happening. And why does this atrial fibrillation occurs in hypertension or coronary artery disease? So in both of those cases, there is volume overload. Okay. So the left ventricle is not able to eject blood properly or something like that. So that blood is static in both left atria. That blood is being filled up in both left atria and left ventricle. So eventually the stress is on left atria, right, to push blood from atria into the ventricle. So when there is increased stress, increased wall tension, the wall thickness also increases, right? There is the Laplace law. It will cause hypertrophy of left atrium. And these hypertrophy, if this is the atrium, now this is the atrium. So now the wall thickness has increased. It can give rise to the automatic foci of electric burst. If here it was this electric foci, now the wall has become so thickened. So one foci can be here, another foci can also be here. There are multiple foci, multiple ectopic foci that will give rise to electric burst activity. These are all automatic foci, which automatic foci means they generate impulses on their own. So due to lot of impulses, atria is not able to catch any of those impulses completely, and it then contracts rapidly, but ineffectively. Now, multifocal atrial tachycardia. There are two terms. One is focal atrial tachycardia, where there is just a single focus of atria generating impulse. So there will be different P waves. There will be a different P waves, but all the P waves will be equal amongst each other. But in multifocal atrial tachycardia, there are multiple foci, multiple ectopic foci, which will all generate different kind of impulses. So different kind of P waves will be formed. So there are at least 3 different distinct P wave morphologies due to multiple ectopic foci. So why does this multiple ectopic foci occur? It occurs due to COPD, pneumonia, or heart failure like conditions, where there is right atrium enlargement also involved. And it also has irregular rate and rhythm like AFib. So as you can see here, that all of these P waves, this and this, all of them are different in the morphology, right? Whereas if we see the focal atrial tachycardia, this P wave does not look normal, right, to you. But they both are similar in morphology, if you can see. So there is just single foci here, which is giving rise to an abnormal P wave, but that abnormal P wave will be same throughout. Whereas here in multifoci, there are different foci giving rise to different atrial contractions, which will give rise to different P wave morphologies. Okay. Now, atrial flutter. It is rapid succession of identical consecutive atrial depolarizations, wave causing sawtooth appearance of P waves. It is very typical sawtooth appearance. If you will see any sawtooth appearance, you will get to know that this is atrial flutter and nothing else. And it is treated like atrial fibrillation. So rate and rhythm control and cardioversion with catheter ablation of region between tricuspid annulus and IVC. Okay. So this is P wave, 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 P wave. So that causes a sawtooth pattern. And the rate is regular. So RR intervals are equal here. So rate is regular. Sorry, the rhythm is regular. Why does this atrial flutter is caused, it is due to macroenterant pathways. Pathways that are in atria. So impulse travels through those microenterant pathway and gives impulses back to the atria. So the atria depolarization occurs at a more rate than the ventricular depolarization. If this is SA node, this is AV node, this is ventricle, and this is atria, there are microenterant pathway. These are microenterant pathway. So what happens if the impulse go from SA node to AV node to ventricles, but most of the impulses come back through those microenterant pathways into the atria. So that will cause more this P waves, more atrial depolarization, and the atrial rate is always more than ventricular rate in atrial flutter. See here it is 4:1 sawtooth pattern. Now PSVT, which is paroxysmal supraventricular tachycardia. Now PSVT, so it is most often due to the reentrant tract between atria and ventricle, most commonly in the AV node. So in medicine you would have read that PSVT is of two kinds. It is AVRT and AVNRT. We are not going into much detail about both of them, but due to reentrant, if this is SA node, this is AV node, there are reentrant currents going through the AV node into the ventricles, and they are not arising from the SA node. They are just passing through the AV nodes into the ventricles. So as there are more reentrant pathways, the conduction will be very fast. So now, if these reentrant pathways are there, they can act two ways, right? The conduction can go this way, which will be called anterograde, and the conduction can also go this way, if it is called retrograde. Now, if the conduction is going anterograde, it will result in faster conduction of impulses to the ventricles, right? And what will faster conduction to the ventricles cause? It will cause ventricular tachycardia. Hence, this is a tachycardia, and hence there is a Q waves. If we continue the rate, the ventricular rate will be higher. Yeah. And at certain point, these reentrant tract becomes the major pathway of conduction of impulses, and so if there is no involvement of SA node, there will be no conduction to the atria, so there will be no P waves. Okay, so there are no P waves, but so you will get confused in the ECG if there are no P waves. You will confuse between PSVT and AFib, because AFib also does not have any kind of P waves here. It does not have any P waves either. But in AFib, the rate is irregular, but here the rate is regular. The rhythm is regular. Okay, you can see the rhythm is regular. And this was the case because the reentrant pathway was anterograde. But now if this pathway is retrograde, there will be slow conduction to the ventricles, right? Because you are going from SA node to AV node, but the reentrant pathway is conducting the impulses back retrograde into the atrias. So now there will be slow conduction to the ventricles, which will cause slow and wide QRS complexes, and it is the case in AVRT. Okay, but if you want to read about it, you'll read about it in medicine. I'm not going into much detail because it is a huge topic, this AVRT and AVNRT. The AVRT also has two types. It is orthodromic and antidromic and all that. But you just have to keep in mind for step 1 that it is tachycardia and it is regular rhythm and there are no P waves. Okay. That should be enough to identify any ECG of PSVT. And the symptoms are sudden onset palpitations, lightheadedness, and diaphoresis. So, what is the treatment? We have to get rid of this reentrant pathway. Okay. How do we get rid of this reentrant pathway? We can teach the patients the vagal maneuvers. We can give IV adenosine, electrical cardioversion if hemodynamically unstable. In any case of tachycardia, if the patient is hemodynamically unstable at any point of time, we have to perform electrical cardioversion. And what is the definitive treatment which we talked about is we have to get rid of the reentrant pathway through catheter ablation of reentry tract. Okay. And if there is wide QRS complex, as I talked about in the AVRT section, where the reentrant pathway is retrograde in nature, we have to defibrillate the patient, okay, because there is wide QRS complexes. Now, Wolff-Parkinson-White syndrome. It is the most common type of ventricular pre-excitation syndrome. So, what is pre-excitation? This delta wave is pre-excitation. It is getting excited before it should be. And it is because of the abnormal fast accessory conduction pathway. It is fast, it is accessory conduction pathway from atria to ventricle. That is called the bundle of Kent. And it bypasses rate slowing the AV node. If this is SA node, this is AV node, this is ventricle. So what bundle of Kent does is it bypasses AV node and straight directly generates impulse into the ventricles, which will cause pre-excitation before the slow AV node conducts the impulse into the ventricles. First, this impulse will go. Second, this impulse through AV node will go, which will cause the major R wave. Ventricles partially depolarize earlier. What I said, this one is partially depolarizing. Characteristic delta wave with widened QRS complex, and shortened PR interval. Okay, yes, this is PR interval normally, but now it has shortened. It may result in re-entry circuit, which will cause SVT, supraventricular tachycardia. Supraventricular tachycardia is the tachycardia that arises because of a pathology that is supraventricular, above the ventricle, that is in the AV node or the atria or the SA node. Anything above the ventricles that gives rise to ventricular tachycardia is called supraventricular tachycardia. And its treatment is procainamide, and we have to avoid AV nodal blocking drugs. Okay. Why do we have to avoid the AV nodal blocking drugs? Because there is only another pathway bundle of Kent present, and now if we block this AV node, we have blocked the AV node. Okay, so now there is just impulses going through bundle of Kent. Okay, and the impulses going through the bundle of Kent were fast and accessory conduction. They were fast, so they can cause ventricular fibrillation if only accessory is working. We need AV node pathway to slow the rate down so that the ventricles does not go into fibrillation, ventricles does not go into the tachycardia. Okay. And this WPW syndrome is also associated with Ebstein's anomaly. Where the right atrium is atrializing the whole of right ventricle because of the downward displacement of the tricuspid valves. And due to this accessory pathway, the ventricular depolarization is occurring early, right? We saw that the PR interval was shortened and the delta waves is present. It is called pre-excitation. So the ventricular depolarization is occurring early, but it is for a prolonged period of time. No, because accessory is not as fast as original. Yes, it is prolonged because first this delta wave is caused by the accessory pathway, and then the original QRS complex is caused by the AV node pathway. So it is prolonged and early. And as it is prolonged, it is called wide QRS. Prolonged and early. There is also another junctional atrial tachycardia, in which there is an atomicity in the ventricular myocyte, which will give rise to impulses which will travel from ventricles to atria. So P waves will be inverted in the lead too. Okay, that is junctional atrial tachycardia. This is atria, this is ventricle, this is SA, this is AV. Now there is an atomicity somewhere here in ventricles, which will travel with the impulse from ventricle into the atria. Normally what was happening is SA node was giving impulse to atria. That was causing normal P waves. But as the impulses are traveling from ventricle into the atria, that is in the reverse direction, it will cause P waves that are inverted. Okay. That is in junctional atrial tachycardia. And it will be seen in lead 2. Alright. So ventricular tachycardias. There are two types of ventricular tachycardias, monomorphic and polymorphic. So monomorphic means that all the QRS complexes are similar in pathology, and in polymorphic VT means all the QRS complexes are different in morphology. Okay. So this ventricular tachycardia is monomorphic. And as the name suggests, this is a tachycardia. So the ventricular rate is going to be high, and it is a regular rhythm because it is due to the pathology of ventricles. It is not due to pathology of any nodes or any atria involving the SA or AV nodes. It is arising due to the pathology of ventricles itself. So the rate is going to be high, and the rhythm is going to be regular. It's just that the P waves are being buried in these wide QRS complexes. You are not able to see those P waves. So P waves are normal and the rhythm is also regular, but the P waves are buried inside these wide QRS complexes. So it is tachycardia, so rate is going to be high. The tachycardia means the rate is going to be more than 100. So, and the QRS complex is wide, it is broad, which means it is more than 120 milliseconds or more than 2 or 3 small boxes. It is most commonly due to structural heart disease like cardiomyopathies and scarring after the myocardial infarction, because the scarred wall does not move that efficiently, and there is high risk of sudden cardiac death associated with VTAC. And why does these conditions causes VTAC? We'll see. Imagine there is this scarring present in this ventricular wall. This is the scarring. So normally the impulses are traveling like this from atria into the ventricle. But now, because of these scarring, it causes a re-entry pathway. Where is this re-entry pathway? On the other side of the scar. So this causes the re-entry pathway. Okay, and that causes returning of the impulses, revolving of the impulses in the ventricles, which will cause more ventricular rate, that is called VTEC. Okay. These impulses that have returned through the re-entry pathway will circle back. Okay, and this will keep going on, which will increase the ventricular rate, and it is due to MI, endocarditis, or scarring after the MI, anything. And how do we diagnose this as ventricular tachycardia? There should be more than 3 broad QRS complexes, consecutive QRS complexes, and it is sustained ventricular tachycardia if it is continued for more than 30 seconds, then it is called sustained VTEC. Now polymorphic VT or torsades de pointes. It is polymorphic, so all the QRS complexes are different in morphology, and there is shifting sinusoidal waveforms. It may progress to VFib, long QT interval predisposes to torsade de pointes, and it is caused by drugs, hypokalemia, hypomagnesemia, and hypocalcemia. So it has shifting waveforms. So this is shifting waveforms. It can lead to VFib eventually. Okay, and it is caused by deficiency of electrolytes or drugs. So which are the drugs that causes torsade de pointes? So you have to remember this alphabetically: anti-arrhythmics, antibiotics, antipsychotics, and chloroquine, antidepressants, diuretics, antiemetics, antifungals, and plus nitric oxide. So NO plus Navir and opioids. Navirs and opioids. Navirs are protease inhibitors used in HIV. Okay. Which are the antiarrhythmics? These are 1A and 1A and 3 class of drugs. Another is arsenic antibiotics, that are macrolides and fluoroquinolones, which causes long QT. And there are antipsychotics, which is haloperidol and chloroquine, used in malaria. There are antidepressants, TCA cycle inhibitors, diuretics, there are thiazides, antiemetics, ondansetron, antifungals is fluconazole, FF, and Navir, protease inhibitors, and opioids is methadone. And what is the treatment of torsades de pointes? There will be a question where a patient is coming in with all these symptoms, and if you check the labs, there were deficiency of electrolytes like potassium, magnesium, and calcium, and these are the ECG changes. So what is your next step of management? You administer magnesium sulfate. Okay. And the last is ventricular fibrillation. In ventricular fibrillation, there is no organized rhythm. There is just scribbling in the ECG, like anything like this. There is disorganized rhythm with no identifiable waves, and the treatment is fatal without immediate CPR and defib. You have to start CPR immediately if you see this on the ECG paper, and there will be no pulse detected. But if you do an ECG, you will find these type of pattern. Now the conduction blocks. So conduction blocks are of 3 types: first degree, second degree, and third degree. And then there is complete conduction block. And in second degree, there are 2 types: Mobitz 1 and Mobitz 2. First, we'll see the first degree AV block. So there's an interesting concept or interesting mnemonic that I've come across on academy platform. So the first degree AV block, it has prolonged PR interval. Okay. So it is like a long distance relationship. So whole conduction block was explained in an academy by a long distance relationship situations. So okay, so long distance relationships are hard, man. So as the conduction blocks, if you have it. Okay, so the first degree AV block is a long distance relationship. So the PR is prolonged. PR is the distance between your the boyfriend and the girlfriend, and it is prolonged. So it is a long distance. But initially in the long distance, the PR1, PR2, PR3 all are equal. The PR intervals are equal. Okay, so you can understand it by, if the couple is in long distance, the boyfriend comes to meet the girlfriend every 1 month, right? So initially the boyfriend comes to meet his girlfriend every 1 month. So that is the PR interval, and that is equal initially, like it is 1 month, 1 month, 1 month. The boyfriend comes every month. He is being a good boyfriend. Okay, and so there is no treatment required. It is benign and asymptomatic. It is just that the PR interval has prolonged. Now the second degree AV block. So first is Mobitz type 1, that is wanky back. Okay, and this signifies a bad boyfriend. So wanky back, wanky bad boyfriend. So why is the boyfriend bad? Because first the boyfriend comes to meet the girlfriend at 1 month, then he keeps prolonging the duration to meet, and now the boyfriend will come at 1.5 months, then the boyfriend will come at 2 months, and after that he will not come at all. Okay, so if this is 1 month, this is 1.5 month, this is 2 month, and then he refuses to meet his girlfriend, so there is absent QRS at all. Okay, so there is progressive lengthening of PR interval until a beat is dropped. So the beat is dropped is when boyfriend has not met his girlfriend. Okay, that P wave is not followed by QRS complex. P wave is the girlfriend and QRS is the boyfriend. So the girlfriend is waiting for him, but the boyfriend has not arrived. And variable RR interval with a pattern. So it is regularly irregular. Okay, and there is no treatment required. It is usually asymptomatic. And now Mobitz type 2. So it is a good boyfriend. How is he a good boyfriend? So the boyfriend has explained the girlfriend that, look, I cannot afford to come every month to meet you, so I will come for 3 months every month, like 1 month, 1 month, 1 month, and then I will not come at the fourth month, so that I can save on the traveling expenses. So what is happening is the PR interval is remaining the same. PR1 is equal to PR2, but then they have mutually decided that the boyfriend will not come at the 3rd or 4th month to save the travel expenses. So there is no QRS complex, there is absent QRS complex, and the P wave is still there. Okay, so it is drop beats that are not preceded by a change in PR interval. So now the PR interval is not progressively lengthening. The PR interval is prolonged, but it is remaining the same, but suddenly a QRS complex is dropped, and it may progress to 3rd degree block, as it is usually indicates a structural abnormality such as ischemia, fibrosis, sclerosis, and the treatment is a pacemaker. Or you can remember it as a money maker, because the QRS wave was dropped, the boyfriend has not come because of saving the travel expenses, right? So if you give them a money maker, there will be enough money for boyfriend to travel every month, right? It is a long shot, but it will help you remember. PI remains the same, but QRS stopped suddenly. Okay. Now the third degree AV block, that is the breakup. So P waves and QRS complex both are on their own paths. P apne raste, QRS complex apne raste. So they are rhythmically dissociated. Atria and ventricles beat independently of each other. So all PP intervals are same, all RR intervals are same, but P and R intervals are never the same. Okay. And atrial rate is always more than ventricular rate, because atrial rate is P and QRS complex is ventricular rate. So girls always do better after the breakups. Okay, so atrial rate is more than ventricular rates, and it may be caused by Lyme disease, and the treatment is usually pacemaker. This association is important, and it is called by Lyme disease. As you can see in the ECG, the P waves are normal. The RR waves are also regular, but the P and R waves, PR interval, is not normal at all. So P अपने रास्ते, QRS अपने रास्ते. If you guys know Hindi. Okay. Now the bundle branch block, that is interruption of conduction of normal left or right bundle branches. Affected ventricle depolarizes via slower myocyte to myocyte conduction from the unaffected ventricles, which depolarizes via the faster His-Purkinje system. If these are the two ventricles, this is not functioning. It has this is left ventricle, this is right ventricle. If there is left bundle branch block, so there is no impulses coming in from left ventricle through that bundle branch. But now what will happen? There are myocytes here, right? And there are myocytes here as well. So LV will not get impulses from the His fibers or Purkinje fibers, but it will get impulses from the right ventricular myocytes. These myocytes will generate some impulse which is called myocyte to myocyte conduction, but it is very slow. Okay. It is not as fast as the His-Purkinje system, but RV is normal. There is no right bundle branch block, so there will be bundle branches. Then first there will be bundle of His, then will be right bundle branch, then there will be Purkinje fibers. Okay, so the conduction is normal in the unaffected ventricles. So its myocyte will conduct impulses to the affected ventricle's myocyte. It is commonly due to ischemia in the left ventricle, degenerative cardiomyopathy, infiltrative diseases, changes in the left ventricle. Premature atrial contraction, which is focal atrial tachycardia, extra beats arising from ectopic foci in atria instead of the SA node, often secondary to increased adrenergic drive like caffeine consumption, and it is benign. Okay, because it is due to caffeine consumption, it cannot be much serious. It is benign, and it may increase risk for atrial fibrillation and flutter. There is narrow QRS complex with preceding P waves on ECG. The QRS complexes are normal. It is narrow. Okay. And look, the P waves are abnormal, but they are all the same. Okay. Now PVC, so premature ventricular contraction. They are ectopic beats arising from ventricles instead of the SA node. In premature atrial contraction, extra beats were arising from ectopic foci in atria, and in premature ventricular contraction, beats are arising from the ventricle. So there will be shortened diastolic filling time which will cause decreased stroke volume compared to a normal beat. The prognosis is largely influenced by the underlying heart disease, wide QRS complex with no preceding P waves on ECG. So we talked about that ventricular tachycardia, right? That if this was a scarred tissue and normal impulses were going this way, but now if there is a scar tissue, it can also start beating on its own, start generating impulses on its own. Okay, that will lead to PVCs. So scarred tissue of MI can lead to PVCs, and if there are more than 5 PVCs in a lead, it is called significant. It should be considered significant PVC. Okay, and this is how it looks like on ECG paper. Now the channelopathies. Brugada syndrome is very interesting, and the Dr. Brugada who found this syndrome is still alive and working, and it is an autosomal dominant condition. It was found in, I think, around 1992 or 94, in between that era. And the most commonly it is due to loss of functional mutation of sodium channels, and there is pseudo right bundle branch block and ST segment elevations in lead V1 and V2 on ECG. But this ST elevation is different from that we saw in myocardial infarction, because this ST elevation is a coned ST elevation. In MI we saw that the ST elevation is kind of this, it's like a tombstone, right? But in Brugada it's not like that. In Brugada it is a coned ST elevation. I'll show you what it is. So this is the coning. It is a coned. It is like this. It is coning ST elevation, and it is followed by T wave inversions also. It is not written here, but there are T wave inversions as well, which helps you differentiate it from the MI. ST segment elevations in lead V1 and V2 on ECG, and there are T wave inversions, and also there are pseudo right bundle branch block. So there will be M pattern in the V1 lead and W pattern in the V6 lead, because it is a right bundle branch block, and treatment is sudden cardiac death with ICD. And if the congenital long QT syndrome, earlier we saw long QT syndromes occurring due to the drugs and hypoelectrolytemia, hypokalemia, hypocalcemia, and hypomagnesemia. But it can also be caused by condition that is congenital, which is due to the mutation of KC and Q1 channels, which causes loss of functional mutation of potassium channels. Okay, Brugada was due to mutation of sodium channels, and congenital long QT is due to mutation of potassium channels, which affects the repolarization. Right? If you guys remember that potassium always goes out of the cell, so making the inner side of the cell more negative, that is repolarization. Sodium and calcium always goes inside the cell, so that they will always cause depolarization of the cell, which will make the inner cell more positive. And potassium always leaves the cell, so it will cause repolarization in the cell. So the repolarization will be affected in potassium channels. It includes two syndromes: Romano-Ward syndrome, which does not have deafness, and Jervell and Large Nelson syndrome, which has deafness. Okay. And Romano-Ward is autosomal dominant. Jervell and Large Nelson is autosomal recessive. So there is sick sinus syndrome. It is in old age. So there are bradycardia, sinus pause, sinus arrest, junctional escape beats, and the ECG waves are of low amplitude. They are just slowed down, low amplitude. There can be sinus arrest, or anything. It is because of the degeneration of SA node with age. Okay, so now myocardial infarction complications that we've already talked about. So we'll go through this quickly. And the first is cardiac arrhythmias. The time frame is first few days to several weeks, but is generally in the first 24 to 48 hours. So it is within the first 48 hours post MI. And it can be supraventricular arrhythmias, ventricular arrhythmias, or conduction blocks due to myocardial death and scarring. Important cause of death before reaching the hospital. So patient dies even before reaching the hospital. It is that quick, because if the area containing the conduction pathways is getting infarcted, it will impair the conduction transmission, which will cause sudden cardiac death. And second is peri-infarction pericarditis, usually in the first 1 to 3 days. It presents with pleuritic chest pain, pericardial friction rub with auscultation, ECG changes, or the ECG changes are in pericarditis are diffuse, ST segment elevations, and PR depressions. And this ST elevation is not similar to the myocardial infarction, but it is a concave ST elevation. So it is like this. The MI ST elevation is like this. It is convex, but here it is concave. And it can also result in small pericardial effusion because there is inflammation. There will be fluid accumulation in the pericardium. The third is papillary muscle rupture, which will be caused by macrophages. So macrophages enter the site after 3 days, right? 3 to 7 days. So papillary muscle rupture will also occur in 2 to 7 days. It can result in acute mitral regurgitation. We've talked about that, which can lead to cardiogenic shock. And cardiogenic shock is just less amount of blood volume. It is just the heart not functioning well. The heart is not ejecting the normal amount of blood it used to. So that is cardiogenic shock. And it can also result in severe pulmonary edema, because as the blood from left ventricle can't be ejected more because of the cardiogenic shock, it is regurgitated back into the left atria and into the pulmonary system, and eventually into the lungs, causing pulmonary edema. Okay, and papillary muscle rupture, the posteromedial papillary muscles are more commonly affected rather than anterolateral papillary muscle, as the posteromedial has single artery blood supply, that is PDA, whereas anterolateral has dual LADA plus LCX. Now all 4 of the complications we are going to see are caused by macrophages. This papillary muscle rupture is caused by macrophage, this is macrophage, this is macrophage, and this is macrophage as well. Okay, and this is due to the neutrophils, the inflammation that is caused by neutrophils. Now interventricular septal rupture, it can be due to macrophages, so that is between in the same time frame, that is 3 to 5 or 3 to 7 days. And symptoms can range from mild to severe with cardiogenic shock and pulmonary edema. It is the same symptoms as seen in the papillary muscle rupture. And there is macrophage mediated degradation of the IV septum, so that can lead to ventricular septal defect. So that will lead to left to right shunt, which will cause increase in O2 saturation in right ventricle and increased in pressure because of the increased volume in right ventricle. Fourth is ventricular pseudoaneurysm. It is in the same time frame, 3 to 14 days. It may be in asymptomatic, but symptoms can include like chest pain, murmurs, arrhythmia, syncope, heart failure, or embolus and mural thrombosis. And if that pseudoaneurysm ruptures, it can also lead to cardiac tamponade. which is a grave complication. Okay. And the mural thrombosis is forming because the wall having the pseudoaneurysm. If this is the wall and it has a pseudoaneurysm, there will be stasis of blood here. So that can give rise to thrombus, which will form mural thrombosis, and if it is dislodged, it can form embolus. And free wall rupture is contained by adherent pericardium or scar tissue. That is why it is called pseudoaneurysm, not a true aneurysm, because even if there is an aneurysm here, it is contained by the pericardium or the scarring that is caused by MI. It is the scarring, okay, which is preventing the pseudoaneurysm to burst out. Okay. But now how does then cardiac tamponade occurs? The pseudoaneurysm can still rupture from here, so that will cause fluid to be filled in the pericardial space, which is called cardiac tamponade. Okay. And it does not contain endocardium or myocardium. It just contains pericardium. See, this is the mural. This is the pseudoaneurysm, and it is covered by a thin pericardial membrane. Okay. And pseudoaneurysms, ironically, are more likely to rupture than true aneurysms, because not ironically, obviously it is more likely to rupture because the true aneurysms have all three layers. Like if this is the pseudoaneurysm, it is covered by pericardium, and this is the true aneurysm. It contains all three layers of the heart, so it will be a strong wall. Despite of being an aneurysm, the wall will be stronger. But here there is just a single layer, so it can rupture more easily than the true aneurysms. And ventricular free wall rupture can also occur because of the macrophages in the same timeline. And the free wall rupture can lead to cardiac tamponade, as we talked about, and acute form usually leads to sudden death. Okay. And LV hypertrophy and previous MI protect against the free wall rupture. So LV hypertrophy can be a savior in this condition, like it can withstand the pressure that is being built because of the free wall rupture of the ventricle. And true ventricular aneurysms, it takes 2 weeks to several months after the scarring has occurred. Because the scarring is a weak wall, it is more prone to forming a true aneurysm. And as it is because of the scarring, it will be in the time frame after the 2 weeks, after the role of macrophages is done and the granulation tissue has set in and collagen is trying to set in too. Okay. So that is the time frame after the 2 weeks to several months. So it is similar to pseudoaneurysm. Symptoms may include chest pain, murmur, arrhythmia, syncope, heart failure, embolus from mural thrombosis, and if it ruptures, it can lead to cardiac tamponade too. And there's outward bulge with contraction, and it is disc, which causes dyskinesia. So whenever, if this is a left ventricle and this is a small aneurysm here, so now if the ventricle is contracting, the bulge will be appearing bigger because the blood from the left ventricle enters that aneurysm, making it bulge, making it bigger, and it is associated with fibrosis. As we talked about, it is due to the scarred wall. And last is post-cardiac injury syndrome. It takes weeks to several months. It is due to the fibrinous pericarditis due to autoimmune reaction, that is Dressler syndrome. Okay, here it is, the Dressler syndrome. And the cardiac antigens released after the injury, deposition of immune complexes in pericardium. Okay. This is the free wall rupture. This is free wall rupture. This is the pseudoaneurysm, which is covered by the pericardium. And I think this is the papillary muscle rupture. Yeah, it is the papillary muscle rupture. Okay. These are the muscles which is binding this is the valve, and the papillary muscles are used to stretch that valve. Now if the muscle is broken here, mitral valve can't be closed completely or open completely. It becomes a regurgitant impaired valve. Acute coronary syndrome treatments. The syndromes are treatments are not supposed to be summed up just in a paragraph. It's a huge topic, but okay, again, for the sake of step 1, this is enough, I think. If it's just unstable angina or NSTEMI, so there is no ST elevation. There's just anticoagulation, which can be done by heparin. There's antiplatelet therapy. It is aspirin plus ADP receptor inhibitors, that is clopidogrel, and beta blockers, ACE inhibitors, statins, and symptom control with nitroglycerin, and plus or minus morphine, which depends on the patient's needs. And the STEMI, in addition to above, reperfusion therapy is most important. Percutaneous coronary intervention, PCI, preferred over fibrinolysis. So fibrinolysis is that alteplase, reteplase, tenecteplase, all that. It is pharmacological, and PCI is interventional. If right ventricle is affected, RCA occlusion support venous return preload to maintain the cardiac output. Because if right ventricle is affected, it might happen that the function of right ventricle, systolic function of right ventricle, decreases. So what we do is we increase the venous return, which will increase the preload in the right ventricle. So there will be enough cardiac output maintained. So we can avoid systolic dysfunction setting in. Okay. And how do we maintain the venous return? By IV fluids and avoiding nitroglycerin, because nitroglycerin does vasodilation of the peripheries, so that will decrease venous return. We don't want that in RVF if RV is affected. Now the cardiomyopathies. Cardiomyopathies, the first is dilated cardiomyopathy. It is the most common cardiomyopathy, 90% of the cases. It is often idiopathic or familial. And familial, it is due to the mutation of TTN gene encoding the sarcomeric protein titin. And other etiologies includes drugs, alcohol. Drugs include alcohol, cocaine, and doxorubicin. Infection, Coxsackie B virus, Chagas disease. Chagas disease, it is caused by the Trypanosoma cruzi, and it also leads to megaesophagus, megacolon, and megaheart, that is dilated cardiomyopathy. It can also be caused by ischemia, like coronary artery disease, systemic condition like hemochromatosis, sarcoidosis, thyrotoxicosis, wet beriberi. Wet beriberi has heart. In wet beriberi, there is dilated cardiomyopathy, but in dry beriberi, there is no circulating blood volume changes. Okay. The heart is spared in the dry beriberi. And peripartum cardiomyopathy, that occurs during the birth to the mother. And findings are heart failure, S3 is there. If heart failure is there, S3 is always there, because our S3 signifies heart failure. Okay. There is systolic regurgitant murmur, because it's a systolic dysfunction. It is a systolic dysfunction. So whenever heart is trying to undergo systole, there will be a murmur, and that will be a regurgitant murmur. And dilated heart on echocardiogram, balloon appearance of heart on chest X-ray. The treatment is sodium, just symptomatic, and lifestyle changes. It is sodium restriction. Then ACE inhibitors, ARBs, which decreases both preload and afterload. Is beta blockers, which decreases the myocardial oxygen demand. And sacubitril, which is most specifically used in heart failures. It is a neprilysin inhibitor, I think, and neprilysin metabolize all other bradykinins, histamine, serotonin, acetylcholine, all that. So if we inhibit the neprilysin, all those metabolites will increase. And there are diuretics, mineralocorticoids receptor blockers like spironolactone, digoxin, ICD, and finally heart transplant. And in DCM there is eccentric hypertrophy. So what is eccentric hypertrophy? The filaments are arranged in series. Okay. If it's concentric hypertrophy, the fibers will be arranged in parallel, increasing the thickness of the wall that we will see in hypertrophic cardiomyopathy. So see, sarcomeres are added in series. And it is similar to an athlete's heart, where the stroke volume and cardiac output has increased. But in here there is increased preload, but it is a systolic dysfunction, so there will still be reduced stroke volume and reduced cardiac output. Okay. And there's another point is stress cardiomyopathy. It is also called Takotsubo cardiomyopathy, broken heart syndrome. It is a ventricular apical ballooning, likely due to increased sympathetic stimulation or in stressful situations. Okay. There was a case on House MD. It was pretty interesting case. The guy was undergoing a heartbreak because I think his crush or something married his best friend or something like that, and he was in heartbreak for years to come, and he was diagnosed with Takotsubo cardiomyopathy ultimately, and it is called broken heart syndrome as well for that reason. Okay. And dilated cardiomyopathy stretches the heart rate, and it can also stretch the valves, causing the regurgitation of valves. So it can cause secondary mitral regurgitation. There is no S4 here. Okay. Now you guys should be knowing that why S4 is not present here, because as I've said, S4 is present only when atria is pushing the blood across the normal valves into non-dilated, non-compliant ventricle, only in non-dilated ventricle. So here the ventricles are dilated, so there will not be any S4s. Okay. In hypertrophic cardiomyopathy, 60 to 70% of the cases are familial autosomal dominant, most commonly due to mutations in gene encoding sarcomeric proteins such as myosin binding protein C and beta myosin heavy chains. So 60 to 70% of the cases are familial as compared to DCM, and it is autosomal dominant. It is due to mutations in the gene coding myosin binding protein C and beta myosin heavy chains. DCM was due to gene mutation, the TTN gene mutation encoding protein titin. Here it is myosin binding protein C, MBPC, and beta myosin heavy chains. It can cause syncope during exercise and may lead to sudden death in young athletes. It can cause syncope during exercise and may even lead to sudden deaths in young athletes. There are so many movies and shows that depicts young athletes uh, dying suddenly on the field during when they are exerting. It is because those athletes have hypertrophic cardiomyopathy, and during exertion they can die due to the ventricular arrhythmias. Because why does ventricular arrhythmias occur? Because there is such a thick wall, right? So there arises multiple ectopic foci that can give rise to impulses, okay, and that will lead to arrhythmia. There shouldn't be any ectopic foci other than SA node and AV node, but because the wall is so thick of left ventricle, it can give rise to ectopic foci of impulse generations. And if you've seen that movie lately, the Bollywood movie Jersey, which was played by Shahid Kapoor, in that movie it's a real story that a cricket player was suffering from hypertrophic cardiomyopathy, and he did die suddenly on the field. He collapsed on the field, and later his doctors told everyone that he was suffering from hypertrophic cardiomyopathy and he was told not to play cricket because of that same reason. And findings are S4 and systolic murmur. S4 is present here because the atria is contracting across normal walls into non-dilated ventricles. It is hypertrophied here, and non-compliant ventricles because it is hypertrophic here. So it is not very compliant, and may see mitral regurgitation due to impaired mitral valve closure. And the treatment is cessation of high intensity athletics, use of beta blockers or non-dihydropyridine calcium channel blockers, verapamil, that blocks L-type calcium channels, and ICD if high risk, and avoid drugs that decrease the preload because already the cavity of the left ventricle is smaller, so it is not accumulating the normal amount of preload, and if we decrease the preload furthermore, it can worsen the condition more. So we have to avoid the drugs like diuretics. It causes diuresis, and it results in less blood volume, hence the less preload. And vasodilators causes peripheral pooling of the blood, which will decrease venous return and which will decrease the preload. Okay, so we have to avoid diuretics and vasodilators. So there is diastolic dysfunction, obviously, because this heart can contract further, but as the sarcomeres are arranged tightly in the parallel sense, it is not viable to dilate all these fibers, the sarcomeres that are arranged in parallel series. It displays ventricular concentric hypertrophy, that is sarcomeres arranged in parallel sense, and often septal predominance. The septum, this is the septum, often that is predominantly hypertrophied. And myofibrillar disarray and fibrosis is also present. It is classified as hypertrophic obstructive cardiomyopathy when LV outflow tract is obstructed. Because of the predominance of interventricular septum, which is as the interventricular septum is affected the most from hypertrophic cardiomyopathy, what it does is this hypertrophic interventricular septum will obstruct the outflow tract. The outflow tract is just here, right? Be it aorta or the pulmonary artery. So as the IV septum is hypertrophic, it is going to obstruct the outflow tracts, and the LV outflow tract is more obstructed, then the right ventricle outflow, and asymmetric septal hypertrophy, and systolic anterior motion of mitral valve. Causes outflow obstruction that will lead to dyspnea and and possible syncope. Okay. And if we now decrease the preload furthermore by stenting or Valsalva, the obstruction will increase even more, and the intensity of the systolic murmur will increase even more. That we've seen in that table, if you remember, guys, right? That mitral valve prolapse and hypertrophic cardiomyopathy are only two conditions whose murmur increases in the intensity whenever the preload is decreased. All other murmurs decrease in intensity when the preload is decreased. Another causes of concentric LV hypertrophy is chronic hypertension to compensate for the increased afterload, and second is Friedreich's ataxia. Okay. And the third and the last is restrictive or infiltrative cardiomyopathy. So you have to remember this mnemonic of please help. It is post-radiation fibrosis, Loeffler's endocarditis, endocardial fibroelastosis, amyloidosis, sarcoidosis, and hemochromatosis. Please help. So what is endocardial fibroelastosis? It is caused in young children, and it is thick fibroelastic tissue in endocardium of young children. So the endocardium has now fibroelastic tissue that is very thick, and it does not allow the ventricles to move. So it restricts the movement of the ventricles, causing restrictive cardiomyopathy. So it also causes diastolic dysfunction. Okay, it can have low voltage ECG despite thick myocardium, especially in amyloidosis. Why the ECG voltages are very low? Because the heart is not moving much. Okay, the movement of the heart is restricted, and if the heart is not moving much, it is also not going to cause the spikes we see in the ECG. It will cause the spikes, but it will be of very low amplitude, like this, compared to the normal. Okay, these are low voltage ECG spikes. And what is Loeffler's endocarditis? It is associated with hyper-eosinophilic syndrome, and histology shows eosinophilic infiltrates in the myocardium. So the inflammation is caused by eosinophils here, and accumulation of eosinophils causes endocardium and myocardium fibrosis. Okay. And it causes endocardium and myocardium fibrosis. So whenever there is fibrosis, there is loss of movement. It restricts the movement of heart wall. So heart failure. Heart failure is the clinical syndrome of cardiac pump dysfunction. It can cause congestion and low perfusion of the organs. Symptoms include dyspnea, orthopnea, fatigue, and signs include S3 heart sounds, because whenever there's heart failure, there's S3 sound present. Jugular venous distension because of the backflow of the blood from right atria into the jugular vein. And pitting edema can also be there. Systolic dysfunction is heart failure with reduced ejection fraction. Heart is not able to eject the normal amount of blood it used to. So that is called reduced ejection fraction. And there is increased and diastolic volume and decreased contractility. Okay. The increased end diastolic volume is because there is increased end systolic volume, there is reduced ejection fraction. So that increased end systolic volume will act as increased amount of blood. It will act as the add-on amount of blood for the next diastole cycle. Okay. And there is decreased contractility. Obviously, it is often due to secondary to ischemia, MI, or dilated cardiomyopathy or valvular problems, or even COPD. Diastolic dysfunction is the heart failure with preserved ejection fraction. So there is diastolic dysfunction. The heart is not able to fill itself to the full potential. So there is no problem with the ejection fraction. It will eject the amount that is being filled in the left ventricle. Okay, but the EDV is normal here. Okay. And there is decreased compliance. So the end diastolic volume is going to be normal, but as the heart is unable to diastole more, that normal amount of end diastolic volume will also cause increase in the end diastolic pressure. Okay. Because the ventricles are not able to diastole in order to accumulate that normal amount of end diastolic volume. So the compliance decreases and the end diastolic pressure of the ventricle increases, and it can often occur secondary to myocardial hypertrophy. Okay, that we saw here, that in hypertrophic cardiomyopathy and restrictive cardiomyopathy there is diastolic dysfunction. Okay, and right heart failure most often results in left heart failure, because the blood because if there is right heart failure, the blood is going to regurgitate back into the body, which will again be regurgitated back into the left heart, causing left heart failure. Sorry, I said the opposite. So left heart failure will cause the right heart failure. Okay, because if the left heart is not able to eject the blood properly, it will get accumulated into the pulmonary systems, and from pulmonary systems the blood will get accumulated into the right ventricle, causing blood overload in right ventricle and eventually causing right heart failure. And the cor pulmonale refers to the isolated right heart failure due to pulmonary cause. Okay, there is no left heart included. What is the treatment? ACE inhibitors, ARBs, angiotensin receptor, and neprilysin inhibitors, that is sacubitril, beta blockers, except in acute decompensated heart failure, and aldosterone receptor antagonist decrease the mortality in HF-REF. Loop and thiazide diuretics are used mainly for symptomatic relief, and hydralazine with nitrate therapy improves both symptoms and mortality in selected patients. Now, what are the symptoms of left heart failure and right heart failure? So in the left heart failure, there is orthopnea, PMD, and pulmonary edema. So why does orthopnea occurs? And remind you that left heart failure is mostly heart failure with reduced ejection fraction. So shortness of breath when supine, there is increased venous return from redistribution of blood. Immediate gravity effect exacerbates pulmonary vascular congestion. So now what happens is, if the patient is lying supine, the venous return is going to increase, right? Because the legs are at the level of the heart. So all of the blood that was pulled will come back to the heart, increasing the venous return. First it will come back into the right atria, then right ventricle, then into the pulmonary circulation, and then it will come to the area that is the problem, that is the left heart. So the all the preload, all the increased preload that is coming back into the left atria and left ventricle will get pooled there, right? Because it cannot go further than left ventricle. The left ventricle is not able to eject that increased amount of preload into the aorta because it is failed. It has failed. The left heart failure is there, which is mostly reduced ejection fraction. So all the blood will revert back from LV into LA into the pulmonary circulation, causing pulmonary vascular congestion. Okay, and this is because the patient was lying supine. The venous return increased, and increased pulmonary vascular congestion will lead to shortness of breath. And it is the same mechanism in paroxysmal nocturnal dyspnea. So whenever the patient is sleeping in supine position, the patient will wake up from shortness of breath because the patient is lying supine. Okay, so whenever the patient is lying supine, the venous return will increase, and because of the redistribution of blood, and vascular congestion will occur, and that will cause shortness of breath, which will result in awakening of the patient. It's called breathless awakening. And the peripheral edema reabsorption also occurs while the patient is supine. Now, third is pulmonary edema. So, because the blood is being reverted back from LV into LA into pulmonary circulation, the pulmonary venous pressure is going to increase, and it will cause pulmonary venous distension and transudation of fluid, and there is presence of hemosiderin laden macrophages. Okay, so there is pulmonary venous distension, right? If now, how does this hemosiderin laden macrophages develop, which is called heart failure cells in lungs? So if this is the interstitium of the lung, and this is the pulmonary vein, okay, and here are the macrophages, those type 1 and type 2 alveolar cells. So now the pulmonary venous distension has occurred, right? There is increased amount of blood incoming from left atria and left ventricle into the heart. So now these macrophages are getting more blood, and in blood there is iron. So these macrophages accumulate iron in themselves, and that is called hemosiderin laden macrophages. Let's see how it looks. See, these are hemosiderin laden macrophages, which will seem a little red to brown. Okay, this is the brown pigment in this is hemosiderin. See, there is accumulation of hemosiderin in all these macrophages, so they are turning dark red to brown. Okay. Now in right heart failure, right heart failure is mostly the diastolic failure. Right heart failure is mostly heart failure with preserved ejection fraction. So what happens is, this is right ventricle, right atria, and there are veins coming in from all over the body, like hepatic vein, inferior vena cava, superior vena cava, into the right ventricle. But now the right ventricle has failed, the right heart has failed. So what it will do is, the blood is not going to get accumulated in right ventricle much, so it gets revert back, and it is now accumulated in the end organs from where the veins were coming. So the first case is congestive hepatomegaly. So the blood will accumulate in the liver and will cause congestive hepatomegaly, and the central venous pressure increases. There is resistance to portal flow, and it can also lead to cardiac cirrhosis because of the hepatic congestion. It is associated with nutmeg liver. It is mottled appearance. The normal, if this is the norm, this is the normal liver. It is of yellow color, and the nutmeg liver has dilated arteries in between, dilated central veins, which will gives rise to red dots in yellow liver. But let's just see. Okay. Yeah, this is, see, these are dilated arteries, and jugular venous distension. The blood is regurgitating back into the superior vena cava and into the jugular veins, causing increased JVP, jugular venous pressure. And there is peripheral edema as well. The venous pressure has increased, which will cause the fluid to go out. This is fluid transudation. Also, in right heart failure, there is peripheral edema too, and in liver cirrhosis, independent liver cirrhosis, there is peripheral edema too. And so how can you differentiate both of them? How can you differentiate both of them? By JVP. Okay, the JVP will be higher just in right heart failure, not in edema due to liver cirrhosis. Okay, both the patient will look alike because there is peripheral edema. There can be nutmeg liver, which is due to right heart failure. Now you have to differentiate that either is it nutmeg liver due to the right heart failure, or is it just right heart failure, okay, or is it just liver cirrhosis. If it's just liver cirrhosis and right heart is not involved in any sense, there will be no increased JVP, or there will be no distension in the jugular vein. Okay, and these are the graph. These are pressure volume graph. And in HF-REF, there is systolic dysfunction, right? So contractility of heart has decreased, and this is end systolic volume, this is end diastolic volume. So end diastolic volume has increased. The graph has moved to the right side. As we saw in HF-REF, the end diastolic volume is increased, and in diastolic dysfunction, the EDV is normal, but end diastolic pressure has increased. So in this graph, pressure volume, this is HF, preserved ejection fraction. So there is increased pressure for a particular amount of end diastolic volume. So end diastolic volume is being the same, and systolic volume is being the same, but for a certain volume, the pressure has increased from this level to this level. Okay, so the end diastolic pressure has increased. So the graph moves upward, and the end diastolic volume is normal. Here, end diastolic volume has increased, and systolic volume has also increased. So EDV is increasing as a result of end systolic volume. Okay. This is a pretty easy chart, but it just looks very terrifying. These are the basic things that you already know. Let's just immediately quickly go through this. So whenever is cardiac output low, it activates sympathetic tone, it activates RAS. If sympathetic tone is increased, catecholamines beta 1 and catecholamines alpha 1. Now if you've studied pharmacology, you know that alpha causes constriction AC, alpha causes constriction AC, and beta causes vasodilatation. Okay. So and beta 1 also increases heart rate, inotropy and chronotropy. So heart rate is increased and contractility is increased, so cardiac output is now maintained through that mechanism. And if contractility is increased, stroke volume is also increased. Now through catecholamine alpha 1 and angiotensin 2 and ADH through V1 receptor, which are activated by the RAS system, they cause vasoconstriction. Okay, alpha 1 causes vasoconstriction. It constricts both arteries as well as the vein. Okay, so if they are constricting the arteries, the blood pressure is going to increase and it will be maintained. If the BP is maintained, the cardiac output is also maintained. Okay, and if they are constricting the veins, if you constrict the veins, peripheral veins, the venous return to the heart is going to increase. So that is increasing the preload, which will further increase the stroke volume. And angiotensin 2 and aldosterone reabsorbs sodium, so hence increasing the circulating blood volume. And the ADH through V2 is aquaporin. The V2 increases the circulating volume. ADH V2 is used in kidneys to reabsorb water in collecting tubules. So they both increase the circulating volume, which increases the venous return to the heart. Okay. So whenever there is hemodynamic stress or neurohormonal stress, cardiac remodeling occurs, which decreases the cardiac output. So high output cardiac failure, it is an uncommon form of heart failure characterized by increase in cardiac output. So the high output state is due to decreased systemic vascular resistance from either vasodilatation or atriovenous shunting. The causes include severe obesity, advanced cirrhosis, severe anemia, hypothyroidism, wet beriberi, and Paget's disease of bone. Okay, so there is very low systemic vascular resistance, so it increases the cardiac output. Okay, and it presents with symptoms and sign of pulmonary or systemic venous congestion. Okay, now shock. So shock is inadequate organ perfusion and delivery of nutrients necessary for normal tissue and cellular function. And initially it may be reversible, but life-threatening if not treated promptly. So first we'll get the basic idea of what each type of shock is. So in hypovolemic shock, the amount of blood is low in the body. Why is the amount of blood low? It can be due to hemorrhage, that is blood loss, dehydration, or burns, that is fluid loss. In cardiogenic shock, the heart is not functioning properly, so heart can't push blood into the body. Obstructive shock is heart is not able to push blood because of the obstruction of right ventricle. Okay, so it is pretty much the similar case as to cardiogenic shock, but in cardiogenic shock the pathology was in the heart itself, like MI, heart failure, vascular dysfunction, arrhythmia and all that. But in obstructive shock there is another factor that is enabling the heart to push the blood. Okay, so heart not able to push the blood due to obstruction. What are these obstructions? This is cardiac tamponade, pleural effusion, tension, pneumothorax, all that. And fourth is distributive shock. We'll see distributive shock later. It is in the there is a decrease in the systemic vascular resistance. Okay. Now let me just first highlight a few things. Okay. Now we are good to go. So first is hypovolemic shock. It is caused by hemorrhage, dehydration and burns, and the mechanism is volume depletion. So there is less amount of blood overall in the body, right? And the main physiological disorder, all these double arrows, those are the physiological disorders that is doing all the things. So first, in hypovolemic shock there is left heart preload. Okay. This is central venous pressure, this is pulmonary capillary wedge pressure, cardiac output, systemic vascular resistance and SVO2. So there is decreased left heart preload in hypovolemic shock. So there is less amount of blood overall in the body. So there will be less amount coming into the venous return will decrease, less amount is coming into right atria, right ventricle, and as a result there is less amount in left atria and left ventricle. So that is left heart preload, the amount of blood coming into the left ventricle that has decreased. Now whenever the preload is decreased, the cardiac output is automatically decreased. So we know that right heart preload is also decreased because of the decreased venous return. So whenever there is decreased preload, it will result into decreased cardiac output. And to compensate that decreased cardiac output, what body does initially in hypovolemic shock is it increases the systemic vascular resistance. There is vasoconstriction occurring, which will increase the systemic vascular resistance. Okay, so if cardiac output is decreasing, the systemic vascular resistance will increase, and the SVO2 is decreasing obviously because the perfusion of the organs is decreasing. There is less blood, so there is less oxygen traveling in the body. Okay, and now I want you guys to remember this thumb rule, that if preload decreases, cardiac output inevitably decreases, and if the cardiac output is decreasing, it is going to do two things. It is going to increase the preload. How? Because if the cardiac output is decreasing, the heart is not ejecting much blood, then that blood is left into the left ventricle, which will be used as preload in the next cycle. So if the blood is not being ejected, it will be accumulated in the left ventricle, that is increasing the preload. And the second thing it will do is it will increase the systemic vascular resistance in order to compensate for the less blood volume. Okay. Here decreased preload is resulting into decreased cardiac output, but if cardiac output is already decreased, then it will accumulate the preload, it will increase the preload, and it will increase the systemic vascular resistance. this thumb rule will help you remember all of the mechanisms of all the types of shock. Okay. Okay, now we'll see cardiogenic shock, where the heart is not able to eject blood. The heart is not functionally efficient to push out the blood. In other words, the cardiac output of the heart has decreased. So that is the main physiologic disorder in cardiogenic shock, that cardiac output has decreased because heart is not functioning well enough. So as per this rule, if the cardiac output is decreased, the preloads are going to increase. So here it is, the preload has increased and systemic vascular resistance has also increased. And if the cardiac output is less, there is less blood volume circulating, there will be decreased SVO2. In obstructive shock, it is due to cardiac tamponade, pleural effusion, tension, pneumothorax, and it has the same mechanism. Like if there is obstruction, the heart is not able to push blood, so the cardiac output has decreased. That is the main physiological disorder. And if the cardiac output is decreased according to this rule, the preloads are going to increase and systemic vascular resistance is also going to increase, and SVO2 obviously decreases. The last one is distributive shock. Distributive shock occurs in sepsis, in early stages of sepsis, in anaphylaxis and CNS injury. So what is the main physiological disorder in distributive shock? In sepsis, anaphylaxis, if you know anaphylactic shock, if you know an allergic reaction, there is vasodilation of the arteries of the face, there is flushing, there is edema and everything. So in short, vasodilation is occurring, and if the vasodilation is occurring, there is decrease in systemic vascular resistance. So the main culprit here is decreased systemic vascular resistance. So now if the systemic vascular resistance is decreased, heart can push the blood very easily, so the cardiac output is going to increase. And if the cardiac output has increased, the preloads are going to decrease. And now if the cardiac output has also increased, the SVO2 or organ perfusions is going to increase. It is in sepsis and anaphylaxis. In CNS injury, there is slightly different case. In CNS injury, there is sympathetic inhibition. Okay, whenever there is CNS injury, there is sympathetic inhibition. So it is going to decrease the systemic vascular. If the sympathetic inhibition is there, always there is vasodilation, right? So vasodilation will cause decreased systemic vascular resistance, but because the sympathetic inhibition is there, the inotropy and chronotropy of the heart is also going to be diminished. So the cardiac output is also going to be decreased, and as a result of decreased heart rate, because sympathetic inhibition is there. And if the cardiac output is and as there is a systemic vascular resistance, so there is more pooling of the blood in the peripheries, so the venous return has also decreased and preload has also decreased. So basically everything decreases in CNS injury distributive shock. Okay. And the SVO2 is normal to slightly increased because of the compensation that of the organs, they pull in more oxygen than normal situations. Okay, so hypovolemic shock, it is due to the left heart preload decrease. Cardiogenic shock is due to decrease in cardiac output, which will lead to increase in both the preloads. Obstructive shock is also due to decreased in cardiac output, which will lead in increase of both the preloads. And distributive shock is due to decrease in systemic vascular resistance, which will cause increase in cardiac output, which will cause decrease in preloads. Okay. Mostly hypovolemic shock is asked, so you should be remembering that by heart, that it is the left heart preload that is decreasing, and which is the main physiological disorder, that left heart preload is decreasing. Every other thing is because of that. So the cardiac output, if the preload is low, as per this law, if the preload is low, the cardiac output is also going to be low, and systemic vascular resistance is going to increase to compensate for the decreased cardiac output. Now we'll see cardiac tamponade. It is compression of the heart by fluid. It can be blood or effusions, and as the heart is compressed, it will not allow the heart to eject blood, which will cause decreased cardiac output. Equilibration of diastolic pressures in all four chambers. Initially, the diastolic pressure was more negative in right ventricle during inspiration, right? Because it has to fill itself during the inspiration. There was negative pressure in right ventricle, but now, as fluid surrounds everything, if this is the heart, earlier what was the case, that this is intrathoracic cavity. During inspiration, there is negative pressure here, which was reflecting on right ventricle. It was pulling the walls of right ventricle, so there was also negative pressure in right ventricle. So the venous return was increasing during inspiration. But now, what is the case? There is cardiac tamponade, so there is fluid everywhere. Okay, this is the fluid. So now the external changes in the pressure, like the negative pressure of ITC, is not going to affect the pressures in the right ventricles, and so there is equilibration of diastolic pressures in all four chambers. Findings: it is backstriad, so it is hypotension, distended neck veins, and distant heart sounds. Hypotension because the cardiac output has decreased, left ventricle is not able to eject much blood, so systolic blood pressure is going to decrease. Distended neck veins because right atrium and right ventricle are not able to fill themselves up because of the pressure of the pericardial fluid, because of the pressure of the cardiac tamponade that is on them. So that blood is accumulated in the venous system in jugular vein, which causes distended neck veins, and it is distant heart sounds or muffled heart sounds. Now the heart rate is increased. Okay. The heart rate is increased in order to compensate for decreased cardiac output, and there is pulsus paradoxus. What was pulsus paradoxus? I forgot. Subnormally large decrease in stroke volume, systolic blood pressure. Pulsus paradoxus, I guess it is decrease in, refers to an exaggerated fall in patient's blood pressure during the systolic blood pressure decreases by more than 10 mmHg. Oh, it's given here. It is decrease in amplitude of systolic blood pressure by more than 10 mmHg during inspiration. Okay, we'll see that later on. The ECG shows low voltage QRS complex and electrical alterance. So that is due to swinging movement of heart in large effusions. So heart is swinging in this pericardial fluid. So it causes electric alterance. Like one of the QRS complex will be of higher amplitude, then another will be of lower amplitude, then another will again be of higher amplitude, like that. So this is altering. This is electrical alterance. and there will be low voltage QRS complexes. Echocardiogram shows pericardial effusion. Okay, this is the pericardial effusion, all this. Systolic right atrium collapse, diastolic right ventricle collapse, and IVC plethora. So why does right atrium collapse occur during systole? If right atrium is trying to contract, the pericardial fluid present or the cardiac tamponade is going to exaggerate that contraction and is going to push RA further more inside. Okay, because so that it collapses. And diastolic RV collapse. And the treatment is pericardiocentesis or surgical drainage. Impulsus paradoxus is decrease in amplitude of systolic BP by more than 10 mmHg during inspiration, and it causes increased venous return during inspiration, increased RV filling. So interventricular septal bows towards the left ventricle due to decreased pericardial compliance. Okay. So that causes decreased LV ejection volume and decreased systolic BP, which is seen in constrictive pericarditis, obstructive pulmonary disease, croup, OS, obstructive sleep apnea, asthma and COPD and cardiac tamponade. So what is occurring here? If this is the heart, this is LV, this is RV. So during inspiration, we know that RV filling is going to increase, right? And now if RV filling is going to increase, it is going to dilate, but there is pericardial fluid all around here, which does not allow the right ventricle to do so. Okay, this is pushing RV against itself. So now what happens is RV, right ventricle, has nowhere to go, nowhere to dilate to, so it dilates towards the left ventricle, and that causes decrease in the volume of left ventricle. It causes decrease in left ventricular filling, and if the left ventricle filling has been impaired, the cardiac output is also going to decrease. LV ejection volume is going to decrease, which further causes systolic BP drop. It is more than 10 mmHg. Normally there is a bit dip in the systolic BP during inspiration, but it is never more than 10. If it is more than 10, it is pulsus paradoxus. Okay. Effective endocarditis. The infection of endocardial surface of the heart, typically involving more than one heart valves. Here is the infection of endocardial surface involving more than one heart valves. It is caused mainly by bacteria, then fungi, and it forms acute and subacute. Acute is mainly caused by Staph aureus. So Staph aureus is a highly virulent bacteria, right? So it can even affect the previously normal valves, whereas in subacute, it is caused by bacteria Strep viridans, and they are not as virulent as Staph aureus, so they need previously diseased valves. Okay, so there should be some kind of disease previously on the valve, like rheumatic fever or any kind of immunosuppression should be there. Okay, or the valves should have been bicuspid aortic valve or something like that. So these are large destructive vegetations on previously normal valve, and it is rapid onset because it is acute. As you can see, these are the vegetations here. They are pretty large vegetations if you see them closely. In subacute, It is caused by viridin streptococci. It is low virulence, and there are smaller vegetations on congenitally abnormal or diseased valve, right? As I told you, and it is following some kind of immunosuppression or some kind of procedures which can make you prone to that bacteria, like dental procedures, which allows pathway for strep viridins to travel from dentures to the heart, and is of gradual onset. It presents with fever, new murmur, vascular and immunological phenomena. Okay, there are very few conditions that presents with murmur, new onset murmur, and a fever. One is pericarditis, second is endocarditis. Okay, sometimes there is fever in myocardial infarction too. Okay, but there's vascular and immunological phenomena present as well in endocarditis. So what are the vascular phenomena? Vascular phenomena are septic embolism, patasia, uh, splinter hemorrhages. These are linear hemorrhagic lesions on the nail bed. So you can see these are the linear hemorrhagic lesions, and another is Janeway lesions. It is painless, flat erythematous lesions on palms or sole. These are Janeway lesions, and they are painless. We will compare them with Osler's nodes, which are very painful. Okay, and yeah. So now the immunological phenomena. So immune complex, it is due to the immune complex deposition at various sites. If it gets deposited in the kidneys, it will cause glomerulonephritis. It will cause inflammation because it is antigen antibody complex. Okay, type 3 hypersensitivity. Then is Osler nodes, which are painful, raised violaceous lesions on finger or toe pads. So if you can see here, these are very violaceous, raised, and you can see there is inflammation, and that inflammation is due to the antigen antibody complex accumulation, that are called Osler nodes, and they are very painful. And the last is Roth spots, which are retinal hemorrhagic lesions with pale centers. So this is an hemorrhage, right? Because it is red and there will be a pale center. Okay, that is called Roth spots. The immune complex damages the retinal layers, so that causes hemorrhage there. It is called Roth spots. The mitral valve is the most commonly involved valve, then aortic valve. And tricuspid valve involvement is associated with drugs. Okay, don't try drugs. And common associations are prosthetic valves with staph epididymis, GU procedures, enterococcus because of gastrointestinal enteric system. So enterococcus, you can remember it like that. Colon cancer as galolyticus, just formerly known as S. bovis. Gram negative HASAC organisms, Haemophilus aggregatibacter, which was formerly called actinobacillus, which sounded much better than aggregatibacter. Cardiobacterium, Kinginella, and if it is culture negative, it can be Coxiella burnetii or Bartonella henselae. And injection drug use, it can cause Staph aureus, the most virulent one, which can cause endocarditis on a previously normal valves. Then there's Pseudomonas, then is Candida, which is fungal. We only came across one fungi here that causes endocarditis, and that is Candida. So what is the pathology behind endocarditis? First, there will be endothelial injury, and there is formation of vegetations consisting of platelet, fibrin, microbes. These platelet and fibrin clots are attracted towards the endothelial injury site, which is on the heart valves, and due to these fibrin and platelet and microbes clot, it will form a vegetation like we saw here on the valve, and that vegetation will impair the function of the valve and make it regurgitant, which will cause valve regurgitation or septic embolism. because some platelet, fibrin or cholesterol emboli can lodge from that vegetation and form embolism, and that embolism can enter the systemic circulation because mitral and aortic valve are affected and they are both on the left sided heart, and pulmonary, and it can also if the vegetation has developed on the right side, it can enter the pulmonary circulation and cause pulmonary embolism. Diagnosis requires multiple blood cultures, okay, and echocardiography. There should be vegetations present on echo. That is one of the diagnostic criteria. There are major and minor criterias and all that. Okay. Now the non-bacterial thrombotic endocarditis is also called merantic endocarditis, which is very rare and non-infective. Okay. Vegetations typically arise on mitral or aortic valve and consist of sterile platelet-rich thrombi that dislodge easily. Usually asymptomatic until embolism occurs. It is associated with hypercoagulable states. So hypercoagulable states can form thrombus, which can lead to emboli. It is seen in advanced malignancy, especially pancreatic adenocarcinoma. It is not very sure how pancreatic adenocarcinoma leads to hypercoagulable state or SLE. Due to SLE, it is called Libman-Sachs endocarditis in this setting. Okay. So there is no infection, there is no bacteria or fungi involved here. It generally occurs because of hypercoagulable state, stasis occurs, and due to that hypercoagulable state, thrombus and emboli is formed on the valves. And it is sterile, so there is no bacteria involved, and it is platelet-rich thrombi. Now, rheumatic fever. It is a consequences of pharyngeal infection with group A beta hemolytic streptococci. And it is a late sequelae include rheumatic heart disease. First there is rheumatic fever, and then a few years later there is rheumatic heart disease, which affects mostly the mitral, aortic and tricuspid valve, just like the endocarditis. And high pressure valves are affected most, and there is early valvular regurgitation and late valvular stenosis. And rheumatic heart disease always starts with mitral valve. It will not affect aortic valve directly. First, it will always affect mitral valve. Then it can travel to aortic valve too. Is associated with Ashkoff bodies. Ashkoff bodies, and this is the Ashkoff body. This whole is called Ashkoff body, and it is a granuloma with giant cells, and those and in that granuloma with giant cells there is also Ashkoff cells, and Ashkoff cells are the macrophages. These are the macrophages with ovoid wavy rod-like nucleus. So it has wavy rod-like nucleus. If you can see closely in this, there is a rod-like nucleus in this cell, in this cell, in this cell. Okay, we'll see other images as well. And there is increased anti-streptolysin O and anti-DNase B titers. So that indicates group A beta hemolytic streptococci infection. So let's see other images. Okay, this is blurred image. This is a diagram of Eshkoff's body. So this here is the wave-like nucleus, that is Eshkoff cells. Look, this is a wave-like Eshkoff cells, and together with that cells plus granuloma, it forms Eshkoff bodies. See. This is the Eshkoff cell. Come on. Okay, just leave it. So this is an immune mediated type 2 hypersensitivity. Okay, there's just antigen and antibody involved. There is no immune complexes. If there were immune complexes involved, then it will be type 3 hypersensitivity. And type 2 hypersensitivity, it is because of deposition of antigen and antibody. It is not because of the bacteria itself, but the bacteria, that is group B strep, secretes M protein that acts as the antigen. Okay. So there are antibodies to M proteins and antibodies that are formed against these M protein antigens. But what it does is these antibodies cross react with myosin antigens of the heart. Okay, there are myosin filaments in the heart that acts as antigens. So it is autoimmunity, kind of autoimmunity, and it is this pathogenesis is called molecular mimicry. So treatment of prophylaxis include penicillin. The major criteria is the mnemonic itself, Jones joint. It is migratory polyarthritis. Migratory polyarthritis is the pain that moves along the joints. One day there is pain in the knee joints, another day the pain is in the ankle joints, and the third day the pain is in hip joints, like that. Second is carditis, myocarditis, endocarditis, pericarditis, all that. And the third is nodules in skin, that is subcutaneous nodules. Fourth is erythema marginatum. It is a ring-like rash, evanescent rash with ring margin. And fifth is Sydenham chorea. It is involuntary irregular movements of limbs and face, and it is dancing-like movements of limb and face of bilateral limbs. Okay. It is not unilateral, it is bilateral. Now syphilitic heart disease, and the cause of death in rheumatic fever is myocarditis. And now syphilitic heart disease. So tertiary syphilis disrupts the vasa vasorum of the aorta with consequent atrophy of vessel wall and dilatation of aorta and valve ring. I explained you this in the abdominal aortic aneurysm section. Like, if this is the vessel, this is the vessel wall, there is the blood vessels called vasa vasorum, which supplies the wall of the big vessel. So these are vasa vasorum. Now tertiary syphilis disrupts these vasa vasorum. So now the wall is not getting enough oxygen. Not getting enough oxygen will make it weak, and if this is weak, it can be dilated pretty much very easily. And if it is near the aortic root and the aortic valve, and it is dilating both the sides, it will pull apart the aortic valve and it will cause aortic root dilatation, which will in turn cause aortic regurgitation. This aortic root is connected to aortic valve, so now the valve is getting pulled too. It will cause aortic regurgitation, and it may see calcification of aortic root, ascending aortic arch, and thoracic aorta, and it leads to tree bark appearance of aorta. So why is the tree bark appearance? So the bark of the tree is dilated, then its upper branches, right? So if this is the aorta, it is being pulled apart, aortic root dilatation is occurring. So aortic root will be dilated, and the aorta, the descending aorta and aortic arch is not dilated that much. So this causes an appearance like tree bark appearance. It can result in aneurysm because the wall has now weakened, because there is less oxygen in the vessel wall, of aneurysm of ascending aorta or aortic arch, and it can cause aortic insufficiency, that is regurgitation. If the aortic regurgitation is occurring, there will be compensatory LV dilatation, and that dilatation will be eccentric hypertrophy in order to accumulate more blood regurgitating back into the left ventricle. Acute pericarditis. So acute pericarditis is the inflammation of the pericardium. So in echocardiogram, you will see the signs of inflammation. There is fluid accumulation, there is wall thickening. Okay. So sorry, this is the fluid accumulation in the pericardial layers. Inflammation of the pericardium, it is commonly presents with sharp pain, aggravated by inspiration and relieved by sitting up and leaning forward. So you can differentiate this pain with myocardial infarction, which is not relieved by sitting up or leaning forward or anything like that. And it is often complicated by pericardial effusion, because there is inflammation, there will be fluid accumulation, which results in pericardial effusion. And it presents with friction rub on auscultation. And ECG changes include widespread diffused ST segment. It is diffused ST segment elevation. Okay, not in just one or two leads. MI will be just in the leads of the wall that has infarcted, but in pericarditis there will be diffuse ST segment elevation in all of the leads, and there will be PR depressions as well. The causes includes surgery, any cardiac surgery, connective tissue disorders, cardiovascular events like acute MI or Dressler syndrome, that is autoimmune pericarditis, then autoimmune diseases like SLE, rheumatoid arthritis, radiation, renal failure. Renal failure leads to increased ammonia, right? The ammonia can't be excreted outside of the body, so the ammonia increases in body, and that will lead to uremia, and that will lead to pericarditis. Idiopathic, which is the most common reason overall, and if it is idiopathic, it is presumed that it is viral, and viral is due to Coxsackie B virus. And then there's neoplasm. The treatment is just very simple. You have to give NSAIDs for pain control and for inflammation control. And then there's colchicine, which will decrease the uric acid amount in the body. Sorry, this is not due to ammonia, but I think it should be due to uric acid. Then glucocorticoids to control the inflammation if it is very severe, and then dialysis to get rid of that uric acid and ammonia. Now, myocarditis. Myocarditis is inflammation of the myocardium. There's global enlargement of heart because myocardium is very thick. The pericardium was thin, but the myocardium consists of most of the wall of the heart. And if that is inflamed, it will go thickening, so that will result in global enlargement of the heart and dilatation of all the chambers. Okay, it is global enlargement and dilatation of all the chambers, and it is a major cause of sudden cardiac death in adults less than 40 years old. Okay. The presentations are highly variable. It can include dyspnea, chest pain, fever, arrhythmias. The arrhythmias is persistent tachycardia out of proportion to fever is characteristic. So with fever there is also tachycardia present, like for each 1 degree Celsius of rise in body temperature, I think there is a increase of 10 beats per minute in heart rate. If the temperature is going 39, then there's tachycardia of 110. If there's 40, then there's 120. 41, then it's 130 beats per minute. Okay, something like that. For each 1 degree of temperature rise, the tachycardia rises by 10 beats per minute. So yeah, there is persistent tachycardia which is out of proportion to fever. So there's not much fever in myocarditis, but the tachycardia is out of proportion to fever. So tachycardia will be 140, 150, but the fever will still be like normal to very less high. So we can figure out that something is wrong with the heart because the tachycardia is out of proportion to fever. It can have multiple causes like viral, which includes adenovirus, Coxsackie B, Parvo B19, HIV, HHV6. Parvo B19 is a very specific cause for myocarditis. Then there's lymphocytic infiltrate with focal necrosis, highly indicative of viral myocarditis. Because it is viral, it will have lymphocytic. If it was bacterial, then we will have neutrophilic infiltrates. And then there's parasitic, which includes Trypanosoma cruzi, which causes Chagas disease. Then there's Toxoplasma gondii. Bacterial includes Borrelia burgdorferi, Mycoplasma, Corynebacterium diphtheria. Then there's toxin, which includes carbon monoxide, black widow venom. Don't know what that is, black widow venom. And rheumatic fever. Then there are drugs, doxorubicin and cocaine. Autoimmune disease like Kawasaki, sarcoid, SLE, polymyositis, dermatomyositis. And the complications include sudden death, arrhythmias, heart block, dilated cardiomyopathy. Because the myocardium is dilating, there is global enlargement of the heart that can lead to dilated cardiomyopathy, heart failure, mural thrombus, with systemic emboli, because if once the myocardium is dilated, there's global enlargement of heart, there will be systolic dysfunction. So the blood will get accumulated into the left ventricle. There will be stasis, which can give rise to thrombus and systemic emboli. And the sudden death is due to arrhythmias. Now we are at the last section of the pathology. It's the cardiac tumors, and the most common cardiac tumor is metastasis. For example, melanoma. So what are the other metastases other than melanoma that can cause secondary cardiac tumor? There are breast cancer, lung cancer, lymphomas. Okay. Now we'll talk about myxoma. Myxoma is the most common primary cardiac tumor in adults. And 90% of them occurs in the atria, mostly left atrium. And myxomas are usually described as a ball wave obstruction. So with the contraction of the heart in echocardiogram, you can actually see the myxoma moving with it too. So it is described as ball wave obstruction in the left atrium. It is associated with multiple syncopal episodes. There is history of multiple syncopes. Okay. And there's IL-6 production by tumor, which causes the constitutional symptoms. Constitutional symptoms are mostly caused by the IL-1, IL-6 and TNF-alpha, right? And if it is malignancy, it is mostly caused by IL-6. Production by tumor, constitutional symptoms that includes fever and weight loss, which goes hand in hand with every malignancy. And you may auscultate early diastolic tumor plop sound. So ventricular diastole is actually an atrial systole. So when atria is contracting, the myxoma moves with the contraction, and if it is striking the wall of the atria, it causes a tumor plop sound. Okay, this is very specific. It will be given in the question that tumor plop sound is heard, which mimics mitral stenosis, and it is heard in the mitral area. Okay, and it's a diastolic murmur. And if it is given that it is a plop sound and there is history of constitutional symptoms as well, you are dealing with myxoma. The murmurs and symptoms worsen in upright position and improve when lying down. Because if this is the heart, this is left atria, this is the myxoma. So now if you are standing upright due to gravity, and here is the mitral valve. If you are standing upright, the myxoma will move towards this side. It will block the mitral valve and it will worsen the murmur as well as the symptoms. And now if you are lying still, if you are lying, this is your left atrium, this is your mitral valve, and here is the myxoma. Myxoma moves this side, and so the valve is opened, and the symptoms and the murmurs both are decreased. Okay. Histology shows gelatinous material with myxoma cells immersed in glycosaminoglycans. Okay, so gelatinous material is eosinophilic materials, and myxoma cells are purple cells. In pink eosinophilic background. So you can see this is the pink gelatinous material, and these myxoma cells are basophilic and it is immersed in that background. Okay. These basophilic dots are the myxoma cells, which is immersed in the pink gelatinous eosinophilic background. Okay. And there's rhabdomyomas. It is the most frequent primary cardiac tumor in children. Atrial myxoma is most common in adults, and rhabdomyoma is most common in children. It is associated with tuberous sclerosis. Tuberous sclerosis is a neurocutaneous disease, right? So there is brain involvement and there is skin involvement. So brain involvement includes seizures and epilepsy and all that, and the skin involvement is like black tuberous scars on the face, around the forehead and around the nose area. Okay, let me show you. I was lucky enough to see one patient of tuberous sclerosis in wards, which came with the complaint of seizures and all. And it was a female, and both the female and her mother had these similar kind of spots on their faces. Okay. And histology will show hamartomatous growth. So what is hamartoma? It is normal kind of cells, but it is at the wrong place. Okay, it is normal kind of cells, but the growth is abnormal. Okay, so and it is more common in the ventricles, unlike myxomas. How is the small sign? It is paradoxical rise in JVP on inspiration. Normally, when there's inspiration, there's negative intrathoracic pressure, which increases the venous return. Which should decrease the JVP. But in small sign, there is paradoxical increase in JVP. So now we'll see why that happens. So if there's impaired RV filling, the RV cannot accommodate increased venous return during inspiration. So blood backs up into the vena cava, which causes small sign. Okay. And may be seen with constrictive pericarditis, restrictive cardiomyopathy, right heart failure, massive pulmonary embolism, right atrial or ventricular tumor. So basically, the small sign is present whenever there is impaired RV filling or RV obstruction is there, which impairs the right ventricle to fill itself to accommodate the venous return, increased venous return, that is during the inspiration. The RV cannot accommodate increased venous return. Why can't it accommodate increased venous return? Because there is some kind of obstruction like constrictive pericarditis, which does not allow the right ventricle to diastole much. Then there's restrictive cardiomyopathy, which has the similar reason. Then there's right heart failure, which can cause diastolic dysfunction, so right ventricle can't diastole. There is massive pulmonary embolism, so it blocks the outflow. So now right ventricle can't push much blood into that pulmonary vessel because there's an embolism down the road. So the blood backs up into right atrium and the jugular veins. Now, or if there is a right atria or ventricular tumor which is causing an obstruction to the blood flow. Okay. So this is jugular vein, this is right atrium, this is right ventricle, this is pulmonary vessels. So anything that is an obstruction here, like restrictive cardiomyopathy, constrictive pericarditis, or anything here that is myxoma, anything here that is rhabdomyoma, anything here, that is pulmonary embolism, will cause backflow of the blood into the jugular vein, which will cause jugular venous distension. You can easily see jugular venous distension if it is increased. You need in wards you need not measure JVP every time with those two rulers, with one ruler placed on the sternum and one ruler placed on the JVP. If the JVP is severely increased, you can see the earlobe of the patient bulging upwards every time there's a wave. Okay, so A wave is the most positive wave. So whenever there's an A wave, it will lift the earlobe up. Okay. And there's hereditary hemorrhagic telangiectasia. It is also called Osler-Weber-Rendu syndrome, and it is an autosomal dominant disorder of blood vessels. And the findings include blanching lesion, that is telangiectasia, on skin and mucous membranes, and it causes recurrent epistaxis and atriovenous malformations, which can be in brain, lung, and liver. If it is in brain, it can cause hemorrhage at any time. If it is in lung, it can cause hemorrhage there. If it is in liver, it can cause congestion and all there. If it is in gastrointestinal tract, it can cause lower GI bleeds. If it is in renal system or urinary tract system, it can cause hematuria at any point of time. And the name itself tells you everything, that it is hereditary, it is autosomal dominant, it is hemorrhagic, so there will be hemorrhages, and there is telangiectasias. So telangiectasias are just lesions of blood vessels, lesions made up of blood vessels. There are telangiectasias, then there are reticular veins, and then there are varicose veins. So telangiectasias, I think, is the smallest one, or the second smallest one after the reticular veins. So they are present in skin and mucous membranes, and they can be easily breakable, which can lead to hemorrhages at any point of time. Okay, so we are done with pathology finally. Whew. So now we'll see the pharmacology section, and we'll start with the treatment of hypertension. So first, we are going to see the treatment of primary essential hypertension that does not cause any kind of secondary end organ damage. So essential hypertension treatment includes thiazides, ACE inhibitors, ARBs, and dihydropyridine calcium channel blockers. And hypertension with heart failure contains beta blocker in addition to all of the above drugs. There are diuretics, ACE inhibitors, ARBs, and aldosterone antagonists. And beta blockers must be cautiously used. Beta blockers must be cautiously used in decompensated heart failure, and they are contraindicated in cardiogenic shock because they have negative inotropic effects, right? And if there's cardiogenic shock, there is already decreased cardiac function, and if we are going to even decrease the inotropy, that is going to worsen the condition. Okay. And in heart failure, ARBs may be combined with neprilysin inhibitor sacubitril. So sacubitril is a neprilysin inhibitor, and neprilysin, I think, is it degrades all of those bradykinin, serotonin, everything. So positive inotropes. So sacubitril inhibits the neprilysin. Hypertension with diabetes mellitus, we can give ACE inhibitors, ARBs, and they both are protective against diabetic nephropathy, right? And calcium channel blockers, thiazide diuretics, and beta blockers. And beta blockers can mask the hypoglycemia symptoms, because the symptoms of hypoglycemia, as we know, is tachycardia, tremors, and sweating and all that. But if we give beta blockers, it will inhibit the tachycardia and tremors, but it will not inhibit sweating. So sweating can still indicate that there's hypoglycemia, but it is masked by the beta blockers we just gave. In hypertension and asthma, we can give ARBs, calcium channel blockers, thiazide diuretics, cardioselective beta blockers. And we have to avoid the non-selective beta blockers because they can cause bronchoconstriction, which can exaggerate asthma attacks. And we have to avoid ACE inhibitors to prevent the confusion between drug or asthma related cough. So ACE inhibitors causes cough, angioedema and all that. And yeah, so we have to avoid that to prevent confusion between the drug or asthma related cough. In hypertension in pregnancy, we have to give nifedipine, methyl dopa labetalol, hydralazine. Okay, if you have been to an labor room or OBGY ward, there's nifedipine 20 mg that they give very commonly. Okay, so there's a mnemonic too. New moms loves hugs. So new moms means the pregnancy, indicates pregnancy. So it is nifedipine, methyl dopa, labetalol, and hydralazine. This table looks kind of scary, but it isn't. Okay. Let me just draw it again for you guys. So this is the smooth muscle cell. Okay, I'll make this quick. So this part indicates contraction, and this part indicates relaxation of the smooth muscle cell. So first we'll see the calcium channels. This is the L type calcium channels that lets calcium inside, which binds to calmodulin and forms calcium calmodulin complex. So there is calcium coming in from a different site as well, that is sarcoplasmic reticulum. And how is this sarcoplasmic reticulum activated in order to release the calcium? It is activated by IP3. And how is IP3 activated or released? By the receptor GQ. And what are okay, we'll see the agonists later. And what GQ activation also does is it releases Rho kinase. Now, so how does contraction and relaxation actually occurs in the smooth muscle cell? So there's, as we know, myosin and actin filaments. So when the myosin is phosphorylated, there's contraction occurring, and when the phosphorus is released, it causes relaxation. And this step is done by MLC kinase because a phosphate is added, and this step is done by MLC phosphatase because phosphate is removed. Okay. So now what happens is calcium calmodulin complex stimulates or activates MLC kinase. So there will be more phosphorylation of myosin occurring, hence the contraction. And what will Rho kinase do? It will inhibit MLC phosphatase. So if MLC phosphatase is inhibited, the myosin will stay in the phosphorylated position and it will result in prolonged contraction. It's that simple. Okay. And now I'm going to simplify this whole method for you. Not this whole method, but I'm going to simplify this whole step for you so that you can remember it. You don't have to remember this much detail. You just have to remember that CAMP causes relaxation by inhibiting the MLC kinase. Okay. This is a GS receptor. Here we saw GQ receptor. Here it is GS receptor, which is activated by beta 1 and beta 2 receptors. Now if G1 is activated, it will activate adenylate cyclase. Okay, and there's one other thing. In this relaxation part, you have to just remember two things, that ATP and AMP, whichever you want to remember, is converted into CAMP initially. So AMP is first converted into ATP and then to CAMP, but let's just remember that ATP is converted. Okay, we are going to make things easier, simpler. And here it is GTP converting into CGMP. And ATP is converted into CAMP by adenylate cyclase because it is cyclic AMP, and GTP is converted into CGMP because of guanylate cyclase. So now you just have to remember that CAMP inhibits MLC kinase, so myosin will not be phosphorylated and it will stay in relaxed state. The smooth muscle cell will stay in relaxed state. You just have to remember that. You don't have to remember that CAMP is converted, activates protein kinase A and it then inhibits for phospholamban B to its receptor, which will cause the calcium influx in sarcoplasmic reticulum, which will then cause relaxation. You don't have to remember all these things. Okay. And what does CGMP do? CGMP actually activates MLC phosphatase. So phosphate will remove quickly and the smooth muscle cell will return into relaxation state quickly. So now we saw the adenylate cyclase and guanylate cyclase. The other thing I want you guys to remember is CAMP is converted into ATP through PDE5 phosphodiesterase. Sorry, not 5, 3. And CGAMP into GTP by PDE5. 3 because A comes first in the alphabet, and G is PDE5 because G comes later, and 5 also comes later after 3. Okay, is there anything left? Yeah, one other thing, that here is a natriuretic peptide receptor. Natriuretic peptide receptor which stimulates guanylate cyclase. So the hormones like ANP, BNP, and the drugs like naciretide, they all act on natriuretic peptide receptor, which will stimulate guanylate cyclase, which will then stimulate MLC phosphatase, and it is also stimulated by nitric oxide. Yeah, and now we'll see the drugs acting on it. and there's another thing left. There is another receptor, GI. I stands for inhibition. GI will inhibit adenylate cyclase. Hence, it will cause contraction. That is why it is kept in the contraction side. Okay. Now we're all set. Let's choose a different color. Yeah, it's the same. So first we'll talk about the L-type calcium channel. L-type calcium channels are inhibited by dihydropyridine calcium channel blockers, that is amlodipine, clevidipine, nicardipine, nifedipine. Okay, it inhibits these, so it inhibits the contraction. Then there's hormones that act on GQ receptors. If you know that GQ is acted upon by alpha 1 agonist, so epinephrine can act through alpha 1 receptors. Then there's endothelin, angiotensin. In short, any hormones that you know which can cause vasoconstriction. Okay, you know endothelin cause vasoconstriction, angiotensin to vasopressin. The name itself tells you that it causes vasoconstriction. So it will stimulate the GQ receptors. Now, GI receptors. GI, if you know, it is acted upon by alpha 2. So if you don't know it, guys, it is the mnemonic is Q, KISS. Alpha 1, alpha 2, beta 1, beta 2. Okay. So I is acted upon by alpha 2 agonist. That is epinephrine, which acts by alpha 2. Now GS agonists are epinephrine that acts by beta 2. And there's prostaglandins, phenoldiazepam, any hormones or drugs that you know that causes relaxation or vasodilation. Then the PDE3 is inhibited by milrinone. So if PDE3 is inhibited, the CAMP will not be converted to ATP. CAMP will increase and it will inhibit more MLC kinase, hence the relaxation will increase. And PDE5 is inhibited by sildenafil. And I obviously told you guys about ANP, BNP, and naziretide. They act on natriuretic peptide receptors. And when you give nitrates, you give nitric oxide. And also one other thing, this, where is this nitric oxide coming from? So nitric oxide is coming from endothelial cell. This is endothelial cell, this is the lumen. Endothelial cell is the border of the vessel, and this is the lumen, and this is the smooth muscle cell. So in lumen there are hormones like acetylcholine, alpha-2 agonist, bradykinin, histamine, serotonin, all those hormones that are responsible for vasodilatation are present there, and there's a receptor for all of them. This is the receptor all these hormones bind to. And these receptors will act on the calcium storage and will make the calcium release into the endothelial lumen. That calcium release it will activate nitric oxide synthase. So L-arginine is now converted into nitric oxide, and these nitric oxide diffuses into the smooth muscle cell. And there's also bacterial lipopolysaccharides that provides nitric oxide synthase that converts L-arginine into nitric oxide. Okay, we are done. Yeah, CAMP, don't get confused with that CAMP. CAMP increases cardiac contractility, but it decreases smooth muscle contractility. CAMP increases cardiac contractility, but CAMP decreases smooth muscle contractility. Okay, so as we saw, this is the calcium channel blockers that is inhibiting the L-type calcium channel, so which will inhibit calcium calmodulin complex formation. There is GQ agonist, all these that acts on GQ receptor that will cause IP3, which will cause calcium calmodulin complex, rho kinase, which will inhibit MLC phosphatase. There's GI agonist, alpha-2. Alpha-2 acts on GI. GI is inhibited. I stands for inhibition. GI will inhibit adenylate cyclase. That will reduce the CAMP, hence causing contraction. GS agonist. These are S is for B2. There's prostaglandin, prostacyclin. All these causing vasorelaxation, vasodilatation. It will stimulate adenylate cyclase, hence CAMP will increase. There's CAMP is converted into AMP. CAMP is converted into AMP through PDE3. PDE3 is inhibited by milrinone, and GTP is converted into CGMP by guanylate cyclase, and CGMP is converted into GMP or GTP by PDE5. PDE5 is inhibited by sildenafil. CGMP activates MLC phosphatase, causing dephosphorylation of myosin chain that causes relaxation in the smooth muscle cell. Guanylate cyclase is activated by two things: nitric oxide and natriuretic peptide receptor, that are ANP, BNP, and acetaldehyde. Nitric oxide is provided by the nitrates that we give, and it can be provided by the endothelial cells. It can be provided by endothelial cells because of the binding of all these hormones to their receptors, causing release of calcium that stimulates nitric oxide synthase, which converts L-arginine into nitric oxide. It is also nitric oxide is also provided by the bacterial lipopolysaccharides. Whew. Okay. Done. So calcium channel blockers. It includes amlodipine dihydropyridines and non-dihydropyridines. Dihydropyridines include amlodipine, clevidipine, nicardipine, nifedipine, amlodipine, all of them with suffix dipine, and it acts on vascular smooth muscles, as we just saw. And non-dihydropyridines that act on cardiac muscle, that is heart. Now the mechanism is it blocks voltage gated L-type calcium channels of cardiac and smooth muscle, so that decreases calcium, that decreases muscle contractility by decreasing calcium calmodulin complex. And for vascular smooth muscle, amlodipine and nifedipines are the most effective, followed by diltiazem and verapamil. Even being the non-hydropyridines, they are more effective than the other dihydropyridines. And in heart, of course, the non-hydropyridines are more effective, so verapamil and diltiazem, followed by amlodipine, nifedipine. Its clinical uses are dihydropyridines are used in hypertension, angina, including vasospastic type, because it is known for vasodilating the vessels. Then it's Raynaud's phenomenon, which is vasospasm of the peripheral arteries in the upper limbs. So dihydropyridine mainly dilates the arteries, so it will be helpful in all of these conditions. Like in hypertension, it will cause vasodilatation, so the BP will increase. In angina, it will dilate the coronaries, so that will be helpful. In Raynaud's, it will decrease the ischemia formation in the fingers, and except nimodipine, because nimodipine is used in nimodipine can cross blood-brain barrier, so it can prevent cerebral vasospasm. So it's most of the effect of nimodipine is shown in cerebral vessels, so it can be used in subarachnoid hemorrhage. Yeah, that is important. Okay. Now, nicardipine, clevidipine, they are used in hypertensive urgency or emergency. And non-dihydropyridines are used in hypertension, angina, atrial flutter, and atrial fibrillation. Because we just saw that on heart, and non-dihydropyridine works better. So verapamil and diltiazem are used in atrial fibrillation or flutter. So the adverse effects are gingival hyperplasia. The effect of dihydropyridine is peripheral edema, flushing, dizziness, because it is all of these effects are due to vascular smooth muscle relaxation. The non-dihydropyridine side effects are cardiac depression, AV block, and hyperprolactinemia, and constipation. Depression and AV block is because it slows the conduction, right? Hyperprolactinemia, it is because due to decrease of dopamine levels that is seen with calcium channel blockers. Now we'll see the hydralazine. Hydralazine increases CGMP levels that causes smooth muscle relaxation. We just saw that CGMP activates MLC phosphatase that will dephosphorylate myosin faster. So we can write here hydralazine stimulates CGMP, increases CGMP that causes smooth muscle relaxation. And hydralazine AA vasodilates veins, more arterioles more than veins. And the second A stands for afterload reduction. Afterload reduction because it is relaxing the aortas and arterioles more than the veins. Its clinical use is severe hypertension, particularly acute heart failure, and it is safe to use during pregnancy. And in heart failure, it is used with organic nitrates. And it is frequently co-administered with beta blocker to prevent reflex tachycardia. Adverse effects are compensatory tachycardia. It is contraindicated in angina and coronary artery disease. It causes fluid retention because of vasodilatation, or edema is not going to occur. Edema is not going to occur, but there's pooling going to occur, peripheral blood pooling, headaches, and angina, and drug-induced lupus. Hypertensive emergency. You have to treat with labetalol, clevidipine, phenoldiazepam, nicardipine, and nitroprusside. So nitroprusside is a short-acting vasodilator. It activates arteries and veins. It dilates arteries and veins equally. And how does nitroprusside act? It increases CGMP via direct release of nitric oxide, and it can cause cyanide toxicity. So you can write here nitroprusside provides nitric oxide, which will increase CGMP. Okay. Nitric oxide will activate guanylate cyclase, which will convert GTP into CGMP, and it can cause cyanide toxicity. Phenoldiazepam. The word itself suggests that it is related to dopamine D1 receptor agonist. So it vasodilates coronaries, peripheral, renal, and splanchnic arteries. It decreases BB, obviously because of vasodilatation, and it increases natriuresis. Also used post-operatively as an antihypertensive. It can cause hypotension, tachycardia, flushing, headache, and nausea. Nitrates. Nitrates include nitroglycerin, isosorbide dinitrate, and isosorbide mononitrate. We already saw that nitrates provide nitric oxide, and it activates guanylate cyclase, which will increase CGMP, which will activate MLC phosphatase. Okay. It dilates veins more. That you have to compare it with hydralazine. Which vasodilated arteries more than veins. Okay. Nitroprusside vasodilates both of them equally. And if it is dilating the veins more, it is going to decrease the venous return, right? Because there will be venous pooling in the peripheries. So the venous return is going to decrease, the preload is also going to decrease. Sorry, I don't know if I said increase the venous return or decrease the venous return, but it will decrease the venous return, it will decrease the preload. The clinical uses angina, acute coronary syndrome, and pulmonary edema. Because you gotta vasodilate in all of those three conditions. Adverse effects is reflex tachycardia, which can be treated with beta blockers. It can cause methemoglobinemia, hypotension, flushing, headache, and Monday disease. In industrial nitrate exposure, let's see that, and development of tolerance for the vasodilating action during the work week, and loss of tolerance over the weekend, which will cause tachycardia, dizziness, and headache upon exposure. It's contraindicated in right ventricular. So Monday disease occurs in those industrial workers where there is high nitrate exposure. So what nitrate will do throughout the week from Monday to Friday, it will cause vasodilatation and all that, but there will be tolerance developing throughout the week, but on weekends there will be no nitrate exposure, right? So the tolerance has gone, and now when the workers go on their shift on Monday again, the tolerance has gone, so the nitrates will cause tachycardia, dizziness, and headache upon re-exposures. It is contraindicated in right ventricular infarction, hypertrophic cardiomyopathy, and with concurrent PDA 5 use. It is contraindicated in right ventricular infarction, hypertrophic cardiomyopathy, and concurrent PDE 5 inhibitor use, that is sildenafil. Anti-anginal therapy. The goal is to reduce the myocardial O2 consumption by one or more of the determinants of MVO2. That is end diastolic volume, blood pressure, heart rate, and contractility. So now we'll compare all the different drugs with their effects. So first is we'll see the component wise. First we'll see the end diastolic volume. So as nitrates vasodilate, so the end diastolic volume is going to decrease. Beta blockers have no effect, and nitrates plus beta blockers gives no effect to decreased effect. Blood pressure is going to decrease with all of them, with both of them. The contractility is going to increase with nitrates and decrease with beta blockers. It is negative ionotrope, chronotrope. And if we give both of them, there is little to no effect. That is why beta blockers are given with nitrates. So there is no effect on, that is in heart rate. Okay, sorry. So heart rate increases with nitrates, contractility increases with nitrates too, and heart rate increases with nitrates too. But beta blockers can nullify the tachycardia, so it is given with nitrates. So beta blocker is given with nitrates to reduce the reflex tachycardia. This is reflex tachycardia. And ejection time, it is decreased with nitrates, and it is increased with beta blockers, because beta blockers slows down the heart, so heart has more time to eject out the blood. Okay. And if you mix both of them, there is little to no effect, and MVO2 is decreased by both of them. And if you combine both of them, there is additional decrease in myocardial O2 consumption. So it is always beneficial to use them together. And verapamil is similar to beta blockers. in effect. Verapamil is non-dihydropyridine, and so that is why it will have effect on heart. Pindolol and acebutolol are partial beta agonists that should be used with caution in angina. Okay, we'll keep that in mind. Now it's ranolazine. It inhibits the late phase of inward sodium current, thereby reducing the diastolic wall tension and oxygen consumption. It does not affect heart rate or blood pressure. So as we saw that action potential graphs, if you remember, this phase was caused by sodium inward current. So it inhibits the late phase. So this is the late phase of inward sodium current, thereby reducing the diastolic wall tension and oxygen consumption. And it does not affect heart rate or blood pressure. So if this late stage is just inhibited, removed altogether from the contraction of the heart, then there will be obviously reduced oxygen consumption, because heart does not have to undergo depolarization now. So depolarization is contraction. Heart does not have to contract that much, decreases the contraction, hence the oxygen consumption, and it is not affecting the heart rate, because you see, as in anti-arrhythmics, anti-arrhythmics used to prolong this cycle, right? Hence decreasing the heart rate. Here there's nothing like that happening. It is just inhibiting the late phase, that too the late phase of the inward sodium current. So clinical use is in refractory angina. Refractory angina is all other drugs that had no effect on that angina. That is called refractory angina. So the adverse effects are constipation, dizziness, headache, and nausea. Sacubitril, it is an apellysin inhibitor. It prevents the degradation of bradykinin, natriuretic peptides, angiotensin 2, that is vasoconstrictor, and substance P. So it will cause vasodilatation and decreased ECF volume. So as we talked about, these all hormones are metabolized by neprilysin. And sacubitril itself inhibits neprilysin. So now these hormones will not be metabolized for longer duration. Its clinical use in combination with valsartan. And the dose is asked in your prof exam. I think it's valsartan is 51 mg and this is 49 mg combination. The adverse effects are hypotension, hyperkalemia, cough, dizziness, and it is contraindicated with ACE inhibitors due to angioedema, because both drugs are increasing the bradykinin, and bradykinin also causes cough. The ACE inhibitors also causes cough. And it also causes hypotension and hyperkalemia as its adverse effect. Now the lipid-lowering agents. Okay, you also don't have to remember the whole of this chart. I will simplify it and draw just the things that you should be remembering. Okay. First there's liver, then there's blood vessels, then there's intestine. So in liver, acetyl-CoA is converted into HMG-CoA. HMG-CoA is converted into mevalonate and then into cholesterol. But you just have to remember that HMG-CoA is converted into cholesterol by an enzyme HMG-CoA reductase. Okay, and then cholesterol is LDL also converts into cholesterol. And the cholesterol now formed will be converted into VLDL that will be transferred to the blood vessels. And there's triglycerides coming from chymogen remnants in the blood vessels. So somehow chymogen remnants end up in liver from the blood vessels, which are converted into the triglycerides, and the triglycerides gets converted into VLDL as well. So now all the VLDL that has been formed in the liver will travel to blood vessels and will form two things. First is the LDL and the second is free fatty acids. And it is activated by PPAR alpha. Yeah. And the free fatty acids form will obviously go into the adipose tissue for storage. And the LDL that is being formed in the blood will travel back into the liver to be formed into the cholesterol again. So this whole cycle. Okay. And yeah, there's this intestine from which cholesterol and bile is being absorbed, and both of them together will be formed into a chymogen, and that chymogen will be transferred into the blood vessels. And then from blood vessels, as I said, it is formed into HDL and free fatty acids, and in chymogen remnants are formed into triglycerides in the liver. But you don't have to remember all of that. You just have to remember that cholesterol and bile are absorbed from intestine and formed into chymogen. There's also HDL that I talked about, that chymogen gives rise to HDL that goes into the liver through HDL receptor, and that also gets converted into cholesterol. So LDL, HDL and HMG-CoA, all three of them gets converted into cholesterol somehow. Now we are going to see the drugs. So first we are going to start with statins. Okay, or if you want to let's just see theory. Okay, as we talked about, there's this HMG-CoA reductase. Okay. Then there's this cholesterol forming from LDL, HDL and HMG-CoA. That cholesterol is converting into VLDL that is being transferred into the blood, and in blood it is going to form into free fatty acids and LDL is first, free fatty acids is second. That free fatty acids goes into the adipose tissue, and it can be brought back into the blood by lipolysis whenever needed, and this LDL goes back into the liver through LDL receptor and gets converted into the cholesterol again. And this cholesterol, free fatty acids and bile acids, all three of them are absorbed from the intestine and formed into chymogen. And that chymogen goes into the blood, gives rise to HDL, free fatty acids and chymogen remnants through ApoE receptors, gets into the liver to form triglycerides and again cholesterol. So there are four things that are giving rise to cholesterol in the liver. First is LDL, HDL, HMG-CoA, and chymogen remnants. Okay, so the first group of drug in lipid-lowering agents. They are all lipid-lowering agents, right? So they will lower the lipids. So what lipids we want them to lower? LDL is the bad cholesterol, HDL is the good cholesterol, so we obviously want the bad cholesterol to decrease. So they all are going to decrease LDL, increase HDL, and decrease the triglycerides. But the bile acid resins that we are going to see, that increases the bile acid reabsorption, that inhibits the bile acid absorption from the intestinal lumen. Those are the only class of drugs that slightly increases the triglyceride. So first is HMG-CoA reductase or statins. There's atorvastatin, simvastatin. It inhibits the conversion of HMG-CoA to mevalonate. It inhibits HMG-CoA reductase. So that will reduce cholesterol. That is our ultimate goal. It will increase the LDL receptor recycling. So the receptors are going to recycle. So there is not much new LDL needed. So eventually the LDL levels are going to drop. It will increase LDL catabolism. It decreases mortality in patients with CAD. Okay. Its adverse effect is hepatotoxicity, because it messes up with liver metabolism, right? So it is going to increase the LFTs. It is going to cause myopathy, especially when used with fibrates that we will see. Most important or most unique adverse effect of all these lipid lowering agents is probably myopathy. That you are going to see. Everything, all other adverse effects are very assumable. Now we want to talk about. Okay, now we'll talk about the PCSK9 inhibitors. We're not going in order. So as I said, that VLDL is converted into LDL and free fatty acids. There are two things in blood VLDL is getting converted into. The LDL is going back into the liver through LDL receptors. But the LDL receptor is being inhibited by PCSK9. And PCSK9, if we inhibit through PCSK9 inhibitors, we can decrease the LDL entry into the liver. Okay. We have to increase the entry of LDL into the liver, because we don't want LDL in the blood. If it goes into the LDL, it can get metabolized. Okay, so LDL was going into the liver through LDL receptor, which was inhibited by PCSK9. So we in turn inhibited the PCSK9 by the drugs alirocumab and evolocumab. They decrease the LDL highly, they increase HDL, they decrease triglycerides, and inactivation of LDL receptor degradation. So that will lead to increased removal of LDL from bloodstream, and entry of LDL into the liver is going to increase. That will cause myalgia, delirium, dementia, and other neurocognitive defects. Okay, now we'll see. Now we are going to see PPAR alpha agonists or upregulators, that are fibrates. As we talked about here, that VLDL is getting converted into LDL, and second is free fatty acids. And PPAR alpha activates that conversion of VLDL into free fatty acids. And if we give fibrates, that will in turn activate the PPAR alpha receptors. fibrates activate PPAR alpha. So it upregulates LPL and increased triglyceride clearance. How does it cause increased triglyceride? How is it going to increase the triglyceride clearance? Because as you can see, the triglyceride is triglyceride is converting into VLDL, which is getting converted into free fatty acids. So if we increase this conversion, there is increase in triglyceride coming in from liver into the blood vessel for clearing out in form of VLDL. So we are increasing the triglyceride clearance from liver. And activating PPAR alpha, it will induce HDL synthesis. Okay, so HDL increases, LDL decreases, and it highly reduces triglycerides. And it has the same adverse effects as the statins, which is myopathy. Myopathy with statins was increasing with the use of fibrates. Increased risk with statins. Cholesterol gallstones via inhibition of cholesterol 7 alpha hydroxylase. Okay. And these fibrates are gemfibrocil, bezafibrate, fenofibrate. So fenofibrate and benzafibrate has fibrate as their suffix, but gemfibrocil is the new one. Now we'll see niacin. So niacin is used at two places. Niacin inhibits cholesterol conversion into VLDL. First is here. Niacin is inhibiting the conversion of cholesterol into the VLDL. So what will do is it will reduce VLDL highly. And the second function is it is causing lipolysis. So it will cause free fatty acids accumulation to decrease from adipose tissue and transfer of that free fatty acids from adipose tissue into the blood. It is going to inhibit that. Okay, it is going to inhibit that, so there is reduced free fatty acids in the blood and more free fatty acids in the adipose tissue. So if it is and if it is reducing the VLDL highly, it is going to reduce LDL highly as well. It is going to increase HDL and it is going to decrease the triglycerides. At first, it inhibits lipolysis, so there is less free fatty acids in the blood and more in the adipose tissue, and it reduces hepatic VLDL synthesis by inhibiting conversion of cholesterol into VLDL. Its adverse effects are flushed face, it is prostaglandin mediated, and it can be decreased by NSAIDs or long-term use. Second is hyperglycemia and third is hyperuricemia. Okay, and the last ones are ezetimibe and bile acid resins. First we'll see bile acid resins. These bile acid resins are decreasing the reabsorption of bile from the lumen. So which are the bile acid resins? They are cholestyramine, cholestyramine and cholestyramine. Cholestyramine, cholestyramine and cholestyramine. It reduces LDL, it increases the HDL slightly, and it increases the triglycerides slightly. As we talked about, all of these drug classes decreases the triglycerides, but bile acid resins are the only class that increases the triglycerides slightly. And it prevents intestinal reabsorption of bile acids. Yes, and liver must use cholesterol to make more. Okay, so now if liver has to use more cholesterol to just make bile because bile is not getting reabsorbed, then that cholesterol will be metabolized in the liver and cholesterol levels are going to decrease. and it will cause GI upset, because obviously we are blocking the reabsorption from gastrointestinal tract that is going to upset it, and it reduces the absorption of other drugs and fat soluble vitamins as well along with it. And ezetimibe action is at the same place. It decreases the cholesterol reabsorption. So it if it is reducing the cholesterol absorption altogether, it is going to decrease LDL, it is going to increase HDL, decrease triglycerides, and its adverse effect will be increased LFTs and diarrhea. So you have to keep the adverse effects in mind. Okay, statins adverse effect was hepatotoxicity, because it was messing up with the liver mechanism, liver metabolism. The important one was myopathy, which was when it is used with fibrates or niacin. Then there's GI upset, absorption, decreased absorption of drugs and fat soluble vitamins with bile acid resins, because they are all GI related, because bile acid resins act on GI. And diarrhea too, because it was acting on GI in ezetimibe. And increase in LFT with ezetimibe. Fibrates, obviously it was causing myopathy. And there's cholesterol gallstones, which is also specific to fibrates. And niacin has very vague adverse effects, like it causes flushed face, hyperglycemia, hyperuricemia, and it can cause myopathy when used with statins. PCSK9 inhibitors, they inhibit the LDL receptors, which increases the removal of LDL from bloodstream. Yeah. It causes myalgia, delirium, dementia, all CNS side effects. And there's fish oil and marine omega-3 fatty acids, which increases LDL and HDL both, but decreases triglyceride at higher doses. It is believed to decrease the free fatty acid delivery to liver and decrease activity of triglyceride synthesizing enzymes. It can cause nausea and fish-like taste. Now, cardiac glycosides, which includes digoxin. So, digoxin causes direct inhibition of sodium potassium ATPase, which in turn causes indirect inhibition of sodium calcium exchanger. So, the calcium inside the cells increases and it causes positive ionotropy, and it stimulates vagus nerve, so it causes bradycardia. So if this is the sodium potassium ATPase, digoxin is inhibiting sodium potassium ATPase. Now sodium will not be able to go out and potassium will not be able to come in. If the sodium is not able to go out, the sodium inside the cell is going to increase. And if the sodium is increasing inside the cell, it is going to inhibit this sodium calcium exchanger, because decreased sodium inside the cell was a driving force for calcium to go out of the cell. But now as sodium itself is increasing inside the cell, the calcium will also not go out of the cell, and it will be accumulated in sarcoplasmic reticulum. Its clinical use is in heart failure, because we have to increase contractility in heart failure, in atrial fibrillation, because it slows down conduction at AV node, and there is depression of SA node. Okay, and it also decreases the heart rate. So if it is decreasing the conduction of AV block and depressing the SA node, it can also be considered as an adverse effect if the patient does not have atrial fibrillation. So the adverse effects are cholinergic effects, which includes nausea, vomiting, diarrhea. This is specific blurry yellow vision, arrhythmias. So I said that it can cause decreased conduction at AV nodes and depression of ICA nodes, so it can cause arrhythmias and AV block. It can lead to hyperkalemia because the potassium is not able to come inside the cell now because sodium potassium pump is inhibited. So potassium will increase in the blood, that is hyperkalemia, and it indicates poor prognosis. So factors predisposing to toxicity is renal failure, which will result in decreased excretion of digoxin. Then there's hypokalemia. It is permissive for digoxin binding at potassium binding site on sodium potassium ATPase. So if there's hypokalemia, there will be easy binding of digoxin to sodium potassium ATPase. It will increase the binding of digoxin to sodium potassium ATPase. And drugs that displace digoxin from tissue binding sites and decreased clearance because of verapamil, amiodarone and quinidine, WAC. And its antidote is we have to first normalize the electrolytes, that is potassium. There's hypokalemia, so we have to replace potassium. We have to give cardiac pacer because it causes decreased conduction in AV and AC nodes. And then there's the main treatment, anti-digoxin fab fragments, and we have to also replace magnesium. Now the anti-arrhythmics. I recommend watching sketchy videos for anti-arrhythmics. They are pretty good. And I will just go over the first aid because I myself used sketchy. So I'm just going over the first aid for you guys. And okay, so first there's class 1, class 2, class 3, class 4, and then there's also class 5. But we are just discussing the first 4 classes here. And in class 1 there's 1A, 1B and 1C. Okay. So what class 1 does is it slows or block conduction, especially in depolarized cells. It decreases the slope of phase 0 depolarization. So if you remember the action potential of ventricular myocytes, not the pacemaker cells but ventricular myocytes, it was this 0, 1, 2, 3 and 4. Okay. And the 0 phase was because of the 0 phase is depolarization, and if you remember, only sodium and calcium can come inside the cell and potassium always goes outside the cell. So to cause depolarization in ventricular myocytes, we use sodium, and to cause depolarization in pacemaker potential, we always use calcium, because we have to slow the rate of action potential in the pacemakers, so we have to use slow channels of calcium. The sodium channels are very fast, so they are only used in depolarization of the ventricular myocytes. So here phase 0 is due to sodium inflow. Increased action at faster heart rate. Okay, state dependent increased heart rate, so that will cause shorter diastole, and sodium channels spend less time in resting state. Drug dissociate during this state, and less time for drug to dissociate from receptor. So effects is most pronounced in CAB. So 1C are more potent than 1A, and then 1B is very weak. So it is due to relative binding strength. Okay, binding strength to the sodium channels and its effect. So first we'll see class 1A. If you can see the effect of, if you want to see the effect of class 1 antiarrhythmics, this is the effect. Earlier the graph was here, now only the phase 0 has moved to the righter side, and the phase is 0, 1, 2 and 3. The 2 and 3 phases of the cycle can also get prolonged, and that is the basis of classification of class 1 into class 1A, B and C. All of them does not lead to prolongation of phases 2 and 3. The first is first class 1A includes quinidine, prokinamide and disopyramide. The queen proclaims disose pyramid, Or you can also remember dancing prom queen. I think dancing prom queen is more easy. Dancing is disopyramide, prom is procainamide, and queen is quinidine. So what is the mechanism? It moderates the moderate sodium channel blockade. So we saw C, A and B. So A has moderate blockade, C has most blockade, and B has the least blockade. So in class 1A there is sodium channel blockade, and then there's also some potassium channel blockade. AP is action potential, so it increases the action potential duration and increases the effective refractory period in ventricular action potential. So refractory period is when the ventricle is in resting state, so that is increased effective refractory period in ventricular action potential. It increases the QT interval too. How do you know it increases the QT interval? Because as I said, not all of the class 1 drugs increases the phase 2 and 3, prolongs phase 2 and 3 of the action potential. So now class 1A is prolonging 2 and 3, as you can see. So if this 2 and 3, that is ventricular repolarization, if that is prolonged, the PR interval is also prolonged, and that will cause increased QT interval. If this is P, Q, R, it's T, this is S, this is T, this is Q, R. So this signifies ventricular depolarization, this signifies ventricular repolarization. So now to prolong QT, you have to increase ventricular repolarization too, right? Because this segment, ST segment and T wave, is part of ventricular repolarization. So now if the phase 2 or 3 or the repolarization phase is increased, it will cause increase in QT, that is QT prolongation. So it can also cause torsade de pointes. Its clinical use in atrial and ventricular arrhythmias. So both supraventricular tachycardia and ventricular tachycardia, especially reentrant and ectopic SVT and VT. And now there's adverse effect, that is synchronism, which is headache, tinnitus, and tinnitus with quinidine. And then there's reversible SLE-like syndrome, which is depicted by a Wolff in sketchy. And SLE-like syndrome is more prominent with procainamide, and heart failure with disopyramide. Then there's thrombocytopenia, which is broken plates in sketchy. Torsade de pointes, which is like a hanger depicted in sketchy, and torsade de pointes is caused by increased QT interval. Heart failure is depicted by a dart in the balloon, a heart-shaped balloon. So that it depicts heart failure. And it can also cause. It is also used in Wolff-Parkinson-White syndrome. Now class 1B. So class 1B is the weakest sodium channel blockade. Okay, yeah, one more thing. I told you that class 1A blocks sodium channel as well as potassium channel. So because it is blocking potassium channels, this repolarization is due to those potassium channels, right? This potassium channel is causing the repolarization. efflux of potassium is causing the repolarization. So as class 1 is inhibiting both sodium and potassium, it is going to inhibit the prolong the repolarization as well, causing QT prolongation. In 1B there is just sodium channel blockade, there is no potassium channel blockade. So it's the same as 1B, that it will decrease the action potential duration. No, in class 1A there was increase in action potential duration, everything was prolonging, but in class 1B there is decrease in action potential duration. And then there's weak sodium channel blockade. So it preferentially affects the ischemic or depolarized Purkinje or ventricular tissue. So it is the clinical uses are ventricular arrhythmias, especially post MI, and digitalis induced arrhythmias. And this is a good mnemonic that IB 1B is best post MI. Okay, and it includes lidocaine, phenytoin, and mexiletine. So in sketchy, there's this quote that you lied. The prom queen is telling the prom king that you lied to me and you are dead to me. So you lied is lidocaine and you are dead to me. It is because it is used in post MI. MI is fatal, right? So that is why you are dead to me. And then there's Mexican flag in the sketchy images, which indicates mexiletine. And then there's phenytoin too. And the adverse effects are CNS stimulation or depression and cardiovascular depression. So there's again a heart-shaped balloon that is being darted on, so that indicates cardiovascular failure or cardiovascular depression. Yeah, class 1B is just used in ventricular arrhythmias. Class 1A was used in supraventricular as well as ventricular arrhythmias. And then it is shortening the action potential duration. See, there is slowing of phase 0 of depolarization. So here is the slowing, but then it speeds up, so it decreases the action potential. So there is no prolongation, there is definitely no prolongation, so there is definitely no QT prolongation. Now it's class 1C, which includes flecainide and propafenone. Propafenone is depicted by the purple theme of the 1C sketch, and flecainide is depicted by flakes that is being eaten by the prom king. And the mechanism is, it is the strongest sodium channel blockade. Significantly prolongs refractory period in AV node and accessory bypass tracts. There is no effect on refractory period in Purkinje or ventricular tissue. Okay. And then there's minimal effect on action potential duration. So it slows the phase 0 of sodium channels. So it is the strongest sodium channel blockers. So there will be the most prolongation in phase 0, but then there is no inhibition of repolarization. It is just inhibiting sodium channels. It is not inhibiting potassium channels. No potassium channel blockade. And if there is no potassium channel blockade, there is no prolongation of repolarization. So it's just inhibiting the or prolonging the depolarization phase, and its clinical use in supraventricular tachycardia, including atrial fibrillation, only as a last resort in refractory VT. And it can be it can be used in both ventricle as well as supraventricular arrhythmias, but it is mostly used in refractory ventricular tachycardia. It can be used in atrial fibrillation as well. The 1A class was also used in atrial and ventricular both arrhythmias. 1B was just used in ventricular arrhythmias, and 1C is again used both in atrial as well as ventricular arrhythmias. And the adverse effects are: it is a pro-arrhythmic. It can cause arrhythmias, especially post-MI. They are contraindicated. 1C is contraindicated in structural and ischemic heart disease, and 1B is best in ischemic heart disease. Okay, so let's summarize. 1A, 1B, and 1C. It blocks sodium as well as potassium. It blocks sodium, but it is weak. It blocks sodium, but it is strong. Used in supraventricular tachycardia as well as ventricular tachycardia, only in ventricular tachycardia, and in both SVT and VT. And as 1A is blocking potassium as well, it will cause prolongation of phase 2 and 3 as well, which will cause QT prolongation. Then in here it only blocks sodium but also decreases the action potential duration. Okay. And in 1C just sodium blockade, so there is no QT prolongation. Now class 2. So class 2 is beta blockers. All these metoprolol, propanolol, esmolol, timolol, and carvedilol. So as we saw here in that chart, that beta blockers, beta blockers act here on the beta receptors through GS pathway, and it will inhibit the adenylate cyclase, which will inhibit the CAMP. So it decreases CAMP, but as we discussed earlier, CAMP causes contraction in cardiac muscles, and it causes relaxation in the smooth muscles. Okay. So CAMP was causing contractions in the heart, but now beta blockers through beta receptors through QS pathway will decrease the CAMP, which will cause inhibition of contraction. So it will decrease the SA and AV nodal activity. It will suppress abnormal pacemakers by decrease in the slope of phase 4. And it is decreasing SA and AV nodal activity, okay, not the ventricular myocyte activity. So SA and AV nodal activity was depicted by the pacemaker action potential graph. Okay, so it was this one. This we saw is ventricular myocyte action potential, and this is the pacemaker action potential, which has phases like 4, 0, and 3. Here 0 is depolarization, 3 is repolarization, and 4 is the resting state. AV node particularly sensitive. AV node is particularly sensitive, which will increase the PR interval. And esmolol is very short acting. So what beta blockers does is it prolongs the phase 4. So if this is the normal action potential, it will prolong the phase 4. So the SA and AV node will be in resting state for a longer time before having depolarization again. And it is very sensitive at the AV node, that is why it will cause prolonged repolarization at AV node as well. And its clinical use in supraventricular tachycardia and for ventricular rate control and for atrial inhibition and atrial flutter. So in atrial fibrillation and atrial flutter, we have to do two things: the rate control and rhythm control. So the rate control is done by the beta blockers, and it is also used in supraventricular tachycardia. The adverse effects is can lead to impotence, exacerbation of COPD and asthma because of bronchoconstriction, and there's cardiovascular effects. So you have to use cardioselective beta blockers. Okay. Then there's cardiovascular effects, which is bradycardia, AV block, heart failure. There's CNS effects, that is sedation and sleep alterations, and it may mask the signs of hypoglycemia. We talked about this in the hypertension treatment. So signs of hypoglycemia, tachycardia, tremors, sweating. So beta blockers will block the tachycardia and the tremors, but it will not be able to inhibit the sweating. And then there's metoprolol, can cause dyslipidemia, and propranolol can exacerbate vasospasm and vasospastic angina. And beta blockers, except the non-selective alpha and beta antagonist carvedilol and labetalol, causes unopposed alpha-1 agonism if given alone for pheochromocytoma or for cocaine toxicity. So beta blockers should not be given alone in the pheochromocytoma or cocaine toxicity, because there's alpha-1 agonism which will cause vasoconstriction, which will further increase the BP, which is not good in pheochromocytoma. And in cocaine, there's already vasospasm, so we should not be causing more vasoconstriction through beta blockers. So in pheochromocytoma, phenoxybenzamine is given, which is an alpha blocker as well. So the beta blockers is causing alpha-1 agonism, but phenoxybenzamine will inhibit the alpha-1 receptors. And we have to treat the beta blocker overdose with saline, atropine and glucagon. So you have to remember these two specific side effects, that metoprolol causes dyslipidemia and propranolol will exacerbate vasospasm and vasospastic angina. Other side effects you already know, that it can exacerbate COPD, asthma, it can mask hypoglycemia, it slows down the heart rate, it slows down the contractility, so it will cause bradycardia, AV block, heart failure, all that. You know all that. Now class 3. So class 3 is a very good mnemonic of AIDS: amiodarone, ibutylite, dofetilide and sotalol. See, both of these are peptides. And sotalol may sound like it's a beta blocker, but it's not. It is a class 3 anti-arrhythmics. And the mechanism of class 3 is it increases the action potential duration, like class 1A drug, but the trick here is, or the catch here is, it only blocks the potassium channels. In class 1A, it used to block sodium as well as potassium, slowing the action potential and also slowing the depolarization. But class 3 blocks only the potassium channels, therefore it slows down the repolarization, therefore slowing the phase 2 and 3. And if the phase 2 and 3 is prolonged, you know what side effect is going to be there. There's going to be QT prolongation. Okay, so increased AP duration, increased ERP, and increased QT interval. So it is used in, if there is prolongation of action potential, it can be used in SA and AV node action potential, right? Sorry, this is ventricular myocyte action potential, not pacemaker action potential. So it will be used in atrial fibrillation, atrial flutter, and ventricular tachycardia. So both SVT and VT, just like class 1A, it is used in both SVT as well as VT. If you want to see, in class 1A also there's SVT and VT, there's prolongation of phase 2 and 3. It's such that here sodium channel isn't blocked in class 3. So sotalol will cause torsade de pointes because there's QT prolongation and excessive beta blockade. Ibutilide will cause torsade de pointes. Amiodarone has a list of adverse effects, which is shown very good in sketchy. So it will cause pulmonary fibrosis. Then there's hepatotoxicity, and due to that hepatotoxicity, there's hepatitis, drug-induced hepatitis. There can be hypothyroidism and hyperthyroidism. So we perform LFT on the patients before starting them on amiodarone, and we also do LFT on follow-ups. Sorry, not LFT, but thyroid function tests, TFTs. And because amiodarone is 40% iodine by weight, it impairs the thyroid function. It can act as heptin. So heptin is something that can that can collect the deposits or attract the deposits with it. So it will cause corneal deposits. It will cause blue-gray skin deposits resulting in photodermatitis. It can cause neurological effects, constipation, cardiovascular effects. Cardiovascular effects include bradycardia, heart block, and heart failure. And then there's also cytochrome P450 inhibition. So that will alter with mechanisms of other drugs as well. And this lung fibrosis, pulmonary fibrosis, can lead to restrictive lung disease. And neurological side effects includes the tremors, ataxia, peripheral neuropathy, and sleep disturbances. Peripheral neuropathy is an important one. There's ataxia, tremors. Remember to check PFT, LFT, and TFTs when using amiodarone. And amiodarone is lipophilic and has class 1, 2, and class 1, 2, 3, and 4 effects. Okay. So it is said that amiodarone has properties of all the classes of anti-arrhythmics. So now we'll see why that is. Here we have to remember that it blocks sodium, it blocks the potassium channels, because that is easier to remember, that it is prolonging the phase 2, 3, and it is also prolonging QT interval. But in real, it does block potassium channels, but it also blocks sodium channels. So that is property of the class 1 drug. It also blocks the inactivated sodium channels, not the activated ones, but it blocks inactivated sodium channels. It also slows heart or something like that. Yeah, it also has beta blocking action, some beta blocking action, so that is class 2, and it also blocks calcium channels, so that is class 4's property. Okay, so it shares properties of all the classes of antiarrhythmics. Now, class 4 is calcium channel blockers, that is non-dihydropyridine calcium channel blockers, which acts on the heart more than the vascular smooth muscle. Dihydropyridines act on the vascular smooth muscles more, and non-dihydropyridines acts on the heart more. It includes diltiazem and verapamil. Its mechanism is decreased conduction velocity, and now you guys have to figure out that if it is blocking the calcium channels, and we want to block the depolarization, right? To set the rhythm right, we have to block depolarization. Now you guys have to tell me that where is calcium used in depolarization? It is used in the pacemaker action potential, right? In ventricular myocytes, the depolarization was caused by sodium influx, but in pacemaker action potential, the depolarization is caused by the calcium influx. So it will cause decreased depolarization in pacemakers potential. Its mechanism is decreased conduction velocity, as it is decreasing the depolarization. So there is slow rise of action potential is 4, 0 and 3, slowing the phase 0, and prolonged repolarization at AV node. Okay. And it increases the ERP, it increases the PR interval, because it is also prolonging the repolarization as well. Prolonged repolarization in beta blockers, there was prolonged repolarization too, but it was but the phase 4, that is depolarization, no sorry, the phase 4, that is resting potential, was prolonging much more than the phase 3. Okay, this phase was prolonging much more than this phase was, so there was no increased QT interval, there was just increased PR interval because of the delayed depolarization. And here there is prolonged repolarization as well, which will cause increased PR interval. In clinical uses, prevention of nodal arrhythmias, that is supraventricular tachycardia, and rate control in atrial fibrillation. It will prevent nodal arrhythmias because it is the pacemaker action potentials, and it is used in rate control along with beta blockers in atrial fibrillation. Its adverse effects are constipation, flushing, edema, cardiovascular effects. It is heart failure, AV block, and sinus node depression. Okay. Done. Let's see the other antiarrhythmics, that is adenosine, very commonly used. It increases the efflux of the potassium out of the cell. So if this is the cell, you are pulling pulling potassium out of the cell as much as you can with adenosine. There will be negative charge or hyperpolarizing the cell, so that will decrease the calcium currents. Decreasing the AV node conduction. If this was the action potential, this is due to potassium efflux, that repolarization is occurring due to potassium efflux, but now you are taking extra potassium out of the cell with the adenosine, so there will be hyperpolarizing of the cell. Okay, this is the hyperpolarizing we did with adenosine. So now again the spike that is caused by calcium L type channels, which is this one, which will be this one, calcium L type channels. It will not be as effective as it was previously, because there's hyperpolarizing occur, so there is lot of negative charge, and to calcium channels cannot overcome that negative charge because the calcium channels are slow, unlike the fast sodium channels. Okay. Sorry. So it will decrease the AV node conduction and the drug of choice in diagnosing or terminating certain forms of SVT. Okay, how it can diagnose SVT, because it is very short acting, 15 seconds for, so the rate will become normal in 15 seconds, so we can diagnose the arrhythmia. The effects are blunted by theophylline and caffeine. Both are adenosine receptor antagonists. Its adverse effects include flushing, hypotension, chest pain, and signs of impending doom or bronchospasm. And magnesium is effective in torsade de pointes and digoxin toxicity. Ivabradine prolongs the slow depolarization, which is phase 4 of action potential. This is the phase 4, which is caused by slow channel sodium currents, that is funny currents, selectively inhibiting funny sodium channels. It prolongs the slow depolarization. So this is slow depolarization, this is fast depolarization, and this is repolarization. It is used in chronic stable angina in patients who cannot take beta blockers. Patient cannot take beta blockers that are asthmatics or heart failure or anything like that. So we give ivabradine, and the adverse effects include luminous phenomena or visual brightness, and hypertension and bradycardia. So now we're done with the cardiology. Let's just summarize the anti-arrhythmics again. Okay. This is class 1. It has class 1A, 1B, 1C. So the class 1A is mainly sodium channel blockers. It is blocking the sodium channels. 1A blocks sodium as well as potassium. So there will be class 1 is acted on just ventricular action potential, not the pacemaker action potential. Class 1A will block sodium and potassium both, so it will cause prolonged depolarization as well as prolonged repolarization, which will cause PR prolongation and QT interval prolongation. It is used in SVT and VT. Okay. Then class 1B, it is just weak sodium channel blockers, and it reduces the action potential duration. Okay, so there is no QT prolongation, and it is just used in ventricular tachycardia after MI. In 1C, there is a strong sodium channel blockade. So the depolarization will be prolonged. And it is used in both. And it is used in both SVT as well as VT. Then there's class 2. Class 1 includes the dancing prom queen, that is disopyramide, procainamide, and quinidine. Class 2 includes beta blockers. Beta blockers decreases CAMP, decreases contractility, decreases heart rate. And beta blockers decreases CAMP in the SA and AV nodes. So if this is the normal action potential of pacemakers. What beta blockers was doing is it prolongs the phase 4. Okay, so the phase 4 is prolonged. Beta blockers is used in SVT and atrial fib and atrial flutters. Rate control is not used in ventricular tachycardias. And it has numerous side effects like that of metoprolol can cause dyslipidemia and propranolol was causing exacerbation in vasospastic angina. Class 3 has AIDS, amiodarone, ibutilide, dofetilide, sotalol. These are tilides, and it blocks potassium channels, and it affects the ventricular potential. So if this is normal ventricular action potential, it prolongs the repolarization. That will cause QT interval prolongation as well and PR interval prolongation as well. It increases the AP duration, action potential durations as well. It is used in both SVT and VT. It is kind of like class 1A group, class 1A drugs, and it is used in AFib, A flutter as well for rate control. Okay, it had numerous side effects like pulmonary fibrosis, hepatotoxicity, hepatitis. Then there's blue-gray skin deposits, corneal deposits, pulmonary fibrosis, hypo and hyperthyroidism, cardiovascular effects, neurological defects, photodermatitis, all those. And class 4, and it has also effects of class 1, that is sodium channel blockade, of class 2, that is beta blocking effect, and class 4, that is calcium blocking effect. Beta blocking cause phase 4 inhibition in action potential. Class 4 includes non-dihydropyridine, calcium channel blockers, diltiazem and verapamil. So it will slow the action potential of pacemakers. It will slow depolarization as well as repolarization. So if this was beta blockers, this is calcium channel blockers. So it prolongs depolarization as well as repolarization. So phase 0 and phase 3. Beta blockers was just prolonging phase 4. And it is used in supraventricular tachycardias in rate control of AFib, just like beta blockers. It is not used in ventricular arrhythmias. It's just used in supraventricular tachycardias. Okay. And adenosine increases the potassium efflux out of the cell, so it will cause hyperpolarization, and it will not be compensated by increased calcium influx because calcium channels are very slow. It cannot depolarize the cell now enough, so it decreases the AV nodal conduction in total. Okay, so that is used in diagnosing and terminating supraventricular tachycardias. Okay, and ivabradine inhibits this slow depolarization phase, that is phase 4. It inhibits the funny currents, this slow sodium channels. Normally sodium channels are very fast, but in action potential of pacemakers and in the slow depolarization phase, that is phase 4, the sodium channel, the funny currents are very slow, unlike the sodium channels in ventricular myocytes that are very fast. Okay, yeah, now we are done with cardiology.